This is George Bredenberg on behalf of the Davos Alzheimer Collaborative, Susan Dixon, the president of EBC, Andy Keller on behalf of Meadows Institute. And we are waiting for the man of the Brain Capital Alliance who is coming in a minute, Harris Air. George, I'd like to start with you with a brief words of introduction about what is the Davos Alzheimer's Collaborative and what does it mean for you to be here today and having agreed to be a co-convener together with EBC and the other partners within the coalition.
Well, thank you very much, Frederick, and thanks for your leadership on this and the European Brain Council's driving force behind this conference. It's been terrific. And I'm very proud to be partnered with European Brain Council, Meadows Mental Health, and the Brain Capital Alliance. Davos Alzheimer's Collaborative, founded in 2020, is a global health mechanism, much in the line and familial line of Gavi and CEPI and the Global Fund, intended to address Alzheimer's disease, a global health crisis of unimaginable proportions with over 50 million families today. But as we have looked at this, and we do both research and we do clinical trials and we do health system strengthening, we have found that in fact all the factors that lead to Alzheimer's in later life start at birth, so that we have increasingly found it important to deal with resilience factors and potential predictors of disease very early in life. So we have now very much taken on board this notion of a life course perspective around this disease. The other thing we have learned is that in fact we need a whole of society approach to the solutions of brain health and brain resilience. It is not enough just to talk to the scientists, not just enough to talk to governments, but in fact we need to bring in business and other sectors of society with whom we deal with all of our lives in terms of what drives us and motivates us positively in life, as well as all the stressors and other characteristics which can detract from our brain health. So we're very proud to announce two things today. First is a global brain campaign with EBC, with Meadows, with the Brain Capital Alliance, and all of you, hopefully, to bring to the fore, to the top of the global health agenda and the global economic agenda, the power of the brain and the challenges of maintaining brain health through a life course. As I learned this morning, it's not just our life course. We were born with the same brains we die with, but through epigenetic changes, indeed, there are future generations who are dependent on our ability to maintain our brain health and not cause epigenetic changes that will last through several generations beyond us. So we have a responsibility to ourselves, to our economies, to reducing brain disorders, but also to our future generations. So the other announcement is the Business Collaborative on Brain Health of Us Against Alzheimer's is today announcing a brain scorecard for employers to be able to measure the brain health of their employee base and to understand how the brain health of their employees and of their company can add to their competitive and financial performance. So this is turning out to be not just sort of a normal convening, but now a convening, Fred, that is in fact causing people to make announcements at this. So thank you very much for your leadership.
And thank you, George, because you've been teasing in the perfect way for the panel of Us Against Alzheimer's, but it's important to leave a little bit of mystery for it. Suzanne, I'd like to invite you next to maybe provide EBC's perspective as to why we travel all the way to New York now on a yearly basis to work with these organizations and organize a meeting like today and tomorrow.
Yes, you hear me okay? Yeah, thanks, Fred. I just want to also extend a very warm welcome to this event. It's so fantastic, so many you have made it here, and thank you to those people who are joining us online. Thanks to our collaborators who have really helped Fred and Steph with the organization and this meeting. It's been really fantastic adventure for us. Yeah, so of course we're here for this super important reason. global priority. We need urgent actions in order to reduce the healthcare and societal burden of brain disorders. Maybe just tell you a little bit about the European Brain Council. So we're an organisation that's devoted to policy and advocacy activities in brain research and brain health, with a goal to improve the lives of those, of course, living with brain disorders. We're essentially an umbrella organisation comprising members representing the scientific, patient, professional communities, also industry partners, national brain councils. We represent essentially the European brain community, bringing people, all these groups, to the same table, speaking with one voice and in a consensual manner to raise awareness and also have impact on policy. On that note, what's exciting really for us is that there's much activity underway in Europe really to put brain health at the top of European, including national agendas. There's a lot of appetite and momentum for this going on currently. And we'll no doubt be sharing that with you during the day. We're, for example, lead partners in the European Brain Health Partnership. You can find out all about that on our web, I'm sure, and it's accompanying strategic and innovation agenda. And that really paves the way for increased attention for the brain, not only at the European level, but also at the global level. I mean, this is a really important step because it gives us a mandate and a step towards contributing at a global level for brain health and brain research. It's led to EBC's strong leadership in securing that the brain is on the UN agenda in the last few years, and joining our partners here on stage in the Formation Coalition that's working towards global brain campaign. So I wish you a great meeting. It's fantastic to be here. Looking forward to all the discussions, and a super warm welcome. Thank you.
Thank you, Suzanne. Actually, Andy, I've just been told that our time was slightly reduced, but I'm eager to hear from you what Meadows is actually looking forward to in this global brain collaboration.
Awesome. I thought you were going to let me not have to talk, because I could just...
Well, I wouldn't dare to take the risk.
Yeah.
Not with you.
Yeah. Well, first of all, I just want to, I guess, add my thanks and also congratulate you, Fred. You know, you talked earlier about folks who came across the oceans and jet lag, but I think what's particularly impressive to me is you got someone from Texas to come to New York, and if you know anything about like the politics of the United States right now, like that's kind of impressive. I was actually on a panel yesterday at the Texas Senate, you know, which is run by Lieutenant Governor Dan Patrick, and today we're going to have Governor Hochul here. So I mean, like, that's amazing, like, to be able to do with those two folks. So thank you for bringing us all together. And I think that's really what the point is. So the Meadows Mental Health Policy Institute, we've been around since 2013, and we started in Texas, but we realized pretty quickly that the poor structure, the misdesigned structure of mental health systems in the United States, and really globally, we couldn't just fix from Texas. So we needed to have partners, and we needed to like look at national as well as international partners on that. So that's what we're about. We really focus at the Institute on about 2/3 of what we do is working in the ecosystem of mental health with investors, health systems, insurers, consumers, patients, researchers, to say, how do we make things better? And then when we find out we can't make things better because there's a structural barrier or a regulatory barrier or a financing barrier, going to decision makers in the policy world to get those things changed. And then just 10 short years, we've seen hundreds of changes in laws and billions of dollars in new funding, even in places like Texas, in Florida, and as well as places like California or New York, where we might expect such funding. Anyway, it's very exciting to be part of that. And I just want to maybe mention 2 data points that we're excited about with this conference and with this whole coalition and alliance that is really being elevated and catapulted through our work together. One of the data points is one we talked about last night, and that is that mental illnesses right now, which are pediatric illnesses, okay, 75% of them begin before your brain is done developing in your mid-20s, are treated on average 8 to 10 years after your illness begins. And yet yesterday, I was sitting on a panel with a policymaker who said, you know, we really shouldn't intervene early because we need to save our workforce for the truly ill people. And y'all, that is such a wrong approach, but it is the approach that is baked into our mental health system in the United States. We do not serve people until there's a crisis and until we muster the energy in our communities and our families to go through all the barriers to get to care, and that has to change. The second, and so you're only going to change, you're not going to change that by incremental investment or investing more in what's happening. You have to change the structure of what's happening. Second data point is the one that my friend George just mentioned, which is we die with the same brain we're born with. And so by treating mental illness more effectively in childhood and adolescence and early adulthood, we're going to change the trajectory so that when we are my age and 10 years older than me, we're going to have different outcomes around degenerative diseases and thriving as older adults. So it's exciting to have the group you brought together, and I just congratulate you, Fred, Suzanne. Thank you so much for convening us.
No, thank you, Andy. And actually, as Europeans, we take pride since 250 years to help you coalesce together in America to fight a common enemy. So,
Really appreciate that.
No, really.
Thank you.
Had to break
Older
away.
brother.
Harris, on to you.
Well, so great to see everybody, friends and new friends alike. I'm sorry I was late. My joke is that Fred came in from Brussels and he didn't get me any chocolates, so I thought I'd make him sweat.
You're speaking too fast. You're speaking too fast.
So I only have 1 minute. I just want to say that yesterday we did the Brain Economy Summit. Many of you were there. We had wonderful participation talking about the role of neuroscience in society. It was a great warm-up for today. Thanks to the BBC for supporting yesterday as well. What we really announced yesterday is this new project. We are embarking upon a very ambitious new economic transformation called the Brain Economy Transformation. And this is this recognition that the current economy that we live in is associated with a $2.2 trillion cost of mental neurological conditions. That's across the lifespan from autism in kids, depression in adults, Alzheimer's disease. The $2.2 trillion cost globally is rising at about 5% a year. The Institute for Health Metrics and Evaluation can tell us more about that data. But we cannot stand this current state. So what are we going to do about it? We think we need a new economic transformation. We need to go from a brain unhealthy position where we are now really as humanity to a brain healthy position. And the methodology that we're using to embark upon this journey is from the clean energy transition, that the current energy mix is too much fossil fuels, oil and gas and coal, which is of course important, but we need to transition to more clean energy in our energy mix, which means solar and wind. And so this is a big shift. We know the clean energy transition we're going through. It's public, private, philanthropic, many different stakeholders. It's workforce, it's science and technology. So looking at that, what are we going to do from the brain unhealthy position to brain healthy? So that's what we unpacked yesterday, and happy to talk more about it.
Your minute, Harris.
Okay.
You disappoint me. You don't deserve your chocolate.
I'm
No,
Australian.
I'm really sorry to give a hard stop to this panel, but I'd like simply to introduce the CEO of our venue, Seema Kumar, who is going to introduce our keynote speaker. So I'd like to invite you to thank our panelists, but also welcome the CEO of Cure, Seema Kumar. Thank you. Can I check? Yeah. No? Okay. Oh, thank you. Thank you. Well, that's fine. That's fine. Okay, it seems Harris will have another point of disagreement and frustration with me. Sorry about that. We have a slight delay, but take it easy. And our keynote and host are going to be there in 1 minute.
Hi, everybody. Good morning. Good morning. I'm Seema Kumar. I'm the CEO of CURE, this beautiful facility innovation campus that you're all gathered here today to discuss important topics. CURE is an innovation campus. Our mission is pretty simple but bold, which is to advance healthcare and find cures, period. And this building is home to 21 different companies that are doing just transformational work, trying to cure diseases, including brain health diseases. And one of the big things also that is housed in this building is the so-called Lab of the Future. Lab of the Future is using AI and machine learning and automation to really accelerate the drug discovery, preclinical discovery and development process. And that is thanks to Governor Hochul, who actually invested $50 million in setting up that facility. And so it is now my real pleasure to welcome Governor Hochul to the stage for her keynote. Governor.
Thank you very much. Good morning, everyone. And yes, it is great to go to a place that houses the Lab of the Future. How cool does that sound? And we're so excited. I'm going to drop by later to actually see some of the work that's being done here. Thank you, Seema. Thank you for the invitation to speak to a group of people that are on the cutting edge of solving some of society's most challenging issues. And as a governor, I'm always trying to find ways that I can contribute to not just the dialogue, but truly to help find solutions that help everyone lead healthier lives. Let's start out with this. Raise your hand if you're a parent. Quite a few. No childless cat ladies here, huh? I digress. But imagine this. One day a stranger knocks on your door, and let's say they represent a car company that you've never heard of before, and they've got this exciting new model. They want your child to try it out. They want your son or daughter to participate in what would be various crash simulations, right? That could actually, one of the risks is that could be recalibrating their brain and change their brain forever. But you're told, don't worry. No, this is the newest model. It's the car of the future. All their friends are already doing it. A lot of social pressure to do this. You get that offer at your door. What do you say? Take a hike. Every parent would say that. Maybe politely, maybe not. You must leave here, because not only would that happen, but it wouldn't take long for government to shut that down. Because the idea of agreeing to inflict irreversible damage to our children's brains is just patently absurd, right? Yet, as a society, we've let smartphones and social media platforms do exactly that, turning our children literally into crash dummies, while we stand by helplessly unable to stop the car from speeding toward a brick wall. That's pretty graphic, but we're talking about how children's brains are being rewired while we are here passively allowing that to happen. And what it does is it steals precious time and attention from our kids while their brains are still developing. Time that was once spent on a playground or making friends, learning social skills, exploring nature, joining teams, is now spent tapping screens all day long, comparing digital profiles, chasing the likes. What are they saying about me? And in-person activities that nurture growth are being supplanted by devices that manipulate and take away our kids' attention. And what I have learned, it really drags them into dark spaces. Smartphone and social media addiction has a stranglehold on our children of today. And I would say, having studied this, and I don't have to be in a lab to do this, I go out and talk to teenagers all the time. It's one of the driving forces behind the mental health epidemic that is plaguing our young people today. And when I took office, having witnessed what happened to members of my own family, I vowed to make a change. But let's start with mental health overall. This was never an issue that politicians embraced. It was sort of left in the shadows, right? Languished, forgotten. Nobody seemed to care. And I knew we needed a sweeping overhaul. And I made a commitment to deliver the resources and the support to elevate, first of all, the conversation around this. But I'm not one for half measures. We're not just going to sit around and talk about it. My mental health agenda, which I unveiled last year, was bold. Started with money. That's when people know you're committed. $1 billion dedicated to mental health. And we started with outpatient services and more psychiatric beds. And if you may not know this, a lot of psychiatric beds were taken offline during the pandemic, converted to COVID beds. But when it came time to put them back online, the CFOs of the hospitals did a quick analysis and figured out that the reimbursements are higher for the COVID beds or the non-psychiatric beds because psychiatric beds are more expensive, right? More expensive, psychiatric nurse, psychiatrist. So they can be more profitable to leave those offline, even though their license said they're required to have a certain number of psychiatric beds. So I caught on to this. I politely asked them to put the beds back. I threatened. I'm fining hospitals now for being out of compliance. And guess what? They're now complying. We now have more hospital beds that are dedicated to psychiatric services. So when someone on the subway or on the street needs our help, they have a place to go, whereas a few years ago, the doors were shut. There was no availability. So we talked about that first. Then we said, when we take people, let's use the subway, for example, we finally convinced them to leave. Where are they going after they have their treatment and their plan? We need more supportive housing units. We expanded our homeless outreach teams, going to people where they are, building the relationships, talking to them, building the trust that is missing, where they finally believe there's someone looking out for their best interests and they'll follow them to get the supportive help they need. We didn't do this alone. We didn't do it impulsively. Each one was guided by conversations that I had, my team had with professionals. What needs to be done to help these individuals? Everyone is suffering, whether it's urban residents, suburban, rural. It was statewide. But one thing that was at the underpinnings of all this, I saw something that was beyond just people homeless or people with challenges that you'd customarily think of. Our kids were now in this category of dealing with mental health problems. Kids, at a time in their lives which should be carefree. So started with investing millions of dollars in suicide prevention efforts, eating disorder care, peer-to-peer programs, making sure that schools have mental health clinics and services embedded in them. Because I know how hard it is when your child needs help to leave your job, and maybe you leave a minimum wage job or you lose your income, take your child out of school, go either near or far, but you're traveling, take them to their appointment, making sure they go every week while they're missing school. It's hard, it doesn't happen. I said, let's get these services in the schools. It makes all the sense in the world. And we're focused on that intensely. But as I started moving beyond talking to the adults, going into classrooms or setting up forums in libraries, having real heart-to-heart conversations, I heard so many shocking stories about this mental health and the state of affairs for our children. I sat with 12, 13, 14, 15-year-olds. A lot of girls, their whole lives ahead of them. Now I know this, because I'm a former teenage girl. It's a tough time no matter what, right? You have identity issues, you have body issues, and acne everywhere, and your hair's all straggly, and there's a lot of things that affect your mental health. But our parents had that, we had that, everybody had that. There was nothing unusual, and you get through that. But now, the number of teenagers reporting depression, anxiety, suicidal thoughts that never went away, I said, what is going on? That so many of them are even telling me they're contemplating taking their own lives. It felt like their lives didn't belong to them anymore. It belonged to the algorithms. They were designed to pull them in and keep them tight, suck them in as long as possible. Why? Because social media companies were monetizing our kids' mental health. And according to the American Psychological Association, teenagers are now spending, on average, 5 hours a day on social media, and we have a Surgeon General who says 3 hours a day is detrimental to their mental health. So what I also listened to was, these are young people still coming out of the pandemic, right? We have a collision course here. The year and a half, 2 years that the kids were isolated, whether they were middle school, high school, college, their norms were turned upside down. They were disconnected from reality. Their existence was looking at a cell phone or an iPad. And those were formative years. So they'll be the first to tell you, they're not over the pandemic. I'm going to guess that all of you are over the pandemic. You don't think about it every day. You don't have this insecurity, but listen to them, their voices. I came home one day and my grandma was taken to the hospital. I never had a chance to say goodbye. She was gone. My grandmother was everything to me. This city in particular, the epicenter of the pandemic, every child knew somebody who lost their lives or a parent who lost a friend. It was devastating. We have moved on. I'm telling you, our kids have not. But at the same time, the rise in addictive algorithms from social media companies targeting our kids, hitting them with information that's based on their preferences. Why? Because they're tracking the kids. They know what their interests are. So it's clever, it's holding them, it's addictive. The statistics are shocking. I'm not going to read all the books that are out there, but the studies are clear of what's happening. But right now we're talking about addictive behavior. It's like cigarettes. They can't put it down. And the parents feel powerless. They see their kid spiraling and they can't keep them out of this toxic abyss. And as the first mom governor in New York, raised a few teenagers, which is why I can handle a lot of other adults. I know how to raise teenagers. It's a skill that comes in handy up the road. It's the worst feeling in the world when you can't help your child when you see them suffering. It just hits you right here, right? You trade places with them. You do anything you could for them. But I have to do something. And last October, I joined our Attorney General, Tish James, and our partners in the legislature and announced legislation that would shield our kids from the predatory feeds and protect their data. Now, we watched what was happening in other states. I'm always wondering what they do in other states. Other states attempted to go this far and were not successful in pushing back the campaign, which is pretty intense, from the social media companies. Now, let me stop here and say this. We are a tech-based economy here in New York, and particularly in the city. We welcome technology companies. I've been at a lot of openings. I've talked to their CEOs. I'm expanding the businesses, giving them more opportunities. We love the fact that we are the #1 tech job destination in America today. It's exciting. But I'm also saying, when we disagree on something, get out of the courtroom. Don't sue me. Come into my conference room and let's solve this together, because I'm going to go on a limb and say a lot of you CEOs of tech companies are parents as well. How do we protect this generation? So this past June, we signed 2 landmark bills into law, first in the nation. The Safer Kids Act prohibits addictive feeds without parental consent. Now, name a parent who's going to say, I want my child to have addictive feeds bombard them all day. I think we're good on that one. We just have to show the parents the approval process. This means that the kids can still go to social media sites. This is not about their rights to do this, but only accounts they've chosen to follow, not this unsolicited bombardment. And it can't be curated by addictive algorithms. Another thing, our kids are exhausted. I have family members who sleep half the day on a weekend because they've been on social media all night. I said, who are they talking to? Isn't anybody sleeping at all? Well, guess what? They're talking to people on the other side of the world, literally. It's fascinating. Our kids are sleep deprived, they're exhausted, they're addicted, and they don't know what to do about it. And now we also have the Child Data Protection Act that bars tech companies from collecting and sharing and selling kids' personal data. It seems like they never should have been able to in the first place, but we had to pass a law to say no more. We moved quickly, decisively, set the bar high for the rest of the states, but also, wouldn't it be better if Congress did the same thing and made it nationwide? That's what should be happening. And so, the Senate passed a set of bills. They're not as far as ours, but let's just start somewhere. And even this week, I think we're breaking some ground here. Instagram announced that they've made some changes when it comes to young people. They've agreed we're going to let them sleep at night. That's good. That's good. Improve their privacy. Should have been there all along, but welcome. And also empowering parents to be able to have an idea of where their kids are going, because there are a lot of predators out there. It is a scary, scary place. I saw a statistic that was chilling, that almost 100% of teenage girls have been solicited, propositioned, or had some sexual contact unsolicited online. Those are our daughters, those are our granddaughters. This is too far. So finally, some of the tech companies are waking up. It's good. We changed what we're saying what they have to do. But I'm saying social media over here, that's one piece of the puzzle. What is the vehicle that allows kids to have their lives dominated by social media? It's not just the platforms that are out there, it is the smartphone itself, always buzzing in our kids' pockets, lighting up on their desk. Even in school, we don't allow kids to drink alcohol in school. We don't allow them to vape. We don't allow them to smoke cigarettes. We don't allow them to play video games, right? But they're allowed to have their cell phone with them all day in school. I mean, adults have a hard time putting on their phones, but we have a teacher in front of a classroom whose sole purpose is to make a connection with that child, look them in the eye, try to impart knowledge, build trust. Talk to a teacher who is so frustrated, standing in front of the classroom and being ignored. They're frustrated beyond belief. And these young brains are so susceptible to this addictive and the nonstop stimuli. It's like dopamine. So even a child who breaks out of this, sits in a cafeteria, lunchtime, tries to talk to somebody next to them, oh, they'll be ostracized forever. What do you mean you're trying to talk to me? Everybody's communicating through this. So how does it make a kid feel? They're not going to do it any longer. Smartphones have connected children with people all over the world, but disconnected them from the people in their immediate immediacy around them. It's disconnected them from the people in the room. And so this has lasting consequences. Young brains cannot develop in a virtual world the way they would have if they were left carefree. And managing risk and conflict and social interaction and collaboration and the creative collisions that we want them to be able to do when they're adults. Imagine kids are silent in classrooms, silent in the hallway, silent in gym, silent in the cafeterias, silent after school, because they're all communicating online now with each other. But when they get out of school, we want them to come to a workplace, collaborate, work with others, look each other in the eye, act like a real social being. How do they make that leap if they don't start when they're kids? It's not happening. So we're also hindering the workforce of tomorrow that our employers are looking for. People come to New York because we're creative here. But that creativity isn't happening alone in someone's basement. It's what you're doing with other human beings, other people. And they don't get the joy and camaraderie of working on something together. So we don't teach a kid about friendship by showing them 100 online videos about how to make friends. You take them to a playground, right? Put them with other kids. Put them on a soccer team. You don't learn to play baseball on YouTube. Go out on a team. We need to get them back into real life. And so the shift from a play-based childhood that we grew up with to a phone-based childhood is robbing children of those experiences. It's stealing the spontaneity and the wonder that makes childhood so special. And in school, one drama teacher told me, the kids aren't even trying to try out for chorus or if we're acting because someone is videoing it, we're going to post it online and mock them out. And that is the worst thing for these young kids. They'll just retreat and say, I'm not even trying. One girl says, she goes, I said, why are you on it all? I'm sitting there, the governor's doing a form with you, and you still are looking at your cell phone. And she says, well, I get mocked out a lot. I need to know what they're saying about me. They mock up my clothes, my hair, this. I'm getting mocked out, and I need to know. I need to know if they're meeting in the girls' lavatory and I'm not invited. I need to know what they're going to be doing after. I need to know. It was pathetic to see this child. So, what are we gonna do about it? When a child says to me at a forum, you have to save us from ourselves, that we have to be the ones, the adult, who stop this in a classroom because we can't be the ones, we'll be scorned forever. I'm paying attention to that. I cannot tune out the needs of a child crying for help, and nor should anyone in our state. So here's what I'm going to be focusing on. Speaking Friday morning at a statewide conference in Albany, sponsored by the New York State Teachers Association. They're leading the charge. 72% of teachers surveyed across America are saying we are frustrated because we're not able to break through to our kids. So teachers are on board with this, saying there cannot be unlimited cell phones in a classroom. I don't think they should be in school at all. And I'll tell you this, my first thought as a mother whose kids were in middle school when Columbine occurred, the mass shooting in a school that shook us to our core. My thought was we need to be connected with our kids all day, right? You need to be able, if something happens, they got to be able to text you, I love you, right? I talked to enough people in law enforcement who said that is the absolute last thing you want your kid to be doing if there is a crisis on campus of any kind. They need to be following the adult in the classroom who'll get them to safety, not creating videos, not texting their friends, not reaching out to anybody. It's not safe for them. And I think the more parents who hear that message, it'll help them realize that just as they and their parents and grandparents got through school without constant communication with their parents throughout the day, which allows them to be more independent, more thinking independently, not tied so close to home when they should be emerging as self-sufficient individuals and ultimately adults, we have to convince them that this is the right way to go. Jonathan Haidt wrote an extraordinary book, said the never-ending stream of interruptions takes a toll on adolescents' ability to think and leaves permanent marks on their rapidly reconfiguring brains. So here's what I'm gonna do. I'm staying in the fight. I don't mind getting knocked around a little bit, it's part of the game, right? But when I see a problem and I see a solution that is not being tackled, I will lead the charge. And I need individuals like yourselves to assist with this, to use your voices, your platforms to support this, because we have to save this generation of kids. That's what's at stake here. And we can stop it now before it goes any further, and their younger siblings will never have to be exposed to this. They will grow up as the carefree adults that maybe their teenage brothers and sisters do not have right now. So we're going cell phone free. Ultimately, we have to find the right path, working with others, what that looks like. But I want to thank all of you for listening to this plea for help through my voice, but it's actually the children of our state who are calling for help. Thank you very much.
Well, thank you for this round of applause, and I think we can definitely say that we have in the room a lot of like-minded organizations and partners sharing the words of Governor Hochul. I'd like to move on now to our next guest speaker. We have the pleasure of having with us Zainab Ijazi on behalf of UNICEF. Zainab, you're the lead for mental health at the UNICEF headquarters, and it's an honor to have you. You have the floor. Over to you.
Thank you so much. Good morning, friends. distinguished speakers, experts, and co-hosts, and good afternoon, good evening to anybody as well joining us online, who might be joining us at a later hour. It's definitely intimidating following the governor, but I will do my best. It's an honor to really be here with you today, exploring the importance of brain health across the life course. And I'm privileged to have the opportunity in this opening session to highlight the critical importance of children, young people, and their families within this dialogue through a global mental health lens. You know, more than 1 in 7 adolescents, over 13% of young people aged 10 to 19, are currently living with a diagnosable mental disorder. Children with mental health problems and cognitive impairments are four times more likely to become victims of violence, and 1 in 4 children lives with a caregiver who has a mental disorder. Let that sink in. Each year, an estimated 45,800 adolescents die by suicide, a number that makes self-harm the leading cause of death among boys aged 10 to 19, and the second leading cause of death among girls aged 15 to 19. This puts a shocking point on the call to action on mental health, because it is absolutely about saving lives. Now, brain health and mental health in childhood is intrinsically linked to the realization of children's rights and the achievement of the Sustainable Development Goals. When mental health challenges go unaddressed, they lead to long-term disability, impaired development, and deep emotional suffering. Conditions like anxiety and depression, but also more common learning, behavioral, and developmental disorders that are often misunderstood, they influence a child's ability to learn, to develop, form relationships, and reach their full potential and contribute to the world. Now, this is compounded by the societal and economic costs, with mental health conditions being one of the leading causes of years lived with disability. Therefore, the burden of mental health morbidity is immense. We often talk about mortality, but we must consider morbidity in this dialogue, because we must highlight the critical need for integrated, preventive, as well as responsive care approaches that address this global burden. Now, addressing this burden means addressing its root causes. Those experiencing violence and adversity are more vulnerable to brain and mental health challenges. And we know that the absence of parental attachment and nurturing caregiving in early childhood and of supportive relationships throughout childhood and adolescence are among the most preventable causes of mental health problems, which means there's a lot that we can prevent, and we must choose to take that forward. Now, this is particularly true for children living in humanitarian crises, low resource settings, or with disabilities. We also see huge gaps when it comes to integrated services and care for children and young people who are engaged in armed conflict and interacting with the juvenile justice system, and for both adolescents and caregivers who are dealing with substance use issues. Earlier this year, UNICEF and UNODC, we hosted a conference at Wilton Park focusing on the impact of adverse, violent, and traumatic experiences on adolescent brain development and behaviors. Tomorrow, we will actually have a panel that will dive deeper into these findings, and I encourage you to participate. But today, I would like to underscore the critical importance of integrating holistic approaches across the continuum of prevention, promotion, and care, and across the life course for addressing the complex and ever-evolving challenges our children and young people face today, as we heard the government mention earlier today. Now, at last year's Global Mental Health Summit in Argentina, the child and adolescent working groups that were co-led by UNICEF and WHO, we highlighted a series of core recommendations to support child and youth mental health from birth through early and middle childhood to adolescence and youth. These recommendations and approaches are guided by a socio-ecological model, which means we're placing the child at the heart and center of multiple circles of support. And we need to be thinking about the supportive networks of people and structures that surround the child, safeguarding their well-being and their sense of agency and supporting their optimal development. So there were 4 main recommendations that came out. First, we must prioritize the development of a multidisciplinary workforce across health, education, social and child protection, the juvenile justice system, and many other areas of work. We need a well-trained and supported workforce to be able to meet the needs of children and their caregivers. But But this also means that we need to be looking at the workforce not in silos, because yes, it's important to build the capacity of workforce at lower levels, but that is not at the exclusion of supporting specialized mental health services and ensuring that we're also investing in skills that are necessary to address the more complex issues. Second, we need to strengthen multi-sectoral policies and legislation for children's mental health. We need to be ensuring that these legislations include determinants for children's mental health. We need to be ensuring that these policies foster safe, inclusive environments in schools and communities. We heard the government today. We need to be working tirelessly to ensure that schools are kinder, gentler places for children so that we can promote the health of their brains and their mental health. Third, we must build networks of community-based mental health services for adolescents. That means meeting children and young people where they are in the community. It means looking to ensure that we're integrating mental health services through primary health care, through schools, through youth centers and other entry points. But we also need to make sure that these services are accessible. We need to make sure that they're designed from the perspective of the young people who need them. And the fourth and final recommendation, we must ensure the meaningful inclusion and leadership of young people, caregivers, and those with lived experience in the development of these mental health policies, these programs, and these services. Now, this last recommendation is crucial. Whenever we talk with young people, mental health emerges as a top priority. Every single time, they talk about three things. They talk about workforce, getting into jobs, they talk about climate, and they talk about mental health. And so for us, we understand that they're no longer, just talking about what their needs are or what their challenges are. They're also proposing solutions. They're pointing us to the entry points for change. They're urging us to create environments that support their mental health. So we must listen, we must learn, and we must equip young people with the tools and platforms to lead the change they want to see. And I hope many of you will be joining us through multiple events during UN General Assembly High Level Week next week, where you will see these young people engaged at the table and engaging with us in these important dialogues. Over the past 18 months, we've seen a growing recognition of mental health significance, from the General Assembly's resolution on mental health to the World Health Assembly resolution on mental health and psychosocial support in emergencies, bringing much attention to protecting and promoting children's mental health in emergency and development contexts. We are also encouraged by the Human Rights Council's recent dialogue on drug use and harm reduction, which provided a critical opportunity to highlight the need for effective harm reduction strategies and policies that protect and promote the physical and mental health of all children. We also look forward to engaging with the mission of Mexico, leading on the forthcoming drug policy resolution to ensure that children and brain health and mental health are well reflected in that final text. Now, as we look ahead, there are multiple events coming up where we have this opportunity to drive action. There is the Qatar Global Mental Health Summit in April and the high-level meeting on NCDs and mental health in September 2025. These are going to be really important moments for us as a community. Because as we all see, the momentum is clear and the time for discussion is over. Now is the time for action, and we heard the panel earlier today, we heard the governor. By acting early, we make the best investment that we can in the mental health and brain health of future generations. I'm really heartened that as a mental health community and brain experts and neuroscience experts in the room, we have come together through this conference to align our interconnected domains within a shared global agenda centered around the mental health and well-being and development of children. Thank you for your generous attention.
Thank you very much, Zainab. And I'll use your words by saying it's no time for action. So thanks for adding that brick on our wall of the introduction for this two-day conference. And I'll ask probably our third keynote speaker, so Werner Obermeier, on behalf of the WHO Office and Representation to the UN, to add an additional contribution in getting us into orbit. Werner, you have the floor.
Good morning, Fred, and to all of you. I have slides. I'm not sure who will be operating them. It's here. This one. I was reminded this morning when I listened to the panel of a saying by Woodrow Wilson, the 28th President of America. And he, at one point in his career, mentioned that he doesn't only use all the brains he possesses, but he also uses all those he can borrow. And I'm mentioning that because this issue around brain health is not something that's only the responsibility of the health sector, although I stand before you as a representative of the World Health Organization. I'm going to speak a little bit about what we have been doing globally. As you see on the screen there, the data that we have available shows that 43% of the world's population experienced nervous system health loss. This translates to 443 million disability-adjusted life years. The treatment gap is staggering. It is really unfathomable that in high-income countries there are 7 neurologists per 100,000 people, but in low-income countries there is only 1 per 1 million people. Only 1 in 10 people in those settings with dementia receive a diagnosis, and only 1 in 4 with epilepsy. So it's very appropriate that 2 years ago, the World Health Assembly, which consists of 194 countries, adopted what is called the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders, which follows the vision of WHO to provide health for everyone everywhere. It also has objectives and targets. You can find those online. It's important to have those benchmarks because only what you can measure is actually what is implemented. The backbone of the IGAP, as we call it, is an integrated approach through health, but other sectors also. It has improved health outcomes for everyone, addressing the social determinants of brain health, because that's where you unlock your advantages. It focuses on improved access to care to make widely accessible to underserved areas, care on prevention and early diagnosis. I need to emphasize this because many of the preventive measures that we can take are overlooked. We need to optimize resource allocation because much of the resources spent, particularly in the public health sector, are wasted and not targeted. And very important, the IGAP also focuses on reducing stigma and discrimination. So what is WHO doing? There are 5 key areas of work, as you see on the screen. I will focus a little bit on one of them, which is dealing with advocacy. Advocacy is obviously very important for increased resource allocation. And you cannot attract resources if you don't have a good investment case. You have to demonstrate what you invest pays dividends. So what we have found is investing in epilepsy interventions generate extremely high returns, a ratio of 1 to 24. And we have also looked at an investment case for meningitis. And if you look at the bottom right-hand corner of the slide, you'll see the calculated socioeconomic benefits reach billions of dollars in saved medical and economic costs and could potentially go up to 100 billion by 2030. As a normative agency, also operating in the field, it's part of our core business to issue technical guidance. So our brain health unit has released several of these products, also all online. I'm not going to mention them. There are toolkits. There are ones that deal specifically with neurological and developmental conditions, with access to medicines, and many recent publications. Many of them are free for use online. An important milestone next year will be what we issue, what is called the Global Status Report on Neurology. It measures the first 3 years of implementation of the IGAP, and it will contain country-level data which can be used comparing progress across regions. The WHO has 150 country offices, and that's really where we do most of our key work. with countries and with partners, with civil society, because most of our offices are based in the health ministries of developing countries, but the practitioners in the field are partners. So in comparison to the work we do on other areas, the work on mental health and brain health, we include healthcare providers, obviously, but also the health and social sectors, and at all times, we include people with lived experience. The partnerships I mentioned are key because you cannot have implementation, advocacy, political leadership without other actors. It has to be more than the public and private sector. We've done many regional and country workshops over the 2-3 years since the IGAP has been implemented. I just want to refer quickly to a forum which we started during the pandemic, which is called the Brain Health and Clinical Exchange Program. It's an online global network. We've been running it for 3 years, and it's been really, really very helpful. So where do we go with the IGAP? As mentioned by many people today, action. There are 3 key areas. You can see action for governments, on policies, on services, on human rights, and on preventing discrimination, eradicating. Then what do civil society do on awareness, on knowledge generation, sharing of best practices? But it should at all times include those people with neurological conditions. They should remain at the center of all we do in implementing the IGAP. Thank you very much for inviting us to speak this morning.
Thank you very much, Werner, and thank you for setting the stage for the panel that is going to follow, because you have mentioned the need for implementation and concrete measures. So did Zainab before you. So we will have now a panel with practical experience as to how these measures are implemented at country level. And I'd like to bring on stage Josefina Cruza, Rajinder Damija, Mika Pico, Christina Adorjan, and Zul Merali. Please. There is no sitting order, so you just pick and choose. Well, it will be turned on. It will be magic, I think. Okay. Yeah. But Josefina, actually, I wanted to start with you. Ladies first, obviously. But you're coming from Chile. You made all the way to come here.
Yes.
And we were very eager to understand how the measures that we just heard from WHO, from UNICEF, actually resonated in a country like Chile. So I'd like to give you the floor first. Oh, wait a second. Actually, apparently, it wasn't on. The magic didn't happen.
Okay, so thank you to the organizers for the possibility of being here. This is a great pleasure. In Chile, neurological diseases are addressed mainly through 3 different strategies. The National Health Plan that aims to improve early diagnosis, treatment, and comprehensive care, aiming to improve patients' quality of life. Also, the second strategy is the explicit guarantee health plan that seeks to prioritize medical attention to patients with neurological diseases over other pathologies. And third, due to the aging population in Chile, we have a national aging and health policy that seeks to promote research on pathologies, on diseases associated to older adults. Also, it promotes awareness campaigns to educate the populations of, for example, Alzheimer's disease, and also puts a lot of efforts in improving the infrastructure of healthcare system. As you may notice, unfortunately, we don't have a proper brain health plan. And the strategies we have in Chile follow more like a traditional approach, focusing on medicalization, disease itself, early detection, treatment, but none of these strategies consider the brain health and brain capital concepts, as they don't consider brain health only as the absence of diseases, and they don't put efforts on improving brain capital, seeking actively to enhance cognitive and non-cognitive abilities such as flexibility, agility, resilience, decision-making, right? Which are, we know, the cognitive resources needed to face the challenges that impose the 21st century. This is from the government side, but luckily we have some private initiatives as the Latin American Brain Health Institute, which I represent, BRAILAT, that is the short for Latin American Brain Health Institute. It's a regional initiative that is dedicated to advance research, multidisciplinary, transdisciplinary, and translational research on brain health and dementia in Latin America, in Chile, but also throughout Latin America. Besides research, we put a lot of efforts on building brain capital, in capacity building, also in science diplomacy, and besides, we also put a lot of efforts in developing new educational programs, such as the newly PhD program in brain health, which we are very proud of it. We are seeking to empower leaders to take action on brain health challenges across Latin America. And we also foster the development of outreach activities to promote awareness on brain health. So besides research, thanks to our collaborative networks, we are partnering with the multinational to REDLAT, which is the multi-partner consortium to expand dementia research in Latin America, and the Latin America and the Caribbean consortium on dementia. And through these initiatives, we are leading very impactful research. And our latest findings have shown that in Latin America, we have specific biomarkers for Alzheimer's disease in our population that doesn't apply to others. We also have shown that brain health in Latin America is very influenced by social and environmental factors, such as education, socioeconomic status, and air pollution. So this is crucial for early detection and treatment. And also it's very important to inform public policies to consider the disparities and heterogeneities and the socio-economic profile of people in Latin America.
Fantastic. So it's basically building a virtuous circle on how to inform policy out of the initiatives that you've been able to undertake. Absolutely. So I wanted to ask you, how does that resonate with your experience in Kenya?
It resonates really well. In Kenya, I think that what's unique and what's happening in Africa as a whole is that we have an interesting phenomenon. We're one of the youngest continents. That means the median age is like 2021. That means half the population is under 20 years old. But if you look at the other side of the equation, is that because the communicable diseases have come under control, there is a significant rise in people that are aging normally. And as a consequence, by 2050, the projections indicate that the largest number of people over 60 years old are going to be in Africa. So here we have a sort of a juxtaposition of challenges and opportunities, in the sense that we have an opportunity to learn about the unique features, expression of mental ill health and neurological conditions, particularly dementia, which is going to be the next sort of a tsunami going to be hitting us. We need to be prepared for this. And here we have an opportunity, and that is, not only can we begin to learn about what are some of the unique features, related to these types of disorders. But on the other hand, we can then flip it around and start intervening early. And I think where the biggest impact is going to be for us is really in the area of prevention and promotion, because by the time the new treatments come, and by the time these treatments become affordable in countries like Africa, I think a decade is going to go by. And we cannot afford to wait, because as Harris was talking about earlier today, I think that the economy is very dependent on this new young generation that is coming up. How do we look after their brains? How do we look after their brain capital? How do we look after the economy of the country and the social determinants of the country? It's all going to be by addressing the young people. So I think that the implementation of the strategy that we're talking about needs to happen very early on. And we have to forget about just focusing on elderly people when we're talking about dementia. We need to go to the younger population. And so that's one of the approaches. And the other that we have kind of been resonating this morning is the across the lifespan approach. And so in Kenya, we're running an institute called the Brain and Mind Institute at the Aga Khan University, where we have developed a model that we're calling the Living Lab. And in this model, it is across the lifespan, and you begin collecting data, not just on particular conditions, but a series of conditions, so not just brain health. We need to collect information about other physical health conditions, such as blood pressure, high blood pressure, diabetes, and other determinants, and also climate change and education. We need to collect a holistic set of data that we can see the interconnectedness of the various factors. And I think that is where there's a lot of advantage to be had. And we're setting up a cohort as we speak of 100,000 individuals that we're going to be following across a lifespan using this Living Lab approach. And we're very excited that I think that we will be generating new data that is going to be quite unique and very powerful in terms of informing how do we really address this challenge that's facing us today. Thank you.
And that's probably one of the greatest achievements in terms of solving or addressing the heterogeneity of brain disorders, which is probably lacking in the composition of cohorts as we currently have them.
Exactly.
So did you have any outcome already or first findings out of this data aggregate?
Yes, so what we have done already is that our approach is really very community-centric in the sense that the community becomes part of our partners, and we develop everything in partnership with the communities. And what we have done is that we have sent in initially a team of anthropologists that have gone in there to understand what is the understanding of the communities of these conditions that we are talking about, be it depression, be it dementia. What do they understand? What are the challenges? What would they like us to address as researchers? And how can we kind of partner with them? And it's been very powerful. And we've learned a lot. For example, first of all, we've learned that the tests that we're using that were developed in North America and Europe are not necessarily the kind of detection tools for dementia and for depression that we typically use. It is because culturally, some things are not relevant. For example, if you tell people, traditionally we ask them to draw a clock face or dementia and show the time. Well, in the regions that we are developing this cohort, they haven't had that opportunity. They haven't even seen a clock face. If they've seen a clock face, it's a digital one, okay, not an analog one. And then, paper and pencil use, for example, if you haven't had opportunity to go to school, you're not proficient with those methods of testing, and already you're at a disadvantage in those tools. So we need to be very contextually specific in how we measure and what we measure, and keeping sure that the domains are consistent, but our tests are much more sensitive in those regions. Thank you.
Thank you, too. Rajinder, being contextually specific in the implementation of the IGAP and other global instruments, how does that resonate in your experience in India?
So thank you very much, Fred, Suzanne, and Harris for having me here. It's really an opportunity to learn and share the experiences, and I'm really glad to be here. I represent my own personal views, although I represent the chair of the National Task Force on Brain Health in Government of India. As you know, India is a very heterogeneous country with 1.4 billion population, world's most populous country as we speak today, and a huge burden of neurological disorders, right from the neurodevelopmental disorders till the dementia and age-related disorders. So it's a very heterogeneous population, each state having a different culture, different language, different faiths, and different kind of an attitude and health behavior. So it's being a complex situation. So the burden of disease, as we have now known, is tremendous. And the recent publication from the Lancet Neurology has a statewide information on various neurological disorders. Why I'm telling is that there's a little difference from the global prevalence of the order of diseases as compared to the Indian subcontinent. For example, in India, the meningitis and epilepsy are higher up as compared to the global order in terms of dementia, stroke, and the things like that. Of course, they are number 4 and 5. Number 1, 2, 3 are the same as in other countries and globally, but number 4 is meningitis or the infections of the nervous system, and number 5 is epilepsy. That is the brain disorders, but coming to the mental disorders, because I am the director of one of the largest neuropsychiatric hospital in Asia, where 3,000 patients come every day in the outpatient clinic. So we have a huge disease burden. And mental health disorders, the rough estimates are more than 10% of individuals having one or the other mental health disorders seeking professional help. But the problem is that there is a huge stigma, there is a huge problem of not coming to the hospital. So our efforts has been to destigmatize and improve the mental health literacy so that people can demand the professional help. There is a huge need, but there is less demand. So that is a mismatch in the general population. So having that attitude change in behavior is very, very important. So people go to the different faith healers and different alternative medicine people, and we are now trying to connect both of these systems, and we are going to the places, mosques and temples where people go for epilepsy. So we are trying to mix them. You treat with the faith, we treat with the medicines. So we are having a joint kind of a, what we call in Hindi, dawa and dua. Dua is a faith or a prayer, and dawa is your medicine. So let us combine together so that they can also have that kind of, because they have a huge clientele. So the customers go there. So we go there and start our own clinic. After consulting them, they come to us, and then we bring to the hospital if required. So that destigmatization and improving the mental health literacy is a very, very important aspect of that. So having said that, 30 million people having one or the other neurological disorder in a huge population itself is a challenge for all of us. So given that scenario and having that thing in mind, and then the signatory to the WHO IGAP declaration, so we have started, the Government of India has now started a National Task Force on Brain Health, which I am the chairperson, and there are number of secretaries from the different government departments or the ministries, from disability to social justice and empowerment, health research, science and technology, biotechnology, NGOs, the patient representatives, and so forth. So that task force has just started in the month of May only, and we have had the stakeholders meetings, and we are looking forward for having more workshops and learning from other nations having the brain health action plan. So having a national task force itself is a very major change in the government's thinking and the policy makers. The policy makers, which is the Planning Commission of India, which is headed by the Honorable Prime Minister of India, is the key nodal agency which has now constituted the national task force. So you can see the right from the top, there is a willpower to start action on the brain health, and that action will be translated into, as we heard in the morning, time to discussion has gone, now the time to action has come. And Honorable Governor Kathy has very clearly stated another problem for the social media and the developing children's brain, and that is a huge problem in India also, and the government has taken a very serious view of this, having that effect of social media on a developing brain and children having that kind of issues, whether the adolescent health and children facing all these issues. I just want to highlight one more very grave issue of having a rising number of suicides in India. So as per the figures, 12 per 100,000 is a very conservative figures, but we see the number of young children or adolescents aspiring to become engineers and doctors committing suicide in one city in Rajasthan, in Kota, where 25 children committed suicide only in 2023. So that is one city, one center where children are exposed to a lot of pressures, peer pressures, and pressure to excel and get into the premier medical schools and the institutes of higher learning. So we have started now wellness clinics in all the institutes of technology and big medical institutes and the institutes of higher learning. So that is again a very welcome step which is being done. And lastly, I just want to we have identified 5 key determinants. One of them is the physical fitness, whether it is the physical activity, having that kind of environment. And second is the cognitive fitness. In addition to the physical fitness, we are also having a major thirst on the cognitive fitness for challenging your brain, advocating and making people aware of the importance of having healthy brains and having healthy connections in the social circles, in the families, in the friends, and at the workplace. So healthy brains and the cognitive fitness with the physical fitness, and providing a safe environment in terms of air pollution, in terms of safe use of radiation, in terms of safe kind of a environment which is brain friendly and brain helpful in the brain development and brain healthy brain. The fourth is of course the accessibility, affordability and availability of the medications, the medicines and the healthcare services for our population. So this will all lead to the preventive, promotive, restorative and curative brain health. That is the aim of this national task force which I am heading, and I hope to learn from all of you how the other countries are planning, and we are now monitoring this the progress of this. And one more thing which we have started in one southern state of India, which is Karnataka, we have started brain health clinics in every district. So it started 3 years ago as a pilot project for 2 districts in Karnataka, which is the state in the southern India, and we have had a very impressive results from 2 districts in terms of the numbers of referrals to the higher institutes or the preventive aspects at the district level. So district brain health initiative has been very successful. It's now under publication, and that has been expanded to whole of the state of Karnataka in 33 districts, and I believe that that model will be replicated to whole of the India. At least the Planning Commission under the Honorable Prime Minister is considering to roll out in 100 model districts. The India has around 750 districts, out of which 100 model districts it will be implemented, and then we will come up with the results hopefully next year in this meeting.
Thank you. Actually, you said something which resonates strongly before getting the Europe on stage and on the map of this reporting. Our president in the introductory panel talked about the developments within the Horizon Europe program and the building of a brain health partnership. And EBC in that context was tasked to foster the collaboration at a global level. And I'm hearing from your 3 contributions that there is definitely a momentum to try and populate that. So that could be a very concrete follow-up to this meeting in order to foster your respective experience. But I'm hearing already a lot of crossover and mutual learnings that could be driven. We are obviously out of our time because of the very interesting contribution of our keynote and the governor this morning, but I'm eager to leave you the opportunity to ask a few questions to our panelists. So be prepared and please consider any questions that you may have. And I would be eager to provide time in order to ensure this interaction. Christina, over to you. Switzerland is probably one of the most recent plans being developed at the European level. Can you tell us a little bit about the experience there and how you came about developing that plan and what were, in your view, the key challenges, but also the main outcomes and benefits?
Yeah, sure. Yeah, first of all, thank you very much for inviting me to this very important and interesting meeting. Yes, as in Switzerland, we have a Swiss Brain Health Plan. 2023, we just published it. Professor Bassetti, who is the head of our medical faculty, he is also the head of our Swiss Brain Health initiative. And yeah, this paper you can find in the internet. As this is an open access paper published in Clinical and Translational Neuroscience. And as this is a plan for the next 10 years, as of from 2023 to 33. So it's, I think, quite interesting to read it. The question is what we describe in this paper, or what we did in the last years. Yeah, as we have 3 stages defined. As the first stage was just to consider and just to see the needs of brain health. Yeah, what is brain health in the Swiss context? Yeah, we have to define this first, and then of course we also just were looking for how is the prevalence of brain health, for example, in Switzerland, or how high are the direct or indirect costs of brain health and brain-related issues in Switzerland. That was the first step. The second step was we just defined 5 strategic objectives. Here you can see them. The first is, yeah, of course, raising awareness about brain health and brain-related issues, because we see that in Switzerland, not only the general population are not involved and informed about the brain health, but also in the field of healthcare workers, for example. There is a big knowledge lack about brain health and brain-related issues. So we need to do many things, especially concerning anti-stigma work and stigmatization work in this regard. The second is, yeah, we would like to educate, and this should be and train in this field, and it should be a transdisciplinary, multidisciplinary approach, as we very much would like to train yeah, interested individuals who just would like to do something in regard of brain health. Here we would like to invite public health workers, healthcare workers, of course, but not only workers from the medical field. I think that's very important. Then the third part was, of course, fostering research activities on brain health determinants, but also for a new diagnostic and of course, therapy methods, and that's what we are working on right now. And we raised also the issue that there are no funding mechanism, enough funding sources for brain health research in Switzerland. And the last 2 objectives were, for example, prevention. And prevention, it was mentioned in the talk before, it is a very important issue, especially in the children and in the young generation. But I think it's also very important to go to resilience. We have to make our children more resilient for the future. So we have to invest here a lot. And the last was, of course, we very much would like to involve also the families, relatives, and other healthcare workers and stakeholders in our work. So that was the second step, and the last step was, or the last step is, of course, the very important step is the implementation. Yeah, and so if we defined all of these objectives and we now know what to do, then we have to implement everything, and we do it right now. This is also a mere stage work, I think. We do it, of course, at a very local level. What we are doing is we very much would like to involve our local practitioners and general practitioners in this work, because these persons are the first contact persons of people affected by brain disorders. Then at the second level, we of course go for specialized department and institutions they are involved in this brain health network. And at the third level, of course, we go also for governmental work. As of next week, we will have a meeting at governmental level in Switzerland just to bring this topic forward. I think it's a quite interesting brain plan. But as I met Professor Bassetti for the first time, then I just told him something is missing for me. And what I told him, I think it would be really interesting not just to think of Switzerland, but to open this plan for other countries. And that's what we are doing now, as this international aspects is for us very important. And as I work since years with African countries together, we very much would like to open this plan and open these approaches for Switzerland, also for other countries. And that we just not talk about this. We have 3 ideas. Yeah. The first is, as I told, the second aim was to go for better education in this field. And indeed, we will open now a clinical advanced study platform. This is an online platform, and we don't want to just open it for people coming from high resource countries or for people coming from Switzerland, but it should be a platform for every countries, and especially we very much would like to support countries from the global south as well. And here we will think about, of course, supports concerning the fundings and the financial opportunities. If you have questions in this regard, then just let me know and we can talk about it. This is the first thing. And the second is, we very much would like to go for research, and therefore we will tomorrow open our first and new Center for Global Mental Health Research, as a collaboration center of the World Psychiatric Association. And our aim is really to support universities and university development in the global south, because we need here more insights also coming from other countries. We need to learn from each other, and I think, and we very much would like to enable and support universities in Africa, for example, to bring them to the level to do high scientific research, high scientific education, and of course also biological research. And that's what we would like to support. I am also associated professor at the Jimma University in Ethiopia. We work together since years, and I think this is the next step, and also in the sense of a sustainable development goal of the UN, to bring universities and brains forward for the countries who are able to stay in the countries and bring the countries forward.
Thank you. Yeah. Thanks a lot for that. And obviously there is quite a lot we can rebound on that, because extending an experience such as in Switzerland for us at a European level is extremely important, as we are working towards an EU coordination plan, which is obviously our upcoming challenge. So entering the EU with Finland, Mika, you have developed in the country a brain capital plan. So can you tell us a little bit more about it, and why haven't gone to that extra mile?
I don't want to tell anything.
You want to go for lunch already? It's a bit early.
Okay, thank you. Thank you for the invitation to this panel and great event. When we started to prepare our national brain health program in the beginning of 2022, we had a few that kind of principles. One was that we wanted to make an impact-based program so that we have a measurable goals in our program. And the other thing was that we wanted to focus on a proactive approach and protective factors. So I asked our experts, we invited about 50 different experts representing different sciences. Of course, they were neurologists, but a lot of people from different sciences and organizations. I asked them not to mention any problem, any brain-based problem, no disorders. We wanted to really take brain health term very seriously and understand brain as an asset, as the starting point for everything important, everything in terms of sustainable development, in sustainable business and everything. So we were working during 22 in 3 different working groups. One looked at brain health from the perspective on children and the youth, and one from the perspective of working age people, and one from the perspective of the elderly. And finally, when we combined the results of those 3 different working groups, we noticed that the conclusions were quite similar. as I mentioned, that there were no wording about disorders, but there were a very similar perspective to brain health and how we can enhance brain health in our society. And the implementation of our program started in the beginning of 2023. And we have one impact goal, the goal what we want to achieve until end of this decade. And we understand that we are not able to achieve that goal at the end of this decade, but that is the starting point. And I have to check how to say that in correct English. What is our impact goal is that we want to create humanly sustainable brain health supportive society. That is our impact goal. And in order to be able to achieve that impact goal, we have 4 different outcome goals. We want to focus on understanding of brain health and brain disorders, awareness raising and that kind of, let's say, training to different professionals that brain health and brain disorders are understood correctly. And then we want to focus brain ergonomy. And we mean about the emotions and that kind of technical things around us in everyday life. And then we want to focus on sleep. And then we want to focus on relationships between people. We are talking about with citizens. And our experts had an idea that focusing on those 4 different factors, we are able to deliver additional value to our society. Because maybe you know that Finland has been quite famous in terms of health promotion and health in policies and economy of well-being, that kind of approaches. But in fact, we have been talking so much about this kind of approaches that we are a little bit tired to do anything in practice. But still we had an idea that by focusing on that kind of factors, new perspectives, we can really deliver additional value our society. And that was our idea when we started the implementation of our program. But now, after 1.5 years, we have noticed that we really have to raise understanding and awareness even more than we thought among politicians. That this is brain health and brain capital is a very crucial question in terms of sustainable development in our society in general. So I think that at the moment we are running this program, but at the same time lobbying is not a very nice term, but we are increasing understanding among politicians how important brain health and that kind of approach is for our society. And we had an idea that this should be in that kind of, let's say, main theme of our political decision making and everything in future. So coming from a very much program-based approach, now we are thinking this is much more, but at the same time we understand that the challenge is huge to get those people to understand the importance of brain health, brain capital, even they somehow understand it already.
But that's a follow-up question I wanted to ask you. I mean, do you see that they are buying into this vision or concept? And what is the extent to which they are asking for more, let's say, tangible measures or tangible outcomes or tangible policies that they can put in place? And this is to share the experience that we had in engaging with the policymakers in Brussels, that sometimes say, okay, look, we've been hearing this type of concepts for 20, 30 years, one after the other. We can buy in, we see the vision, that's perfect. But what do we need to do concretely, and where do we start now? So were you able to develop this kind of value proposition in a very short and a somewhat longer term?
I think that those 4 outcome goals which we have, those are concrete enough to convince and get those politicians and other stakeholders to understand about what we are talking about. Of course, we are talking about more traditional issues from a brain health perspective, like physical activity and healthy nutrition and that kind of things. But you remember that we are not talking about disorders, because we have an idea that those things belong to the healthcare systems, and those people are best to do best possible treatments and diagnostics and everything. But to challenge our politicians, one more thing is that, because in my past I have been working in terms of impact investing, we have an idea that we have to get private capital involved to our processes, and our maybe the biggest dream is that we can use outcomes contracting as a way to implement this program on this idea. That means that the public sector buys results, and there's private capital which make it possible to do different kind of things in order to achieve our goals. So I think that by using this kind of different approaches, including private capital and this kind of possibilities, we can convince our politicians and get them doing this in practice. But you have to remember that at the same time, I'm a naive optimist.
Well, I mean, I think we all are, or part of us is. Actually, I'd like to ask both the optimist and the pessimist within the room to consider a question. I don't know if we can have mics, so I have 1, 2, 3, and 4. So the first who grabs the mic has the floor first, but you will each have the opportunity to ask your question.
Okay, I have the mic so I can go first.
Yeah. Please introduce yourself.
Yes, of course. So my name is Anita Burgos. I'm the Director of Policy at the National Alliance on Mental Illness. And so for those of you who are not familiar, that is the largest mental health advocacy organization in the United States. And so this question was actually inspired by an earlier conversation I was having this morning. But so in the United States, or at least like with my organization, we think a lot about access to care. You know, do people have insurance? Do they have access to the treatment? Can they get to the treatments, et cetera? And so I was just wondering, kind of from your vantage point, what sort of metrics do you all look for success in improving the lives of people and the mental health, brain health of individuals?
Thank you. I suggest we take the 4 questions and then you can respond to it. Yes, please, first.
Hi, I'm Lucia. I am a postgraduate student at University of Cambridge in the United Kingdom. I wanted to ask you a little bit about, and kind of follow up on Frederick's comment. When you define these national plans, what are the quantifiable measures that you look for? I think it's very crucial that you motivate your team, that you have the policymakers on board. Kind of what are the milestones that you aim to achieve within 1 year, within 5 years? Because I think the vision is very enticing for everybody. We all want brain health. We all want, you know, a healthy society, this brain capital at its fullest. But what are the predefined steps that you want to achieve within your national plans? Because when we talk about the burden, we have very quantified measures. We know that it costs 2.2 trillion per year, the neurological disorders. So if you can comment on that and how you actually approach this issue or this question within each of your respective countries.
Okay,
Thank you.
Thank you. So I suggest that we come to the notions of the KPIs that are addressed within the IGAP when addressing that question, but let's move on. And yeah, please go ahead. Yeah,
okay.
It works.
Thank you so much. I mean, it's a lot of information. My name is Abali Erima Mustafa. I'm coming in from Nigeria, and I have a question to Professor Rajendra from India. You made mention of how your institute or center is working with traditional communities, but also with local leaders who are into mental health or brain health in general. I just want to understand if there is like any learning outcome that came out of that. And I'm asking this because there is a correlation, obviously, at some point with social, religious, but also economic kind of, not that so much of similarity between India and Nigeria. I know for a fact that many local communities do have a strategy that they locally use to solve the issue of mental health, but also brain health. But most of the times, these are issues that are attributed to mythical issues, such as in Islam. When you go to Islamic scholars, sometimes you have a mental health issue that requires a psychiatrist's attention, but it will be termed as you are being possessed by a certain spirit. Or if you go into the African culture, we have things like the black magic, the juju, which for many times have been attributed to, you know, people that have psychological issue. So I don't know, maybe when you're collaborating, you know, with these local communities or local institutions to find a niche where you would work together, have you been able to find any learning outcome out of this? I would be curious to hear your feedback on this. Thank you.
Thank you. And whilst the mic is moving, maybe Rajendra, as it is targeted to you, maybe you want to provide a very quick answer to that?
Yeah, sure. Thank you for asking this question. So this is a very common in many of the countries that people have that faith, and if they go to the faith healers, particularly for epilepsy, as well as for the mental health disorders, both. So what we did, we were having this kind of problem. So we tried to reach out the local leaders there. Instead of a confrontation attitude, we tried to make a friendship with them. And we told them that, look, you are getting the patients and we are also there. So we went to have the clinics there only, so that when they come to the mosque or they come to the religious places, we are also there. So what they come to to have their faith is also provided to them, and we also provided the modern medicine treatment, and the local leaders were very much happy to have that kind of a collaboration in the interest of the patient care, that win-win for all of us, for them also. So we are having an outreach clinic in many of these places, not only for the people who come there, but also for the homeless people who don't have any place to go there. So we go there. In India, there is a national mental health program, which is an act of the parliament in 2017, where the right to mental health is a right, basic right. Right to health is not there, but right to mental health is there. And that act is very, very strong, and that act is very, very implementable. And so obviously that act is now in place, and we are all duty bound to provide the care and access with the free medication and accessibility, availability, affordability, and acceptability. All the four things we have to do that. And I think this particular collaboration has been very successful, and we are now collating data, and then outcome would probably be published very soon.
Thank you. So I'll take the fourth question and then answers from the panel. Yeah, it's not on.
Testing.
Yep.
Good morning, good morning, good morning to you. My question has something to do with that. First of all, I posted or shared a picture of my 3-year-old son holding a brain, and I said Alzheimer's prevention starts in infancy. So I'm so glad Andy supported that share. But I'm an educator by trade, and I've worked in nurseries with the young ones. I taught elementary school. I started a nonprofit for 6th through 12th graders to teach them about creative literacy and entrepreneurship. I taught at California State University to help teachers get their master's and bring in the creative arts. And now I do corporate training and write books. And I just got off of the Royal Caribbean ship doing a keynote, and everyone was on the ship was 55 and plus. So I have literally touched the entire pipeline, right? And my question is, I'm a lifelong learner, and I'm not a neuroscientist, I'm not a doctor, but I just love sitting in. And I sat in on the NIH and Kennedy Center meetings, and it's all about music and the mind, right? You have Dr. Charles Lim, Dr. Ani Patel, Nina Kraus, that are looking at how music affects the brain from infancy all the way into adulthood. And I'm over there with them, watching them, and then I'm over here with you, and I'm like, they're not talking to one another. Their research is profound of how dance improves Parkinson's disease and how the brain literally looks different if you have musical training. And so my question to you is, looking at the work or the book that just came out, Music and the Mind and Your Brain on Art, what is America doing, but what are your nations doing to incorporate the arts into every part of the lived experiences and into your strategic plan for brain capital? Thank you.
So, and you're also obviously making an offer to entertain us during the breaks, right? So, fantastic. That's great. Okay, so we have 3 questions: music and the mind, quantifiable measures, and the issue of access. Who wants to start?
So,
yeah?
I'll start with the last question. I think that music is so important. And in Kenya, for example, we work with community organizations. I'm working very closely with an organization called Cheza Cheza, that means dance, dance. And this is a group of individuals that go into marginalized communities and actually create an environment through music where people can express their emotions. The kids who have had trauma and are unable to express their emotions in words can easily do so during dance and during music. So it is amazing how impactful that program is, and we're working closely with that. So just flip around so that we're not that disconnected. We are quite connected, actually, in terms of neuroscience, music, movement, and healing of the brain as a whole. But then let me flip around to the other issue that was raised about access to care.
Very briefly, because I'd like everyone to be.
So in terms of access to care, I think that one of the issues that we face in LMICs, the low and middle income countries, is that the model of care that we've inherited is like a top-down model whereby the disease is addressed using experts. In the developing countries, we don't have all the neurologists and all the psychiatrists we need. And how do you provide access to care? So what we've developed are apps that low-level workers, lady health workers, community workers can go door to door and do the assessments so they know what the mental health need is of the individuals in the families, and then provide low-grade psychotherapy like CBT. And we are finding that it reduces the symptoms by about 70% for depression and anxiety. So it's very encouraging to know that we can actually, even without the top professionals in the countries where we don't have access to that, that we can indeed make a difference. So thank you.
Thank you too. Josefina.
Yes, I wanted to comment on the indicators. I don't know, because in Chile we don't have a proper brain health plan, but I have the experience of working with two big industries that provide services, and they both have like a lot of issues with dealing with people because of mental health issues. And so they both settle a unit of brain health within their companies. And there is like, we inform them to, like with this program to improve that. And what they've been, the data that they've been collecting, it's about the like more monetary outcomes from that. Like people are going more, the absence licenses are decreasing, and the social cohesion within the industry, it's raising. So there's not only like the numbers of cases going down, but also the monetary aspect.
Thank you. Christina? Yes?
So maybe two questions I would like to answer. First of all, music and art. I think is very important for, especially for the psychiatric and mental health field. I think in Switzerland we have a very good tradition concerning of that, as we have many very famous patients who were painters, for example. We have a museum, for example, for psychiatry, and this is open to everyone. Also, you can come and visit this museum, and you can find very important and famous pictures from important painters, for example, who had mental illnesses. And a couple of weeks ago, I just opened a ceremony on that, as people with mental illnesses celebrated their paintings, and people without mental illnesses came there, and we wanted to just spend a day together. So we have this, and also music is implemented in our therapeutic approaches. So that's, but I think really, really important. And the second is, concerning the measurements instrument. It's a very important question, and we are really. That was also our question in the last stakeholder meeting of our Brain Health Initiative, and we are now working on these measurements. As we will develop some questionnaires, for example, to measure the outcomes of our activities. But it's very important, for the future.
Thank you. Mika?
Yeah. Very brief comments, maybe not responses to your questions, but first of all, as I mentioned, we are focusing on those, let's say, positive factors, but we have an idea that focusing to those, we are doing our best in order to prevent preventable problems, which means that those people who has already some disorders, these factors are important and useful for them also, but when we are doing this, we can prevent really preventable problems. That means that those people who really need cure and that kind of care, they have better possibilities to have that in our system. That's our approach. That means that we don't underestimate those people who have some disorders, and I wanted to make clear that even that we are. And then come to the question in terms of measurement, we would like to develop some positive metrics to prove that brain health is improved, like a productivity or something else. And we are really, really interested to cooperate in terms of that, because you know, we are quite melancholic population in Finland, but we would like to find some positive aspects to measure when we are talking about brain health, really. And then what comes to the art, we recognize that the importance of art very, very much. And in terms of our outcome goals, we are doing our best in order to create that kind of dream teams to work for those goals. And I can imagine very well that some art delivers or art productions can be included to that kind of coalition as a tool to achieve our goals.
But you Finns have been fantastic in translating that melancholy into music, so, you know. Well
and
done.
we are the happiest country in the world, but I'm always saying that we are too shy to say that we are not happy.
Rajinder, you're coming back on stage later to talk about access, so I suggest that you concentrate on the other questions. You have 30 seconds as we need to move on.
Just a very brief comment about the outcome measures. We had the pilot project in the state in Karnataka where we have now, we are under publication, the number of referrals from the district brain health unit to the super specialty hospitals have gone up. So that is one measurable effect, that people are being picked up at the early stage so that the adequate intervention can be done timely. Number two, the number of epilepsy patients who were coming to the higher centers, now we have found that they can be managed at the primary level for their follow-up. So they don't have to travel all the 1,000 kilometers to come to Bangalore just to have the medicines or just to have a follow-up visit. That can be managed, and that is being done there. So that is two outcome measures which I wanted to highlight from our district brain health units. The number two, the music, I just briefly tell, the music and brain has been very important combination. And you will be delighted to know that there's departments in the University of Toronto where there's a department of neuromusiology, where I'm the honorary professor of music now. I wear different hats, from professor of neurology to honorary professor of music. So we have done a lot of work in Parkinson's disease, where music has made a big difference in their rehabilitation.
Well, thanks for that, because obviously we can see already an innovative partnership emerging from the discussion here and the interaction, and loads of ideas for future events. So thank you for that. Please join me in thanking our panelists. And obviously, I'm now eager to move on, but I would like this process to be participatory, because either we skip your coffee break or we reduce the length of your lunch break. So as I'm eminently democratic, I'd like a show of hands. Who would like to privilege the coffee break? Okay, and so that means you all maintain the length of the lunch break as it stands. So I'd like you to accept the offer I made in the introduction of this meeting. If you'd like to go, stretch your legs, grab a cup of coffee, please do so, but we would appreciate if it's done in relative discretion. But please do not all leave the room at the same time, because the program is continuing, and I'll be cross with my board member at EBC, Orla Galvin, who is the next speaker on our program. Orla is the Executive Director of the European Federation of Neurological Association. And as we have been talking about patients, there is really something that is there at our heart at EBC, is really to make sure that patients have the voice, and patients can also be leaders of our advocacy work. So Orla, you have the floor for your presentation on patient-led advocacy on behalf of EFNA, but also to explain to us what were your efforts at a global level. And please stay quiet for Orla's presentation and the follow-up of the program. Thank you.
Thank you, Fred, and thank you to the organizers with the EBC team. Yes, I'm a board member of the European Brain Council. Today, I am absolutely delighted, representing patient advocates in the neurology space, to hear again reiterated by the WHO that when it comes to policies and strategies that impact health, that patients are at the center of the discussions and of the dialogue. One of the phrases that this brings to mind, which is over 2 decades old now, is that there is no decision about me without me. Today I'm going to speak to you not about EFNA per se, but a very important role that EFNA has, serving as the secretariat for the One Neurology Partnership. And I do encourage you to look up the One Neurology website, oneneurology.net. The One Neurology Partnership represents a global group of organizations and individuals focused on policy and advocacy actions, very much in line with the strategic objectives of the WHO's IGAP. And we're very fortunate today that, yes, EBC are members of the partnership, but we will also hear from Samir representing the pediatric neurology community a little later on, who's part of the partnership, and from Chris tomorrow representing ADI, from whom we have a significant amount of learnings. It is a little difficult with the noise here, so I'm going to try and maintain the focus and flow of the conversation. What I want to share with you is the power and the influence that patient organizations can have. So yes, the partnership of One Neurology has many patient-focused groups like ourselves, but it also represents researchers, it also represents clinicians as well. We also have the ear of the WHO Brain Health Unit, which is quite significant. And as EFNA, we are members of the NCD Alliance. I would like to draw your attention to one of our many achievements as the One Neurology Partnership. But earlier this year in April, we had a publication in The Lancet, and we've heard our panel discussing today and indeed yesterday around national brain health plans and awareness campaigns. So there is a publication readily available in The Lancet on national plans and awareness campaigns as priorities for achieving brain health. In the same month, we held a very important meeting. We went to Geneva as the One Neurology Partnership. We had 3 representatives of the Brain Health Unit present and 2 representatives of the Non-Communicable Disease Alliance present, together with the partners of the One Neurology Partnership. And much like today, when you have great minds in a room, you get the attention, like today, we had the attention of the Governor of New York. In Geneva, we also had the attention of a number of member states. Today, Tavrat has just caught my eye. He is a brain health advocate. He also serves as the senior policy advisor to EFNA and One Neurology, and he is tasked often with the duties of the One Neurology Secretariat in contacting member states and health attaches. And we are now in a really good position that we can convene and collaborate more with the Brain Health Unit and with the Non-Communicable Disease Alliance. Acknowledging the fact that One Neurology, yes, serves neurology as a whole, we do also acknowledge that in addition to NCDs, we do have representation of communicable diseases, namely meningitis. But for the moment, as we're here, we would like to refer to the fact that a year ago, we successfully advocated for the inclusion of neurology in the Universal Health Coverage Political Declaration. As the One Neurology Partnership moves forward this year, I would invite you to keep an eye on our activities. We are proposing a virtual meeting following the meeting in Geneva, where we discuss progress from across the globe. And I want to draw your attention to two major points that were brought to us by the WHO. So the first was around the toolkit in relation to the IGAP, and we heard about that earlier, and it is available online. But what you may not be aware of is that there is a role for absolutely everybody in implementation of the IGAP, no matter what sector that you work in. And there are 90 resources and tools within that toolkit that you can use and that are at your disposal. We also heard from the Brain Health Unit around the Global Status Report. So this work was ongoing at the time in April, and we will expect to see the outcome of that with best practices launched in December of this year. Throughout the summer then, when we heard from the NCD Alliance, there was consultations on the next report on NCDs ahead of the high-level meeting next year. And the final draft is, well, consultations actually end this month, and final draft is expected between May and August next year. I'd like to draw your attention to the fact that we have the opportunity to act globally when it comes to NCDs with the Global Week of Action in October. Again, we talk about the urgency at the moment, so really the tagline for NCDs is "the time to lead is now," and something that is really important is around sustainable financing for NCDs, and this includes neurology and mental health. And the other component of that is around powering up communities, and that is why we are here today. I am so pleased that the lady at the back asked the question around music, and I actually feel that that spirit around education and supporting neurology through the life course is something that the One Neurology Partnership would benefit from. And I invite you and anyone who may consider themselves passionate about the implementation of, yes, the WHO's IGAP, but also advocating for neurology patients and caregivers, that you might consider becoming a One Neurology ambassador. Professor Rajinder is one of our ambassadors, and we heard from him today. I would also like to draw your attention to a final piece before I will wrap up, in that, much like these meetings here, the One Neurology meetings allow us to have a convening of great minds and influencing projects. I would love to go through the entire meeting report from April. It is available online, so do check that out. But we saw major outputs from the Women's Brain Foundation. So when we think about how do we implement plans, as I mentioned yesterday, you need to build on what's there. So there is a movement around gender equity in women, and we see fantastic global work in the area of Parkinson's disease, in Alzheimer's, in multiple sclerosis, and dementia from the Women's Brain Foundation, formerly the Women's Brain Project. Another major study that I believe is going to be included into the Global Status Report as a best case example is from DREPAC around migraine. And what we learned was, in the briefest amount of time possible, research was conducted in Japan. There were 73,000 participants involved in this project in relation to migraine in relation to one particular tech company. The aim was to increase awareness, decrease stigma, and increase productivity. And one of the findings of that study was that actually by creating awareness, inviting people to discuss migraine, inviting people to seek support for their migraine, actually productivity in the company went up 32-fold. I won't go into all of the detail, but we heard huge conversations around sleep, which we again heard yesterday, and I would just encourage you to check out the website. I'm sorry there was so much noise throughout this presentation, but I'm here, Tadeusz is here. If you are interested in the work that we do and you want to be part of something that is influential, do join One Neurology or have a chat to us. We have a number of podcasts available. We have a huge amount of freely available resources online, and thank you for those who did give me your attention.
Thank you very much, Ola, and you don't need to apologize for others, being so noisy. So just if I can ask everyone to play by the rules of the game, if you want to have a conversation, to probably hijack the other meetings that are being held here in the Cure, but please not ours. I would like now to move on the basis of this introduction, and actually our virtual coffee break was meant to close this set of introductions and maybe start a deep dive panel by panel, and starting with the perspective of neuroscience and how neuroscience is serving society. And I have the great honor to welcome on stage Tarek Samad. So Tarek is the Senior Vice President and Global Head of Research at Lundbeck. Lundbeck is a Copenhagen-based pharma company, and Tarek is going to explain to us what is the interest of Lundbeck being a partner of this event, and what is the personal stake on the matter. So Tarek, please, you have the l'embarras du choix.
Absolutely. Thank you so much. I'm thrilled and happy and honored to be here and contribute to the same agenda that we all have, which is advancing brain health. Wonderful.
So thank you, Tarek, for being here. And first and foremost, thank you for Lundbeck being a supporter of the event. Can you tell us what was, let's say, what prompted this sponsorship and contribution to our program to today's event?
Absolutely, and thanks for the question. This stems from our long-standing interest in brain health. We like to think of ourselves at Lundbeck as a main stakeholder in discovering new therapeutics for brain diseases with unmet need. Maybe one or two words about Lundbeck to start, to thank you for that kind introduction. We are a 100-plus-year-old company that is solely focused on finding solutions and therapeutics for patients with brain diseases. And it is, as far as I can tell, it's a unique model for a pharma company to be solely focused on neuroscience. And we take pride in doing this. And we consider this our cause together with all the stakeholders in this room. So it's humbling to be here and interacting with individuals that have the same goal, which is making a difference and improving brain health.
I understand you have a couple of slides, and
yes.
Here's the remote. Mm-hmm. But before you lead us through the presentation, in our preparation, you were telling me you have a research background, obviously, and you were not, let's say, familiar with the policy environment and the policy work. So obviously today, this is something we would like to be able to address, how neuroscience addresses societal challenges, but also how it informs policy. But what do you think is so specific to neuroscience discovering a company that is specializing into that field specifically?
Absolutely. And yes, you are right. I have to admit, I'm a little bit out of my comfort zone when it comes to policy and legislation.
Friends, don't worry.
As you mentioned, my background is I'm a neuroscientist and neuroimmunologist by training, and spent most of my career in research and development, finding new drugs. And I realized that the interplay with so many factors in the ecosystem is crucial. So we contribute to one piece of the puzzle, but it's imperative for the other pieces to fall in place to be able to accomplish our mission. So we are bound to work together. And every day I learn about a new contribution to the ecosystem that I wasn't aware of, equally, if not sometimes more important than my own. So that's more or less the rationale why I'm here. And I can tell you a little bit why I joined Lundbeck as well. Back when I joined Lundbeck from Boston. I spent over 20 years in Boston in drug discovery, biotech, pharma. But as a neuroscientist by training, Lundbeck is the place to be for neurology and finding solutions for brain diseases. So the sole focus and commitment, long-standing commitment in this. So those are all factors that made me join the fight to find new cures and join Lundbeck in the process.
Okay, so you have a few slides to share with us?
Yes.
Up to you to stay seated or take the lantern. I mean,
either way, I think it's probably easier if I stand up. Is that fine with you? So let me just maybe take a step back and highlight a little bit the role that innovation plays in advancing neuroscience, drug discovery, therapeutics, and impacting the society. I went a little bit over what Lundbeck does, who we are. You find few numbers here, some revealing numbers, not only about the size of the company or how old the company is, but the global reach. Over 8 million people use our product to better their brain health every day. So talk about a reach, that's a global reach. and that's not enough. We need to do more than this. We have a presence that is in over 50 countries worldwide, and we like to think of ourselves as leading the front in discovering new therapeutics for brain diseases. I'm not going to make a case for this audience about the impact of brain disorders on patients, on society, on the economy, on countries. Needless to say that the impact is huge, and the time to act, I believe, is now. To be precise, it was 15 years ago. We're a little late, but we need to act. We need to act now. So what is our impact and the areas that we decided to focus on? What are we known for, starting with Lundbeck? And I take it a little bit broader in terms of innovation and brain diseases. From a legacy standpoint, we're known to be significant contributors to a number of therapeutic solutions for psychiatric disorders, mental disorders, but also neurology. We've identified a unique opportunity to move into additional areas where the science has really allowed us to understand the disease a little better. We're moving into areas where the disorders are not as common as Alzheimer's disease, for example, but they are more rare, just as devastating, but rarer. So we call this neuro-rare, and lots of, narcolepsy is one of examples, other neurodegenerative diseases, and also a neurospecialty where those are disorders treated by specialists. And I can discuss if there are any questions as to why these areas. So we cover those 4 broad squares and everything in between as well. So mainly a lot of neurology and neuropsychiatry disorders. I discussed a little bit Lundbeck. One thing maybe to remember about Lundbeck is we've got a unique ownership structure, and that's not uncommon in Denmark for a pharma company, and that has really contributed to the thrive of the pharma industry in Denmark, is the ownership by the foundation that gives us stability. We're as I mentioned, over 100 years old. We're owned up to 70% by the foundation, but we're still a publicly traded company. And the advantage of having the foundation backing the company is the philanthropy that comes to it and the contribution to the ecosystem beyond just drug discovery, which is what I personally do. Just to give a few examples, in annual grants, over 500 million krona, which is a little shy to $80 million, something like this, every year to academic labs, PIs, contributors to brain health. And we've got, that's my favorite, the Brain Prize. We like to think about this as the equivalent of the Nobel Prize, but is focused on brain diseases. Maybe give it a few decades and it'll become the Nobel Prize for neuroscience. It's actually more than the Nobel Prize. It's close to 1.4 million euro every year. We give it to scientists and investigators that have made a real breakthrough in the field. So we discussed the growing burden. I think we've heard not only from me, but from other speakers today, the huge burden on society and the cost. I think it should be a lot easier, at least to me personally, to make a case to monetize the impact of brain disorders on a society, on an economy, and yet we still have challenges to make that case. It's easier in some instances to make case for different dilemma. There's a challenge here, and I hope we make progress because the case is very clear, and the impact of brain disorders on society, brain health in general, on the economy is massive. And I can discuss that as well. And Fred, you have any questions on it, I'll get back to that. But what is at stake here? I think it all starts with knowledge. In order to solve solutions related to brain health, the first step is to understand how the brain functions. It's easier said than done. The brain is fundamental to so many tasks, to everything we do as a society, but at the same time, it's complex. And we're starting to scratch the tip of the iceberg of all the mechanisms, all the cell types, all the neurons that are at play. The good news is that we're making breakthrough after breakthrough and lots of new discoveries that we're putting those to use, good use, to find new therapeutics. So we need to navigate that challenge. We discussed that. And we're up against another issue, which is the history, not so distant history, where the dogma was, oh, it is so difficult to work on brain diseases. It is so difficult to work on brain health. There isn't a business case for that. That was 10 to 15 years ago, and there were some reasons as to why these reasons were put forward. The failure in a lot of clinical trials, the difficulty in getting some tangible scientific angles to tackle brain disorders, the approach that was more based on what I like to call phenomenology as opposed to mechanistic biology, that led to a lot of failures as well. If you don't understand the disease you're treating, it's very hard to come up with a solution for it. So the good news is that we've turned the page. A new horizon has emerged, and that's a combination of multiple factors. The first one, and starting with the biology, is the rapid increase in our understanding of the mechanistic pathology of many brain disorders. This has been a game changer. The genetics associated with it, the multiple players, we've got a lot of options now to intervene at different stages of brain disorders where 10 years ago, it was not conceivable to come up with a bold therapy. It's more and more doable today, so there are exciting new advances. The druggability space, what we call the modality of the drug, back in the days, the only option was to design a small molecule, in other words, a pill, orally bioavailable pill to take, and that limits the option to find the right drug. Nowadays, you can go into biologics, you can use nucleic acid, RNA, so the science has allowed us to intervene in many different approaches. This has helped as well. And then the landscape, the regulatory landscape has also evolved. Regulators are just as eager as us to find solutions for brain disorders. So we're not alone, and lots of partners are helping. And of course, we can't discuss contribution to neuroscience and drug discovery without mentioning capital and funding. This is also changing. There's a lot more investment. The growth is double-digit growth yearly. From 12 to 21, it's 23% annual growth in investment. And then we're seeing a big growth in the market as well, which is, I believe, still underestimated. I think the need and the growth for the market is only going to increase, and the unmet need isn't going anywhere. The population, society is aging. We have to deal and tackle those brain disorders. It's just to kind of put away and brush aside the dogma that it is so hard. We've heard 10, 15 years ago, many pharma companies exiting the neuroscience therapeutic area. Oh, nothing works. It's very hard. Let's give up. Let's go into other diseases. Let's go into cancer. It's much better. Well, we've done the homework. We went back, I think when science started emerging, which is around 10 years ago, and looked at, okay, how many, we looked at the FDA alone, how many drug approvals, and what therapeutic areas did these drug approval belong to? And invariably, neurology or neuropsychiatry was in the top 3 approvals. So one of the main reasons that drove stakeholders and many investors away from neuroscience is disappearing before our own eyes. Lots of approvals. Almost 3 approvals for Alzheimer's disease alone. Many other approvals in different disorder, neurology, neuropsychiatry disorder, schizophrenia. Now we're seeing a resurgence in approval for schizophrenia and finding solutions. So lots of reasons to be optimistic. And as I said, this is the consequence of emerging and convergence of the multiple factors if you had to kind of remember one thing, remember the biology is evolving, the modalities evolving, engineering new ways to make drugs, and the biomarker and the clinical landscape. It's very important to be able to tell as early as possible before spending all the investment, which is, you know, for a phase 3 clinical trial in a neurology disorder is over $1 billion. Wouldn't it be nice to find out a few years before committing $1 billion whether your approach has the legs, has the likelihood to work? That would be a game changer, because not many players can afford multiple failures at $1 billion a pop. So that has been consequential and transformative. The development of the biomarker, can we tell early on? And this is something that we put to use, and I'll provide 1 or 2 examples. So we've heard about examples in other diseases. Alzheimer's, we've heard a little bit about that. There are a lot of examples. Epilepsy has been really a remarkable field where progress in science has brought new therapies, new treatment, new approaches to epilepsy. I'd like to pick another example where biology has been transformative. It's the case of migraine. It's a disorder I'm sure you're all familiar with, but the problem with migraine is it has a stigma. It took a long time to recognize this as a proper neurology disorder. It wasn't these people are complaining or whining. Migraine attacks can be debilitating, and the numbers back this up. So it's a devastating disease that has a big burden on society, and you can monetize that burden. Where this is an area where science, again, has saved the day. Those 4 esteemed scientists and individuals have provided seminal work in discovering a key component in triggering migraine attack. Not to get too technical, there is what we call a peptide, which is a molecule released in the brain. It's a chemical called CGRP. It turns out when this is released, it acts on neurons in the brain, and it triggers those big and severe migraine attacks. Some of them are so debilitating that they lead to individuals not working for weeks, if not months, with continuous headache or very frequent attacks. You intercept those with one of those novel modalities that I described. It's an antibody in this case. You administer an antibody, and boom, in over 50% of the patients, the migraine attack never occurs. And you get 50%. We still have a long way to go, because we've got 50% that are non or partial responders. But that's a huge, huge advantage there. So that's an example where innovation has saved the day. So to go maybe a little bit quicker as to what would be the approach, what do I propose as an approach to tackle some of these burdens on society and on patients? But as you probably felt a little bit, I'm a biologist by training. I think understanding what the problem is, regardless of the field, I think is key. Knowledge is key. So understanding the biology that we're up against, I think this is fundamental to a therapeutic approach. Second, before dispatching the big investment, find a way to tell whether or not you're sitting on an approach that has the legs to make an impact. So let the molecule speak as early as possible. And finally, listen to patients. They know best what the unmet need is. Not the market size, not the commercial, the patients. That should be in the heart of what we do. So this is super important, and I'm going to go quickly over this. It's going to save you some of the details, but I think we can make these slides available if you're interested. We're going to focus on some areas of biology that we believe are driving the disease, and it's very important to do this. We focus on these, but there are many others that stakeholders can focus on. Really understand the biology, you design the right drug, you're more likely to increase your probability of success. Second, remember, biomarkers. That's how we can stratify patients. The biggest problem is having a powerful drug but have the effect being diluted in a population of heterogeneous patients. So not only you wasted patients' time and lives, but you also waste what otherwise would be a great drug had you put it in the right patient population. So I can't stress out enough the impact of biomarkers, and letting the molecule speak as early as possible in the clinic. And finally, of course, patients are at the heart of what we do. We rely on patients' feedback at every step of the way, from the design of the clinical trial all the way to the readout and the endpoints. So let me finish with this. And this is the core, I think, if there is one slide to remember from this presentation, is how underestimated brain burden and brain health in society is today. So at the core is neuroscience, is the discipline of understanding the nervous system. And by the way, it's not only the brain, there's the peripheral nervous system, it's just as consequential as well. We study that, we discover drugs. But the advantage is not just to tackle this population of patients or sell the drug. It's the effect on society. Brain health alone can propel a society to thrive economically. Where do the ideas come from? They come from a healthy brain. And a dynamic society is a society where the brain is healthy. And a society that's faltering is a society where the brain is suffering. So the halo effect is often underestimated. And this requires a holistic approach to tackle that problem. If you touch neuroscience alone, that would provide some advantage, but it won't solve the problem. You need to look at it holistically and have the key stakeholders from early discovery all the way to policy making, legislations, and patients. So I'm going to pause here, and if you have any other question, I'm going to sit next to you again. Yes, wonderful.
Well,
thank you all.
It's supposed to be a fireside, so
yes.
I think we have the context. And I mean, actually, you've provided fantastic elements of information. I don't know if we can go back to your slide where you had the shuttle and the various advances, because I had a question on that, which is probably to lead us into some of the details.
Yes.
And I'd like to hear from you as a biologist. What are you the most excited about in what's coming up in this field?
Yes, thank you for the question. And this is like asking a parent, who is your favorite kid? So those are my babies. But it's true that I'm particularly excited about some emerging areas that has the potential to be unique. You mentioned the shuttle. So why is this exciting? What we call it is the brain shuttle. Not to get too technical, but there are two classes of medicines. One that is small enough to go straight to the brain. It's an oral pill. The other one is too bulky and too big to go to the brain. A lot of the targets for diseases are bulky, like antibodies, huge. Those we administer, but they don't go into the brain. What do we do about this? So not myself, but my colleagues, I'm not going to take credit for it, engineered a shuttle that outsmarts what we call the blood-brain barrier and then make it to the brain. When you attach the bulky drug on that shuttle, it can go and penetrate the brain and then treat the disorder in the brain. So that's exciting, that's futuristic, right? And yet it's close to reality because some of those projects are in phase 1 with others and hopefully soon with us too.
So just to understand, the shuttle would be able to trick the blood-brain barrier. It's not a system where a gate would open. It's simply a way to enter more easily.
It seeps through without disrupting the blood-brain barrier.
And that would be one of the ways to address what has been for long one of the key challenges in the complexity of neuroscience.
Correct.
Yeah.
Correct.
Okay. So from there on, I mean, you've worked with academics in order to design this avenue, this let's call it a new technology. So now your challenge is to be able to implement it. So a question I had, and it's also related to the other example on migraine that we love at EBC because actually it's one of the grantees is the founding president of EBC, Jesse Olesen. But how much time does it take between a discovery like that in a lab or in an academy and for you and your colleagues in the pharma sector to deliver to the market?
Yes, a great question, and that's a dilemma as well. What sets neuroscience a little bit apart from other therapeutic areas is the time it takes. So let's kind of divide this in two. If you look at the time it takes from a target already discovered and the ability to engineer a drug and then go through all the phases of clinical trial, it is 10 to 15 years. 10 to 15 years minimum from the time we know what the biology that we need to tackle is, all the way to launch with an approval by the FDA. And all these, it takes a lot to make a drug. There are so many different pieces. It's one of the most complex approaches in the world. But then you ask another question, how long it takes to discover also in basic biology that drug. And that also takes between 5 and 10 years to make sure that what you've discovered is translatable and can become a drug. Not every discovery can become a drug target, because some of the functions we discovered, it's true they contribute to one disease, but they're vital in another context. You don't want to inhibit something that's so vital just because it contributes to the disease. You'll have toxicity. So that also, research takes 5 to 10 years. But you touch on an important point. If pharma companies start doing basic science, they get lost in those 5 to 10 years desert of discovering fundamental biology, and then walk away from what their focus should be, which is discovering drugs, and vice versa. So there is a place for every stakeholder. If it's done well, you can shorten that time. If it's not done well, it can take over 20 years, right? With a disappointment in the end.
But so when you're saying that science and biology no deliver, I mean, sometimes I get a feedback within our membership to say, okay, does that create an understanding that scientists were lazy in the past? What does it make it that now we can say we are getting to a stage of greater understanding, a greater degree of knowledge generation? And I would even push it further, is like, can we call it somewhat a renaissance in the space?
So I'll start with the end. I think yes. I think this is what we're witnessing today.
And what is giving you that feeling?
Yeah, what we're witnessing today is nothing short of a renaissance. And what's giving me that feeling is all the discovery, the ability, for example, to use a shuttle to send it to the brain, the understanding. Genetics alone has been transformative. Now we've got causal evidence. What goes wrong that the body develops a disease, right? So we've got a lot of, now there's a lot to be done still. We don't know everything. But to go back to your previous statement, where it's why hasn't this happened in the past, and where scientists are a little lazy, I don't think that is the case. I think it's just technology hasn't progressed. It's like saying why in the 1800s they didn't have cars, right? That's how it is. But now that the technology is there, it is almost a crime not to take advantage of it. Why this hasn't occurred earlier, that's a separate question. I don't think the technology was progressed enough. And the tools that we have to study the human body are completely revolutionary. By AI alone now, you can do a lot more in one day than what you would do in 2, 3 years, 10 years ago, right?
Okay. And another thing because I'd like to go back to this timing issue. What are the challenges that you would identify, within these 10 to 15 years you just mentioned? What are the barriers, and what would be your vision to address those barriers? Because we've addressed the biology, we've addressed the molecule, but now there is this notion of partnership, because you very much emphasize the way by which patients should be real actors and recognized into the system in actually creating the validation of such solutions. And we talk increasingly about patient-reported outcomes measurements and actually how to recognize that in the system. And does that bear potential to accelerate progress?
Well, the answer is yes. And to talk about barriers, sadly, we have numerous barriers. But like in every field, you have barriers, you have challenges. The question is not whether or not we have barriers, but how can we overcome those barriers? So let me give you one example. I think cost is a huge barrier, right? This is not a business that any organization can venture into. If it takes $1 billion to make a drug, and the probability of success is still sadly less than 10%. So if you want to be sure to come up with a solution, you got to invest a lot of capital. And if the risk is very high, then very few. So how do you do that? How do you pay for innovation?
So I'm tempted to ask you, is the issue the cost, or is the issue the risk?
I think the two are connected, because if the probability of success was 100%, then even though the cost is high, you know that you're going to spend $1 billion, right? And then you're going to impact society worth hundreds of billions. So, but given the risk, the risk is the probability of success is not very high in this field, because we don't understand all the biology. Then the two kind of the combination of the two make it even more challenging, right? So it's the cost plus the low probability of success together is a bad combination, right?
Okay, and how about then an issue of the return on that cost?
Yeah.
And where, I mean, how can we nurture the cycle? Because there is this saying of innovation that is not implemented is worthless. So how can we make sure that we can sustain the progress, that innovation is being generated, that it has a transformational capacity, a societal benefit, but that we can also generate an uptake within our healthcare systems of that innovation in a daily practice?
Yeah, I think realizing, and this is, I hope, one of the things I would advocate for, realizing how impactful innovation is across all stakeholders, starting with the government, but also, pharmaceutical companies themselves. It is almost imperative to put all the return into the new drugs of the future as well. So pump a lot of this revenue in R&D, research and development, in drug discovery, to maintain that cycle and then build on the momentum of the innovation in science. Policymakers have to also be on the receiving end and make it even easier, right? And of course, there are cases where, pricing needs to be tackled as well. It's kind of unfair to have the prices extremely high in some part of the world, and you can't launch in others. So that needs to be fixed through policy as well. At the end of the day, we need a creative solution to pay for innovation. And this is something I thought a lot about personally, right? I'm not speaking here in Lundbeck's name. And I think if you look at what other fields innovation has worked very well, right? And has paid for itself. Technology, we don't sit there worrying, okay, when is the iPhone 15 going to come out? Who's going to pay for it? It just happens. Why? Because people realize that it's needed, it solves problem, and then we have no choice but to invest in it, and then we'll pay for it as well. When it comes to healthcare and brain health, this is not the case, right? So, and again, we can talk a little bit about this, but I'm surprised by the lack of homology between those two identical problems.
No, absolutely. And actually, you took the perfect example after the contribution of the governor this morning about social media and smartphones. Well, just an issue, and to come back maybe on that notion of the partnership, because you mentioned policymakers. Obviously, we can integrate regulators in this understanding. And you were saying earlier that as a pharma company, you wouldn't do what scientists and academia are doing, and vice versa. So what would be, let's say, your ideal ecosystem, and how can we make sure that we generate dialogue so that everyone fulfills their role, but also that there is this level of understanding between let's say, the contribution of each actor into the ecosystem?
Absolutely, and I'm glad you asked this question. I mean, probably the best way to answer this is to provide an example where this has been super efficient. I'm going to go back a few years, and you all remember still going on, the COVID pandemics, right? There was a clear commitment and a decision to solve the problem. And it went all the way from basic scientists and universities, right? Oxford universities, other universities, all the way to pharma companies, biotech, legislators, the FDA. They all worked and had in one direction. And guess what happened? 2 to 3 years, we had the tests, we had the vaccines, and I like to argue that we saved humanity. Less than 3 years. So that's just to show you the potential when there is a systemic approach to solving a problem, and not targeted, not just helping pharma, helping scientists, helping policymaking. Isolated effect, it won't have the big impact. But if you put them all together and ask them to row in one direction, you'll get marvelous results, right?
And we are currently into, I'll open the floor for questions in a moment, and I'll bring you in, George, and Marco as well. So if anyone, Tad, and maybe a last one. Yes, and the gentleman at the front. Just a last question. This ecosystem working together, is it aligned with the understanding of what we talk about when we talk about brain health, brain disorders? Because we currently have an emerging discussion on the notion of classification or description of brain disorders. And I know this is something you've been working on, is what I think you call the phenomenology of diseases. So can you talk to us a little bit about that?
Yeah. So I'd like us to move from what we call the phenomenon of brain diseases, where we describe, say, let's pick a disease like Alzheimer. Alzheimer is just dementia. And let's enroll 20 patients with dementia, not understanding what led to the dementia, and try to treat them. Well, guess what? You're highly likely to end up with 20 different diseases in 20 people. They all manifest themselves by dementia. So it's almost dangerous to go through phenomenology, and I think let's take advantage of the science, right? But maybe to take a step back, I think the first step in this systemic approach is to acknowledge the burden and the problem, and to all be aligned that we need a solution and the time's now. And this was unequivocally the case for COVID. It's not yet the case for brain health. And I wonder why, right? And then we all, after 2 or 3 years, felt that, oh my God, we saved society with this. And we have yet to experience this in brain health. Hopefully awareness will be stimulated.
And I think we are all concerned and curious to know why brain health is not a priority like COVID was. Are you up to take a few questions from the audience? Because I've seen a few hands raised. And I'd like to start with you, George. I don't know if we've got a mic available. Yes, thank you. Yeah, I think it's up.
George Vredenberg, Davos Alzheimer's Collaborative. But we are now working with the FDA, the NIH, regulators around the world to construct an Operation Warp Speed to develop a vaccine for Alzheimer's, an active immunology, immunotherapy, something that is low cost and is available to the whole world. Because we've been testing medicines basically in white Europeans, legacy populations, and not the rest of the world. It's where most of the disease is. How do we get to something like $100 product? I mean, how do we get something that is low enough cost that it will deal with the problem around the world, and that it's easily administrable, not through neurologists, not through specialized equipment, but through the shot?
Oh, great question.
So
should I answer or should we go to?
Yeah, George, can you give the mic to Marco? And Marco, wait a second.
Yes. Well, first of all, thank you for doing this. And I think big problems require bold solutions. Tackling neurodegenerative diseases with a vaccine used to be a dream 10, 15 years ago. We're getting closer to reality. And I think if you compare a standard therapeutics, what is available now, and it's fairly costly, and from a cost of goods standpoint, the actual drug costs a lot of money. This is not a revenue margin. To a vaccine, the vaccine is better positioned to have a more reasonable price, even from a cost of goods standpoint. So you are pushing the field closer to a place where the price can go down via a vaccine and the impact can go broader. And I think it will be, there is an equivalence, even from paying for innovation or innovation paying for itself, because if the penetrance is limited and the price is high, it's almost equivalent if you've got a broad impact with a lower price. We want to be there, and that might take us there. Now, the biology, hopefully the biology will go our way as well. We've got a clinical trial that will show this unequivocally, placebo-controlled, double-blind. But when this happens, tell us how we can help, right? Not in vaccine, and I have to admit that Lundbeck is a mid-sized pharma, and $1 billion is a lot of money for us. So unless we find a partner, this is not something we've got the capability to do it by ourselves for a big disease like Alzheimer's, but we're willing to partner with this. So if you know partners that are willing to, we tackled Alzheimer from a symptomatology standpoint, but that's another story.
So the answer is not yet.
Not yet.
And George and yourselves will be up for an offline discussion, if I understand correctly.
Yes.
So. Marco?
Hi, Marco Mowinkelt. Hi, Tarek. Nice presentation. I wanted to your perspective on precision and stratification of patients using biomarkers and different technologies that are available to us. what is your view and of the potential, and where are we on that journey to getting to more precise and targeted treatments using biomarkers, particularly in psychiatry?
Yes, yes. And then, so you touch on an important point. I think psychiatry is one of the fields where the need is more dire, just because it's a circuitry issues and we don't fully understand it. But I'm almost tempted to say that discovering biomarkers for disease stratification is almost as important, if not more important, than discovering the therapy itself. And we are tempted to also make a decision if we don't have the means to find out whether we have the right patient population or did the drug do what it was intended to do, we're better off deprioritizing this particular project because it's more likely to fail and focus on another one with that biomarker diagnosis companion to target and then guide us through the disorder. Now, psychiatry is a tough one, but there are reasons to hope the immune system might come back and save the day. This is public information. And in many cases of psychosis and schizophrenia, levels of autoantibodies are higher in some of the patients. Then you'll be able to actually triage and select those patients that might benefit more from an immunology therapeutic intervention. 5-10 years ago, it wasn't possible to treat everybody the same. There will be a population that had a different etiology of the disease that won't benefit from this intervention. But that's a modest but significant progress we're making. But that's the future, right?
So I'm just conscious of the time remaining, and I really would like to take the last two questions. So please, short question and short answer in order to be finished on the time I was thinking we could allocate.
Well, thanks for taking my question. I'm Michael Martino, MD PhD student at MUSC, and so I'm interested in if your group is working on, the promise of, I guess, digital mental health in the treatment of neurological and especially psychiatric disorders as the computational tools and understanding of how these neurocircuits affect behavior, decision-making, and cognition are being better understood. And if you can just kind of comment on that.
Yes, so we are starting to work on this. We are not yet at a stage where we've got clear therapeutics, but others are in the field. And one of the challenges that probably for you to keep an eye on and follow the field, it is very hard to register and approve a device that's associated with AI. So there are some regulatory hurdles that make this hard. We haven't faced this yet, but others are. So that's something to keep an eye on. Our journey is just starting there, but that's an equally fascinating field to understand the circuitry that way.
Tadeusz. Thank you. I'm Tadeusz Hawrot. Thank you for an interesting talk, Tarek. So I'm straddling, in a way, brain. On one hand, I'm here with Orla, doing policy and advocacy work for the European Federation of Neurological Associations and One Neurology, but I'm also the founder and executive director of the Psychedelic Access and Research European Alliance. And so my question is this, we speak about CNS, we speak about neuroscience pipeline, but when you zoom in, things are not very equal because I think IQVIA a couple of years ago did a report and 80% of the pipeline is neurology and 20% is psychiatry. Out of psychiatry, probably maybe half of it is psychedelics, I don't know. But so I think kind of the trajectory of neurology has been going up quite nicely, but yeah, psychiatry is catching up slower, and maybe my question was already tackled partly by the discussion that Marco started, but I wanted to ask, where do you see mental health innovation and mental health therapeutics, in the next, say, 10 years? Thank you.
Oh, great, thank you. And very quickly.
And that could be actually a very nice way for you to extend your response as a way of concluding this.
Yeah, I'd love to. And so you're absolutely right that psychiatry is lagging a little bit behind, but maybe to mention two things very quickly on psychiatry. I think the reason why it's biomarkers, but there are two areas where we've seen progress, we've seen impact. Psychedelic is one of them. We're still wrapping our head around how does this work and what does it require and what are the safety components around it. But what we're seeing are very encouraging sign. The other one is a new class of drugs called the muscarinic drugs. And then you've seen 2 trials that were positive recently in psychosis. So this is a new class of antipsychotic. It's that we've never seen this before in the past 10 to 20 years. New class of antipsychotic acting on muscarinic receptor in the hands of 2 biotech companies that has shown efficacy. So reasons to be excited, even in psychosis and schizophrenia, toughest diseases. Right?
Yeah. And reasons to make you optimistic for these 10 years to come in the space, right?
Absolutely. And so I'm fairly bullish. Optimistic is my nature, but I'm bullish this time because I think the science is helping my optimism. And I think we've got multiple avenues to go. But don't get me wrong, we're not done yet. I think the goal is the cure. I don't think we can say that we are at a point where we can cure. I think cure and prevention. If you want to maybe keep 2 words as a take-home message from today, cure and prevention. Maybe the vaccine can give us the good prevention for neurodegenerative diseases. And then how do we run a prevention clinical trial? How do you do that? Do you take a trial for 15 years to prevent? You don't know when the disease is going to occur. So cure and prevention is the next frontier.
Okay. Well, thank you very much, Tarek. And please join me in thanking Tarek for this fireside chat.
Thank you very much.
And we will now be moving on with our program. Thanks a lot. Cheers. We will now be moving on with our program, and we have our next panel on business and brain health. That is a panel organized by one of our partners, Us Against Alzheimer. And we have a keynote to introduce the panel, who is Kena Enamoto. Oh, Kena, you're here. I'm relieved to see you were around. So Kena is working at the McKinsey Health Institute and is director for brain health at the Institute. So Kena, you have the floor.
Good afternoon. Good afternoon. So I would like each of you to do me a favor and think about something that you have learned today that left you inspired, excited, joyful, hopeful. Just think about that to yourself. Anything that made you feel inspired, excited, joyful, hopeful. And hang on to that feeling for the next 10 minutes, because what I've learned is that the brain learns faster, 4 times faster when it's emotionally engaged. So I think I'm thinking about the joy and the hopefulness that I felt when I've heard several presenters today talk about including people with lived experience, co-creation and partnership, because I think it's amazing. We've been doing that sort of in the psychosocial realm for a long time, but now to hear pharmaceutical companies and NGOs talking about that kind of engagement of people who are lived and living experiences is really exciting and hopeful for me. So that's the joy that I'm riding on this morning. As Frederick mentioned, I'm Kena Enamoto. I'm Director of Brain Health for McKinsey Health Institute, and I'm really pleased to be here representing a partnership together with Us Against Alzheimer's and Davos Alzheimer's Collaborative, because the 3 of our organizations came together recently thinking about how do we present this combined view. So at MHI, we have a team. I lead the brain health team, but we also have a healthy longevity team. I'll take the clue. We also have a healthy and longevity team, and we also have a employee health and well-being team. So kind of brain health, healthy longevity, healthy workplaces. How do those 3 things come together? And so we created our partnership to think about, can we develop a framework, a conceptual framework that can help employers think about these things? Because if we have a hard time articulating how these 3 disciplines come together, imagine how much more confusing it gets for employers. And I know the panel today will talk to you more about that. So here we have the role that employers play in the brain economy. We've been talking about that yesterday. We're going to be talking about that for the next 2 days. There is so much potential that employers have, that our economies have, by paying attention to employee health and well-being, right? 12% of GDP could be added. That's from one of our cleverly titled McKinsey Health Institute articles called 9 to Thrive. We could add up to $12 trillion to the global by investing in global health and well-being and economic value. And then we think about the 12 billion working days that are lost to productivity, lost productivity or absenteeism from employers. That's up to $1 trillion if we could pay better attention and address employee mental health. We spend about 1/3 of our lives at work. About 2/3 of us derive our identities from our work. And I don't know if that's a good thing or a bad thing, but luckily for all of us, we're doing important work of brain health. And so I think that's a meaningful part of our purpose that we derive at work. And yet 1 out of 5 employees, we have this from a global survey that we did in over 20 countries, and we found this to be surprisingly consistent. 1 out of 5 employees worldwide says they are experiencing some form of burnout, and this is post-COVID. So what can employers do? They're getting a lot of point solutions. We talk to a lot of employers. We'll have employers on the stage today. They'll talk about the fantastic things they're doing. They get approached by many, many good opportunities. There's strong evidence that if you could do more around mental health, we can create better access to healthcare. We can help people address their depression and anxiety, address their substance use in workplaces. We know neurological health, that then this is, again, as a person with lived experience, my mother had dementia for the last 13 years of her life. There is $347 billion of unpaid care provided by caregivers in just 1 year to people living with Alzheimer's and dementia. And then the $8.8 trillion cost of people who are disengaged at work. And so employers have a lot of investment in this area across these different disciplines. They're also getting approached with lots of different solutions, right? You could do mindfulness, you could do brain training, you can do high quality childcare. Each of these things has evidence of effectiveness for at least one of these dimensions. But we also all know we're not going to yoga our way out of this problem. Right? We need a different kind of a framework to think about how to get the most out of our investments. Employers can only do so many things, and they're not necessarily going to dive into the literature and each of these literatures separately to identify what are the right highest value interventions that they might think about. And we don't have very much guidance available to employers that looks across these domains. And so in our partnership with Us Against Alzheimer's and Davos Alzheimer's Collaborative, our McKinsey Health Institute team looked at our own surveys, our own data, the research that we've published on drivers of poor health at work. And then we looked at their research and their conceptual models for how you would look at neurological health or healthy longevity over time. And we identified, the funny thing about this page is you're not actually meant to read it. You're just supposed to take away from it that there are a lot of risk and resilience factors for each of these different domains, right? And some of them are overlapping, like age, right? Age is a risk factor for each of these conditions. But then some of them are not so overlapping, like stigma or toxic workplace. But we looked at these risk and resilience factors, and then we said, well, this is a lot for people to think about, right? How would you do programs that do all of these things at one time? That's too much, it's not navigable. So we then tried to look at, can we refine these models? So we looked at hundreds of articles, took 125 high quality articles, found 72 risk and resilience factors, and then we said, well, still 72 is too many. Can we narrow that down? Can we look at factors that cross over between mental health and neurological health, or mental health and workplace performance? And so we were able to find things like cognitive engagement, for example, does cross over to all three. Then we're also able to find some risk factors that have their kind of risk factor on one side, resiliency factor on the other, so like sedentary lifestyle versus active lifestyle, so we could combine those things. When we did that, we came down to this lovely unified model of brain health in the workplace, which we landed on 21 factors that cross over. So our definition of now brain health is combining mental health, neurological health, and workplace performance. We looked at sources of value to employers. We looked at the literature. How does this topic relate to the key sources of values for employers? So increased innovation and creativity, reduced healthcare costs, increased retention, increased productivity, and adaptability and learnability. So those are, how do these factors that affect our mental health, neurological health, and workplace performance relate to those sources of values for employers, so that we can help employers see that investing in brain health, investing across these three dimensions and the risk and resilience factors that go into them has a bottom line or top line impact for you, right? These are things that you care about. These are things that are important to the functioning and the health of your organization. And these are also important to your employees. So even 21 factors, it's a very cool looking chart, but it is a little bit still hard to focus. So we narrowed down a little bit further and found what are 3 factors that drive all 3 of these dimensions of brain health. So when we landed on community engagement, social support, stress, sleep, cognitive engagement, access to services, and mindsets and beliefs. And that with this kind of more refined, unified framework, we think this is something that we'd love your feedback on. We'd love your suggestions. If you say, well, there's parts of the literature you guys probably didn't dig into, but here's what we know. We had great conversations with George and Kelly. George had a hard push. Creativity is important. What are the things that lead to creativity? We know that's an important source of value for employers. And then as it turns out, we found that there are a number of dimensions and that did actually rise to the top. So it's not everything. This isn't meant to be exhaustive. It is meant to be directional. It's not a statistical model. It is a framework for considering that. But we'd love for folks to give us feedback. We'd like to continue this conversation about how each of these risk and resilience factors can support each of these things. How do we promote more programs that do these things? And then again, other things we might have left out or forgotten. We'll be posting this on the Us Against Alzheimer's website, so you'll be able to take a look at it. And we will welcome your reflections. So again, here are our 3 QR codes: McKinsey Health Institute, Davos Alzheimer's Collaborative, and Us Against Alzheimer's. We're excited because the factors that we identified actually dovetail very nicely with another tool that you can find on the website, which is HERO, and the Us Against Alzheimer's Business Collaborative have come together with a workplace assessment that you can also find there. And we welcome you to reach out and keep talking to us about what you see and what you'd like to see. Thank you.
Thank you very much, Kenna. And actually, it's paving the way very nicely to the panel that follows, the panel on business and brain health. And please welcome on stage the moderator, who is the CEO of HERO, Karen Mosley. And Karen, you have the duty and the honor and privilege to welcome your panelists on stage. So I'll give you the floor.
I'm going to invite my panel to come up while I get started in the interest of time, so that we can get you to lunch. But thanks to Kana for helping us to get to a positive place so that we can learn together for these next 50 minutes or so. The research that you presented, I'm so excited to share with the HERO network as well, because we like to elevate the research that is occurring around workplace health and well-being, connecting science and practice. And I'm pleased that we have employers and representatives today on stage who already understand that connection. So we'll be having that discussion and delving a little bit further. This panel discussion is going to explore how employers are recognizing brain health as a competitive asset, one that not only supports healthy longevity, but also generates greater economic returns, empowerment, and societal resilience. So about 18 months ago, HERO partnered with Us Against Alzheimer's, and thank you to Us Against Alzheimer's for this opportunity to really elevate and continue to raise the bar on the research and the practice for health and well-being in workplaces. We partnered to explore the business connection to brain health, and initially there was some skepticism about whether this topic would resonate with employers, but here we are, and we can see the growing recognition of its importance. Representing a research organization, I'd be remiss if I did not use a few studies to help frame this discussion. First was a study published in the Journal of American Medical Association earlier this year, and is considered to be the first to show that healthy lifestyle practices can help maintain cognitive functioning even in older adults with Alzheimer's. Using 24 years autopsy data from more than 700 patients, the study linked higher and lower healthy lifestyle scores to dementia-related brain pathologies. researchers concluded that lifestyle choices, such as diet and physical activity, can build a cognitive reserve that can help maintain cognitive abilities in spite of the pathologies related to dementia. Another study from the Industrial Relations Journal examined mental health interventions in over 200 British organizations, and despite its limitations, it did provide valuable insights that can help inform brain health interventions and practices going forward. Here are just 3 of those insights highlighted by Dr. Paul Terry, Hero Research Senior Fellow, in his American Journal of Health Promotion editorial. First, too often we consider program effectiveness without consideration of a program's reach. As we consider brain health initiatives, we need to invest in doses strong enough to be impactful, but we also need to make reach and equitable access central in our approaches. As with the challenges we face related to mental health interventions, we won't solve for reach until we solve for stigma. Second, right from the get-go in our brain health promotion efforts, how can we better amplify the role of social connections and belongingness alongside other proven pillars like diet and exercise? The most effective intervention uncovered in the British mental health study was the positive mental health impact of volunteerism. Participants reported significant improvements in subjective well-being as well as improvements in subjective accounts of their work environment. Increases in a sense of purpose, accomplishment, and social resources were all well-being products of volunteering. And third, are individual interventions occurring within the context of workplace well-being best practices. You may have heard, and you heard it just now, you can't yoga your way out of a terrible work environment. Once we routinely combine individual level data with organizational level data about culture, policies, and environmental supports, such as is found in the Hero Health and Wellbeing Best Practices Scorecard in collaboration with Mercer, only then will we be able to answer questions about the right balance between individual and organizational level interventions. Hero research shows that organizations implementing evidence-based health and well-being best practices demonstrate superior health risk and healthcare cost trends and are linked to higher stock performance for publicly traded companies. In fact, this graph demonstrates the results of one study in which a portfolio of companies that received high scores on the Hero scorecard appreciated by 235%, compared with the S&P 500 index of 159% over a 6-year simulation period. The Hero scorecard, developed almost 20 years ago and continuously updated, and side note, is freely available in the public domain. There's an easy QR code to get there, and also available in a US and international version, has helped thousands of organizations learn about best practices for a comprehensive approach to promote health and well-being and to discover opportunities to measure and improve over time. This Hero scorecard highlights best practices for supporting mental health, social determinants of health, diversity, equity, and inclusion, and now, as George mentioned earlier today, officially launching the special Brain Health Best Practice Score to help organizations zoom in on assessing how they are supporting brain health and to identify opportunities to improve. Business addresses both mental health and brain health through motivation, purpose, and social relationships at work and in the community. This framing of mental health and brain health will lead to a stronger connection with business outcomes and the value proposition for business to be a key player in healthy aging and reducing the risk of neurological disease. This next discussion will delve deeper into these themes, and I'm excited to hear from our experts, so we're going to get started. First off, we have David Stark, Chief Medical Officer with Morgan Stanley. David, you're in a unique position at Morgan Stanley with line of sight over both HR and benefits and into the CEO's office. But perhaps most interestingly in the context today is, as a neurologist, you get this. So if you'll put on your doctor coat for a minute, knowing what you know about neuroplasticity and brain function, how does this or can this inform your thinking and approach to well-being at Morgan Stanley?
Sure thing. Thanks, Karen. Can everyone hear me okay? All right. Good to be here. Great discussion. Look, my team and I, we get up out of bed every day to deliver the triple aim of healthcare for Morgan Stanley's 80,000 employees and their families in over 40 countries. So we're delivering access to high quality, affordable care. And that's in service of broader business objectives, recruitment, retention, productivity, a healthy amount of financial risk management, because as I'm sure we've been discussing, much of healthcare spend is borne by employers, particularly here in the US. So getting to brain health, I want to touch on 2 points: neuroplasticity and executive function. So I think this is a pretty well-informed audience. We know that neuroplasticity is how the brain wires and rewires itself over time, over 80 billion neurons, trillions of synapses. Essentially, the brain, like any organ, requires a steady supply of glucose and oxygen to do that work. So when we think about brain health, we think about a total body approach to health. How can we support physical health, mental health, financial well-being, family support? How can we aid our employees address their sleep, nutrition, exercise, mindset, relationships? All of that together is how we think about stitching together our healthcare and other benefits on behalf of our workforce. So we don't address brain health specifically per se, but we know that by taking that holistic approach, we're aiding all the body's organs, inclusive of the brain. Now, on executive function, we all know that executive function is how the brain attends to stimuli, tunes out less relevant stimuli. And what do you need to have executive function? You can't be too stressed, right? As soon as stress goes up, prefrontal cortex shuts down. So we think a lot about how we can support our workforce, not just around mental ill health prevention, disease prevention, but across the entire continuum of mental health. Burnout, stress, anxiety, not quite in the medical realm, but in our workplace realm, really, really important. And I would gander that the stats are far more than 1 in 5, by the way. I think that across all of our workplaces, these what I would call normative effects of mental health are prevalent. And I'm sure all of us in the room have experienced stress, anxiety, et cetera, at some point in time during our work careers. And we know that when we are experiencing those things, we're not at our best. Our executive function is not at its best. And that's going to have an impact not just on us, but on the workplace culture and ultimately on the bottom line. So we take a very holistic approach again, and there's a lot we're doing internally, providing access to high quality mental health care that's in network, that's evidence-based. Doing work internally, I like to say this is the roll up your sleeves work. You can't just bring on a vendor to do this work. This is about organizational culture redesign, manager mental health training, training our employees to spot signs of burnout and come to the aid of their colleagues. Because with an 80,000 workforce, we can't rely on top-down messaging to get the message across. We have to enable the community that we have internally. So really glad to be here. Looking forward to the discussion.
Thanks, David. I'm going to repeat, roll up your sleeves work. That's a good one to keep in mind. So next we have Brian Jebb, partner at Global Co-Head Compensation, Employment, and Governance at A&O Sherman. Brian is also a key leader in the Mind Forward Alliance. Brian, A&O Sherman is the product of a very public merger that created one of the largest global firms in the world. How did you and your leadership support the cognitive well-being of your people during this challenging time, and what, in your view, makes the difference in outcomes?
Yeah, so thanks for including me. I'm Brian Jebb. I'm an employment lawyer by training. And as in the introduction, our firm went through a merger. It's the biggest law firm merger in history. Allen & Overy merged with Sherman and Sterling. Mergers create stress. It also gives rise to opportunities, but it was a real challenge for our organization. How can we bring two firms together? And also we're lawyers, and those of you who work for lawyers probably know that lawyers tend to have opinions on things and sometimes express those. So in terms of leadership, I think that's the key. When I was starting out as a lawyer, my first boss was Greek, and he had all these great Greek sayings for things. And he used to say, the fish smells from the head. And I think in an organization, particularly as an employment lawyer, this is something I see from day to day. You need to get buy-in from the top of the organization. So we're very fortunate at A&O Sherman that the leadership of the organization identified focusing on mental health and wellness is a key driver of our business, and particularly at a stressful time like a merger. So one of the things we did, we created a global wellbeing advisory board. We set concrete KPIs. So it's not just talking about things, because we want we want, to your point, we want people to buy in. It's not something you can just sell to the organization. One of the things we found has worked is to be careful on how you brand things. So when you mention words like wellness, you might lose some people in the organization, particularly, you know, some folks who thought, oh, when I was a junior lawyer, no one talked about my wellness. So what we branded as sustaining high performance. And the key for us is, you know, to do your best work, you have to be at your best. And so we've tried to create policies to support our employees, our lawyers and our staff, and to make sure that all our employees know that they have support at the top of the organization. And that's part of what, you know, the board that I'm on is designing to do.
The fish smells from the head. Next, we have James Mitchell-Garvey, Senior VP of Total Rewards and Technology at Southern Company. James, Southern Company is squarely focused on sustainability and the transition to a green economy. Your role is focused on supporting the humans that are facilitating this transition. So in other words, you lead the human sustainability part of the equation, and by all accounts, you're indeed a very progressive organization in this respect. The well-being practices and structures you've established are among the best in the nation, including for brain health. So if you could tell us a bit about your approach to brain health and well-being, both internally with your workforce, externally in the communities where you are, and why this is a critical priority for the leadership of Southern Company.
Thank you. Yeah, good to be with everyone. I guess before I jump into my story, let me just share a little bit with the points that have been made around stigma and some of the other things. So the notion of brain health, and it's probably one of my biggest takeaways from preparing for this and also just, you know, reflecting on some of it. When we think about brain health, it's so important to move away from the notion of, and it was mentioned earlier around stigma and how do people perceive some of these things. And the thing I love about brain health is that it shifts it away. If you're thinking about emotional well-being or mental health, it starts to shift the conversation from being one of a liability to an asset, one of being risk management to one of kind of endless opportunities, one of kind of on the defense to one on the offense. So I think that whole notion, and you've heard a theme here from a couple of folks already on the importance of being able to reach everyone and get over the stigma. So I'll share just a little bit about our journey. Gosh, 8-9 years ago, and I love the fish smells from the head, because I had a conversation with our CEO at the time, and we're a large we own massive infrastructure. So we're one of the largest energy infrastructure companies in the United States. And we're just talking about an underperforming asset, the human capital asset, and this was about 8 years ago. And it was one around, you know, if you had an underperforming asset, what do you do with that? And we started to bring in a lot of data, and it was data around, at the time, what we had on physical well-being, financial well-being, all of the data. And we started to bring in tons of that, absentee data, you know, disability management data. Gosh, we got credit score data from some of the credit bureaus. And you could start to see that you had an underperforming asset. So it became this whole conversation with senior leadership 8-9 years ago. How do we start to invest in that? How do we start to invest in people being well so that they can turn up, not just from a safety perspective, but help in the complex business challenges that we had around sustainability of the energy infrastructure? So we started to invest. We did a whole bunch of co-creation with vendors and with technologies. And we helped create, you know, co-create a bunch of different online applications, applications that were in some cases virtual, really to go after many of the aspects that have been hit on here. And we've had really good results, and really good results, not just from an ROI that we track, financial ROI, but you start to see productivity improvements. You start to see higher levels of engagement. So for us, it's a business imperative. It is something we've moved beyond that this is just something we need to do. It's moved into how do we now be citizens where we serve, and how do we serve in our communities, and how do we do things as a business that helps drive the communities in which we serve. So we want our employees to be well, and our CEO ends every meeting with that, be well. And I want you to be engaged and talk to people, and it starts with leadership there, and it really, once you can get over that whole notion of talking to people that we all need, and we talk about life stages, everyone needs to manage stress through all of our life stages. So we talk about openly in our company, if you're adopting a child, having a child, you've got aging parents, parents with, you know, conditions, buying a house, selling a house, every stage of life has stress. therefore engage with people to manage that. And here's all of our infrastructure, tools, some of them digital therapies, various different tools that we've helped co-create to help employees engage on those fronts. So.
So we need the accountants in the room or online to figure out how to move this human capital back up in the balance sheet where it belongs at the assets. Absolutely. Next up, Crystal Sexton leads health analytics at Shell. She's also one of my favorite Hero board members because she's here. I can say that today, right? Stephen, you're number 2. As the person at Shell who tracks global analytics and outcomes of health and well-being initiatives, what are you seeing? How does your global organization see the issue of brain health?
So I think just to echo what has been said before, can you hear me?
Can you hear her?
Yes.
Yes.
Oh, yeah, can you hear me now? Okay, so I hear you. Yeah. So just to echo what was said before, we don't actually talk about this in the sense of brain health per se. We look at this from a holistic perspective. That includes physical, mental, social, and financial health. And we've been doing that for a number of years. We were traditionally looking at just health promotion from a physical health perspective, and we started to make this transition to look at mental health through resilience. And without going into a lot of details, what our resilience program entailed, we were able to demonstrate year after year that the more resilient our employees were, the more engaged they were in work and the more included they felt in their team. And along that same timeline, we were started to work in something called Care for People, which was really an intentional demonstration of caring for our employees. And we looked at things like the working environment, leadership, some intangible things around respect and dignity and autonomy. And we found over every survey that we did across all of the globe that the more our employees felt cared for, the more engaged they were, the more productive they were, by about 2 times the average Shell productivity metric. So and the safer they were working. And so we were putting all this together and realizing, focusing on the individual employee as well as the organization and the organizational culture and organizational factors was really critical for us. And so we took some time to go through the scientific literature, understand what we were seeing from our own data, and we built over time what we have now in the mental well-being space. We started a pilot a few years ago. We had about 6,000 participants across Shell. We were really interested in the feasibility of our plans for mental well-being. And we had real plans, not just concepts of plans. So we wanted to test those and see how effective they could be. We built it around 3 pillars. Okay. Promotion of good mental health, which we called our protect pillar. Our promote pillar. We had a protect pillar, which is protection of our employees against psychosocial stressors in the workplace, and an access pillar. So I think this is aligned with the messaging that came from UNICEF earlier, but we focus all of our work on promote, protect, and access. That pilot study was overwhelmingly successful. We did demonstrate that indeed we can measure as the first step of a survey. We can have a toolkit that sits behind that is all about mindsets and behaviors and how we can adapt to change, how we can handle the constant churn in corporate America and in our personal lives. And we were able to show that we can have a data-driven program that can be effective for employees and for the business. But we also realized we were not going to be able to roll it out in our 80 or 90,000 person organization with our small health function. So we decided we were going to have our global rollout. We partnered with our vendor, Wellaba, to meet all of our data privacy requirements, all of the data collection requirements, and we rolled our program out in November of 2023. So it's still new. What I'm about to tell you is fairly preliminary, although we do have 25,000 respondents. So we have a survey of 25,000 respondents that points to our toolkit. And what we've seen in the first cut of data is that the organizational factors are split. 3 are the highest scoring constructs in our survey. 3 are the lowest of the 4 lowest scoring constructs. So the role of organizational culture cannot be undermined and underestimated, because in light of everything that's happening, we still see really, really positive results organizationally. The next piece is about relationships, which surprised me a bit because we saw relationships, one of the strongest scoring constructs that we've seen. Relationships at work, relationships with your boss, being free of harassment and free of strain. Even when looking at predictors of adverse mental health outcomes, relationships at work can be protective against adverse outcomes. So we really wanted to focus on the strength of our relationships at Shell and get that across to our senior leadership. We're doing something right in the relationship space that's helping our employees. And the third thing, to go back to what someone else said here, I think everybody actually, the role of stigma. One of the highest scoring questions across all the 25,000 respondents was about the role a manager would play and the belief that a manager will be supportive in light of a mental health event. One of the lowest scoring questions was the willingness to talk about a mental health event. So we have this disconnect where we know the vast majority of our employees feel their managers will support them, and the vast majority will not talk about it. So we have a gap that we need to address. And that's going to come from time, organizational culture, everything that we do. And I just want to make one closing point. I'm asked very frequently about the ability for small and medium-sized companies to do what we're doing, because we are a massive organization. And what I say is, we started very small, individually focused programs. We built our business case over time. That does not take a massive company to do that. Our health function is extraordinarily small, extraordinarily mighty, and we're able to accomplish a lot. And none of this could be done without all the years of dedication from our entire health team at Shell. So I don't want to discourage the small and medium-sized companies and the leaders of those, because it absolutely can be accomplished.
Yeah, thanks, Crystal. I want to double click on one thing that you brought out, which is the importance of manager training, because managers are part of that leadership support, and the importance of leaders modeling that it's okay to talk about it. Those stories are really critical. So Peter Axel Blodson, Senior Vice President for GN Group. Thanks, Peter. I tried really hard. Peter Axel, your company has been around for a while, just a little bit younger than maybe this country, 155 years. You created a whole new business unit, BrainWorks, that is focused on holistic health, and you're connecting your product and services to a broader proposition and public education effort around the role that hearing plays in our brain health. So important. Can you tell us why GN Group made this bet, and maybe a little of the science around hearing loss and the work environment and cognitive load?
Absolutely, and first and foremost, we're doing this because it makes sense. It's obviously a topic that deserves more attention. And we are committed as a global employer for protecting the workplace brain health, obviously, but we also believe that we are uniquely positioned to make an impact because of our technology and our presence in hearing health. There's a growing pool of evidence that shows how hearing loss is perhaps the highest modifiable risk factor for dementia. Well published and still evolving data. And we also see new evidence that suggests that a hearing aid can actually be a really important intervention for those at risk, potentially reducing cognitive decline by upwards 40–48%. Outcomes measures that really can be benchmarked against some of the highest aspirations among the pharmaceutical technologies, I would argue. And then there's also something which is incredible. Research that shows how we can use the human voice as a digital biomarker, if you will, for us to understand much earlier indications on people's health, for instance, cognitive decline. So we, as a technology company with a 155-year-old history in sound and communication, have dedicated a lot of resources and focus in trying to understand how we can triangulate between the science of how hearing loss is impacting our cognitive health, but also how we can use the vocal biomarker. And GN is a company that are developing amazing hearing aid technology. We have millions and millions of installed units, but we are also working on enterprise headset technologies. And if any of you occasionally work from home, chances are that you are using one of our devices. And now we are talking about tens of millions of installed units that potentially can help people understand, how their daily work is being impacted by how they are communicating. And we're also going even deeper into the science on cognitive load and how we can help alleviate that by providing even more individualized sound. So basically just combining the hearing aid technology and making it available to consumers and people who work at large corporations. The Brainwork initiative and the team that we have built back home is a team that work exclusively what we call above brand. So I've unlearned myself, if you will, to talk about our brands. We talk about the topic. We talk about how we can use new technology in making a huge impact globally. We are making this available without talking about our brands so that our partners who are prescribing our hearing aids, they can use it agnostically regardless of what hearing aid that they prescribe to the individual patient. The communications platform that we are developing, we call Listen to This. For those of you who are curious, you can visit listentothis.com, and you will see that what I've just said is setting up a platform that everyone can use open source. All of the information and content that we have built together with partners, and we are making that a one-stop shop to unlock and improve the access to information and awareness around that critical interface between hearing loss, sound, and then cognitive health.
White label and open source, I'd say that's a challenge for all of us to make this happen. So if we could shift a little bit to measurement, because tying this to business outcomes and the bottom line is important for many employers to understand why this is an area they should be paying attention to. Crystal, I'll go to you first. Can you tell us the value proposition for Shell in addressing brain health and utilizing the HERO scorecard?
Yeah, sure. So I think over time, you know, it was initially, we were reviewing sort of our holistic approach to health, or definitely when it was traditional health promotion, as the right thing to do. And I think we've shifted that to the right thing to do that also drives business outcomes. And one of the things we know, we have a purpose within Shell Health, is in part to empower people and the business to thrive. And Shell's purpose overall is to power progress, in part. There's a much longer part of that. But to achieve both of those, people really need to be at their best. And for us, we have to be able to measure that against business metrics, other metrics, and some benchmarking. So we've completed the HERO scorecard for several years. We just recently completed it again, because we need to be able to monitor our success. And the scorecard, no matter how much we think great stuff we think we're doing, and the organizational leadership support that we see comes through quantitatively in that scorecard. But there are always areas of opportunity. And one of those things that pops up again and again in all the scorecard measurements is the need to reach beyond just the employees and to their families and communities. And we do that work. I think we probably have an area where we can do more in that space. But that being said, you know, our scores were more than twice the national average that was provided to us in all of the sub-scores and the overall HERO scorecard. So I think as a function, as an entire organization, we should be very proud of the work that we're doing.
Absolutely, you should. So if you indulge me, one more question on the scorecard. James, how has your team utilized the HERO scorecard and the brain health best practice score, and are these useful to your organization?
Absolutely, and I guess let me hit on the HERO scorecard first of all, then I'll touch just a little bit on some ROI stuff as well. But so the HERO scorecard helps a lot with kind of, to the point made earlier, benchmarking. Are we making progress? Are we setting aspirational goals? How are we doing? How are we relative to other companies? All those things, I think it's critically important. But it is one data input into a whole host of other things that we look at. And one of the things, I've got, 5 actuaries on my team that can comb over a whole bunch of data. And they'll tell you when you're going through it, especially on brain health type things, you can, it's very hard to say, here's exactly the ROI in some of these things. There's things we can get into. You've really got to have a commitment as a business that says, this is the right thing to do. And you've got to start from that premise. And if you don't have that premise, because you will be able to pick a whole bunch of data to bits and say, yeah, in the short term. I'll give you a perfect example. We opened up our network here in the United States because we noticed, and I haven't seen many employers do this. In fact, I haven't seen any other employer do it, but it was a huge investment. We said any mental health provider, because when you looked at the provider networks for mental health here in the United States, it was, generally speaking, I'm making a general statement here, it was the C- providers that were in. The Bs and As were out of network. They said, I get $200 an hour reimbursement. I'm not going to take $75 an hour. I'm out of network. So we opened that up and said, as long as you're licensed, you can come on in. That was a huge cost right out the gate. And we had to get a lot of commitment to do that. The ROI in that immediately, it could take years. It could take 10 years before you get a really good, but it was the right thing to do. And see, when things happened like the pandemic, and there was a whole bunch of racial tension, and there was a whole bunch of stuff that was happening with George Floyd, there was stuff that happened Asian Pacific Islanders. I can't tell you the number of employees that walked into my office and said, thank you, because I've brought somebody that looks just like me into network, that's a psychologist, a psychiatrist, and now I can talk to somebody that's just like me, not this little narrow network with a C- provider in it. That was a huge investment. So my point is, you've got to look outside. Here is an absolutely great benchmark, but it's way, way broader than that. And some things are strong ROIs, some of the sleep study stuff we've got, some of the productivity around that, fantastic, strong ROIs, high productivity. There's other stuff like investment in network, which may take a decade for us to get that investment back. And it's very hard to get the relationship between a strong ROI financially on that, but it's the right thing to do, and it will create resiliency going forward, and that's really what was our high ground.
We might have to do another panel later on the case for the chief financial officer to agree with some of your thinking. So that's awesome. Peter, we're here at the invitation of the Business Collaborative on Brain Health, one of the hosts here, and GN Group is a founding partner. Hero is also a member, but Peter, Axel, if you could tell us about why you are helping to support and lead this effort aimed at engaging business leaders in brain health.
It's actually I think it's quite simple, because I think it's clear to everyone. We can also see by the diversity of participants in meetings like this that this is a topic and a challenge that will require a multidisciplinary approach. And the promise of new technology and science is something that can be unlocked if we manage to find ways of collaborating. And as a company, we have already gotten so much benefit by meeting amazing people and organizations in that specific initiative. And I just believe that this is something that is the right thing to do, but it's also certainly something that is good for business. Something that will help improve our productivity, performance, well-being, and that channels right down to the bottom line.
Yeah. Brian, you had some adjectives to describe lawyering earlier. It's a cognitive sport. That's how I'll frame it. How have you been able to track your commitment to mental health with your business competitiveness and ROI?
Yeah, the two big things is we talk to our employees about it, and we talk to our clients about it. And I'm glad that one of our clients is actually sitting on the stage with us, so that's a great thing. But in terms of talking to employees, firstly you have to ask your employees relevant questions in this area. You have to compile the data, and most importantly, you have to act on that data. And you have to track what are the trends. Are stresses going up? Do they feel supported? Things like that, and particularly at a time like a merger for us, which can be a stressful event, to focus as an opportunity. And one of the key drivers we find, we're a professional services organization, and work allocation in a law firm is a very big issue. And I think one of the things we thought about is, are lawyers working too hard? Are they too stressed? And of course, there are a percentage of our lawyers that said that, and that's something we need to look at. But I think one of the things I hadn't really focused on as much is the stress on the other side, that some of our lawyers were not getting enough work or not getting the best quality work. So when we really have a commitment on objective work allocation, and to make sure that people get a variety of work, they're able to say what kind of work they want to get, so all our lawyers get the opportunity to learn and to train and to show their skills. And as I say, we also have brought our clients into these discussions as well. And I've been surprised how many of our clients actually want to talk to us about these issues. And they talk about their experiences working with us, and so we can kind of get best practices from each other, rather than just that we're a service provider to create a product for them.
That's a really great model. So David, connecting the dot, is it possible to connect the dots between brain health, performance, and business outcomes? And if so, what does that look like in a large organization?
Well, look, we have to be realistic. I think that's very challenging, but it's doable. I'm a neurologist and a biomedical informaticist by training. I love measuring. You can't manage what you don't measure. On the flip side, I'm in visceral alignment with James, who said that, at the end of the day, it's the right thing to do. We have studies that have demonstrated the link between mental health and performance and business outcomes. So if we all, our organizations spend our time trying to internally recreate those studies, we're missing the point, right? But on the flip side, again, back to the original point, it's our job to manage it, and we look at process and we look at outcomes. So, just to get really specific, our mental health benefit, so great benefit. We provide access to licensed mental health therapists who are practicing evidence-based care. We subsidize that to the tune of 16 free visits per employee per year, and it's anecdotally been great. But we want to know, how is that impacting business outcomes? So, we measure, we look at utilization of the benefit. We look at net promoter score, our employees' experience of the benefit. But we don't stop there. We look at how our benefits impact total cost of care. So in this particular case, we ran an observational study, a matched, I think this is a geeky audience, so I'll say, it's a propensity score matched cohort analysis, utilizers, non-utilizers, matched on a bunch of confounders. And we found indeed that those who utilized this mental health service had a 27% reduction in total cost of care. Not bad. And then we look at the actual individual level data and find that those who've had 2 or more PHQ-9 measures, this is a common measure of depression, 80% of those show improvement over time. And we've reduced the median time to accessing the service from somewhere on the order of 6 weeks to a median of 6 days. So just to illustrate, those are very tangible measurements, some linked to outcomes, some more process-oriented. And then what we do is we zoom out and we survey our population on whether their benefits improved their productivity or affected their decision to take a job at the firm or stay at the firm. And indeed, we find that the overwhelming majority of our population say, yes, indeed, benefits do impact their taking a job, remaining in their job, being more productive in their job. So, correlation is not causation. We don't run RCTs, but I think that collectively we can demonstrate that the work that we do does have impact, not just on our individuals, but on business outcomes, and that's what we need to keep rolling the ball forward.
We need to keep doing that. So we need partners for data and research and funding to continue to raise the bar on this. We're not going to take audience questions. Lunch is right after this, so I encourage you to grab the panelists that you have questions for. So I have one final question for our speed round to wrap it all up. As we wrap up, imagine it's 5 years from now, so 2030-ish, and you've successfully implemented the most innovative and impactful brain health strategy imaginable. What is one unexpected yet profound change that you've noticed in company culture, but also business outcomes as a result, and how might it reshape the future of work for the better? You want to go first, Peter?
Oh yeah, it's hard to choose. There's a lot of things here, and I gotta admit I'm a tech geek, and I work in a technology company, and there's all sorts of techy stuff that we are working on that I really hope will be progressed in 5 years' time to do amazing things. But I'm gonna come back to something else, and that's the stigma. The hearing aid industry, in the first place, is battling stigma every single day. That is one of the things that get me out of bed every single morning to see if we can ensure that more than just 1 in 5 people with a hearing loss actually have a hearing aid. But I think that when we talk about brain health, we face, as a community, we face that same challenge. And in 5 years' time, I honestly think stigma will have I think stigma will be reduced significantly in 5 years' time. And I think that we are on the right track to do that. And I think it's just such an important fundamental for progressing as a community.
That would be amazing. Crystal, you want to go next?
Peter stole my answer. No, it's fine. I think because of the data and the results that we're seeing around stigma, we have to lessen that gap. I mean, we know people are comfortable believing that their managers will help, but they're totally unwilling to talk about it. And we have to shift that. the stigma that's around it, the impact it has on long-term health, we have to do better. As an organization, as a society, we have to do better.
It's okay to repeat that, I'm sorry.
So I'm really optimistic on the aspect of leadership, skill, commitment, and what it takes to be a leader going forward. You need to have the ability to be able to tap into this whole notion of financial, mental health, mental agility, all that piece of it. So I'm optimistic if we fast forward 5 years, the awareness that's being created, the leadership bandwidth that's being created for leaders in an enterprise to be able to tackle these issues. And then I think you couple that with where technology is going on digital therapy, even in some aspects of that care continuum using robotics for loneliness and some other things, I think we'll fast forward and we'll see a couple there of awareness, leadership bandwidth, and leveraging technology on the care continuum.
I hope you're right. Brian?
I'm an employment lawyer by training, so the thing I would like would be if the way managers or partners are assessed this is one of the things that people talk about. How are they working with their teams? How are they focusing on their teams, brain health and mental health? If it just becomes part of an ordinary way that you're evaluated, that it's not just about, how much you produce or financial metrics, that it's just one of the things that is regularly talked about in an HR perspective.
KPIs. David, you get the last word.
There's a progression of innovation, from life sciences, R&D, to FDA approval in this country, to insurance reimbursement, and then we, who all are in the care delivery business, get to deploy these innovations to our workforce. If we're doing our jobs, 165 million Americans get their insurance through their employer. Collectively, we are responsible for purchasing a whole lot of health care. So if we as employers can do a better job of holistically attending to whole person health, inclusive of brain health, then we can demonstrate a different way. And that can be fed back into life sciences R&D, and we can develop better treatments, more holistic therapeutics for Alzheimer's, for depression, for other brain health disorders. And that's why I think we have an important healthcare role to play as employers.
Thank you so much for showing how businesses are actually already doing and modeling, and I hope it has inspired others of you in the room and online to think about what can be added to the strategy, what can be done next. It's that next step that's important that leads to the next one. Please help me to thank our panel.
Well, thank you very much, Karen. Thank you very much to the panelists. It's now time for lunch, but as we are running a little bit out of time, and as we realized you were extremely mindful to have enough time for your lunch break, we propose to reconvene at 2:10 in this room. So if you promise to be on time, we can extend it slightly. So please get your seat at 2:10. Thank you. Sorry, what's your name?
Tommy.
Tommy. Name of your colleague?
Fred.
Fred. Oh, okay. Nice first name. Okay. Is it on? Yeah, you good to go? Okay. Okay, folks. As promised, now it's time to get back to your seats. You made a commitment before lunch. I just hope it was enjoyable. Apparently, a little bit too much, if I can hear from the background noise. And you can blame Tommy, and please give a round of applause for Tommy, who is helping us out. just to check who is listening. Okay. And Fred, who is in the background. So they're helping me to not having to shout, even though I'm shouting in order to make you bring back to silence. So please go and grab a seat. If you'd like to continue the conversation, as we said, please go to another floor to hijack the other meetings organized at Cure today. So we will start our first panel of this afternoon on the topic of implementing innovation in brain health across sectors. So this is, well, if even the panelists are making noise, I mean, we're never going to, I mean, whom did you invite? Oh, okay, well. Well, be careful, your mic may be on, so it's, all right. So our panel is going to be on implementing innovation in brain health across sectors and taking examples from business, philanthropy, and government. This panel is moderated by Casey Kelly. Casey is the Chief Innovation Officer at Meadows, Meadows being one of our co-conveners today for this event. So Casey, you have the floor.
Good afternoon. I'm excited to be the first session after lunch, after an energizing morning. I'd like to invite Andy Keller, who's the CEO of the Meadows Institute, to come on stage and to set us up for a panel discussion that will follow it with a bit of a visioning keynote for us, and then we'll have the panelists join on stage.
And thanks, Fred, for getting everybody corralled. It's always fun after lunch to be the first speaker, but you did a great job. Everybody's so quiet, so thank you for this. So some of y'all I met this morning, and I just want to give a little bit of a background and a frame for why we're so excited about the folks who are joining us here for this panel. So I mentioned this morning that the mental health system we're in right now, and I'm focusing just on mental health care, primarily, as we talked about this morning, these are pediatric illnesses, and our children and our young adults are waiting, like we said, almost a decade before they get care. And a lot of us are focused in our research and in our work about how do we make that care better, how do we find ways of getting people better access to care. But one of the real problems is we have these structural barriers that get in the way of the most well-intentioned efforts. And so our name, the Meadows Mental Health Policy Institute, comes from the Meadows family. So the Meadows family are an unusual family in Texas because they were involved in oil production. I don't know if folks are familiar with this, but Texas has something to do with oil production, which I know Harris wanted me to focus on clean energy, but for now you need to use some of our energy too. So we'll just focus on that. And so Alger Meadows was one of the early folks in Texas who in the 30s was able in East Texas and then out in Midland to be able to, get the things that drive your cars and power the other stuff there. And so Alger felt that the best way to take this wealth was actually not to give it to his children, which was somewhat to his children's dismay, and I've never actually met well, I met one of his children, but was to give it to the people of Texas. And so the Meadows Foundation is really the only foundation in Texas that gives statewide and is dedicated only to the well-being of the people in Texas. The other thing that's not unusual, because that was a joke, it's not unusual to be affiliated with oil in Texas, just in case you didn't follow me there. The other thing that's not unusual about the Meadows family is as a large family, they have a lot of impact with mental illness in their family, like all of our families do, like I do, like many of the people I love. As more than 50% of us will in our lifetime. And so the Meadows family at first, because they started in the 40s and 50s, didn't want to talk about this because that was where we all were, right, in the 60s, 70s. It really wasn't until the third generation of leadership in the foundation, under Linda Perryman Evans, who was their CEO and whose name I hold as part of my title, that the family decided that they're going to do something about that. And they really decided because Linda decided they were going to do something about it. So they gave for 10 years in the area of mental health, gave almost $50 million. And what they found was that the grants they were getting at the end of that, giving away at the end of that 10-year period were exactly the same grants that they were giving at the beginning. And they were for things like vans. And they're sort of like, vans? Like, you need us to buy you a van. Like, how is that not something that someone else should be paying for? And so what they did was they stepped back and they said, are there systemic issues? Should we be getting to look at systems? And that's really what gave rise to our institute, the Meadows Institute. And as I mentioned this morning, we're really trying to focus on the systemic factors that don't just need to be advanced, but need to be broken down and disrupted, because the systemic factors that are getting in the way are actually quite robust. So that's why I'm so excited about this panel, because as I said this morning, and again, Fred, thank you for getting people from all over the world, but just as importantly, all over Texas, I'm sorry. Sometimes I call the United States Texas, but really, we're not all Texas. I mean, we are all eventually will be Texans, but at this point, I'm sorry. But because we're all going to join you in that, and I think getting us together in this period is important, because we're not going to be able to do these things on our own. And we're not going to be able to do these things on our own with just mental health. We're going to have to be joining that with our other brain health colleagues. But we also need to disrupt. So we're going to focus on, in this talk, 3 disruptive levers. One of which is the business community, the private sector, which is doing a lot. And also, they're the ones providing health insurance for most people in this country. So they're the ones making sure they're buying that health care, which in most cases for mental health is subpar. Second group is the investment community, private investment community, that's trying to bring, alongside philanthropy, private dollars to bear to catalyze change. And then also the newest player in this, which I'm very excited about and very appreciative to the Biden administration for making possible, is the Advanced Research Project Administration for Health, ARPA-H, which is an amazing group that is basically doing what I think people wouldn't have naturally thought could be done: government leading innovation, and doing it by being able to make big bets on things that are going to be not just disruptive, but constructive. So we're going to have folks coming up here in a sec. Casey will introduce them, and we're going to put some real world examples out and hear where each of them are coming from, because you all, as our partners and soon to be partners and hopefully future partners, need to know these people. And you need to feel able and empowered to partner with these forces, with whatever silo you're in, whatever group you're in that's not a silo, whatever collaborative you have, because we have to build bigger collaboratives. And I want to just give you one example for why this is so important and what I think the potential is. And that's the example of primary care-based mental health, what we sometimes call integrated mental health care. So, you know, cancer care and heart disease care, we're doing a lot better on, you know, and we have, by which I mean fewer people die every year than the year before. We're doing the opposite of mental health. And when I tell people that I'd like mental health care to be more like health care, what I really mean is I want it to be only as bad as the rest of health care. Because health care is not great, right? I mean, but at least we're killing fewer people in the heart disease category and the cancer category than we are in mental health. And in mental health, we're not. You know, we were really happy a couple years ago because we'd killed only the same number as the year before. But now even that's starting to creep back up. And we're starting to lose people to suicide in groups that previously we had not seen that in, like African-American young men, and women's rates coming up to be able to be in some ways comparable to what men had had before. So we're not doing a great job. And so the way that we got ahead of these other diseases was to actually detect sooner. And how do you detect sooner? Well, yeah, schools can be good. Schools are a great place to find needs. But if you really want to detect sooner, you're going to have to go, as the U.S. Preventive Task Force recommends, at age 8, to be checking in with every child in their wellness checkups to see if they're suffering from anxiety. And guess what? Other mental illnesses that can develop earlier in life look a lot like anxiety earlier on. And so if we're tracking little Andy, I have an anxiety disorder. If my folks have been able to bring me in when I was 8 years old, my mom would have had some help dealing with little Andy, who was not always easy to deal with, and being able to be there alongside. So you know how long the technology has existed to know what to do in primary care? Over 30 years. We've had 90 randomized controlled trials, over 90, that have shown that something called collaborative care works better than care delivered outside the office. And other ones like person-centered behavioral health, patient-centered behavioral health, the variations of that. All of these approaches are not just as effective and sometimes more effective, but they're also a much better deployment of our resources. So a psychologist who's in a PCBH clinic is going to be able to serve 2 to 3 times as many people. A psychiatrist we've seen in a collaborative care clinic can serve almost 8 times as many people. So why? It's not just that this has been around for 30 years, it's also been paid for by Medicare for almost 10 years. And it's been paid for by insurance companies with pretty actually decent rates since 2019. A decent, you know, put an asterisk by decent. Less bad than some other rates, maybe that's what I actually mean. So what's the reason we're not doing it? The reason we're not doing it is because we haven't been able to disrupt the practices and be able to create the pathways to build the capital we need to deploy additional resources, because it takes capital. And it also takes things like disruptive technology. So that's what we're going to hear about in this panel. And we're super excited. We've been able in the last few years with philanthropy and industry working together to have health systems in Texas, almost 20 of them serving almost 7 million people, be able to make this conversion. And we're looking at now, how do we take this to other parts of the country? We have Northwestern University just had a big investment from West Health to be able to do this. Work closely with our friends at McKinsey to be able to figure out some of that. And there's some really neat things happening, but we have to accelerate them. So this panel is about acceleration. I think you're going to hear some wonderful things. So I'm actually going to be quiet and let my friend Casey come up and tell you about these wonderful people as they begin to walk up. So friends, come this way. Actually, there's a stair over here if you don't want to make the big leap, but it's not actually, you might want to make the big leap. You're big leapers, you can do it.
Thank you, Andy. Thank you, Andy. So I'm going to use the podium mic tech team, and then I'm going to sit down and use my lav mic. If you could help me successfully do that, that would be awesome. So I am Casey Kelly, the Chief Innovation Officer at the Meadows Institute. I love these events, and I generally don't like events. I've been to a lot of events in my 25-year career, but I love this event because it provides an opportunity for me to engage with people that I don't engage with on a regular basis. And I always come away from these types of events with a new perspective and a learning. And I think that's really important for us to think about as part of our collective goals for today. And that's what we were hoping to demonstrate in this panel. As innovators, we often think about innovation as something that needs to be discovered, something novel or new. At the Meadows Institute, we know that innovation also includes trying things in new ways so that things that work today for some can be scaled so that more people can access them. We also know that scaling innovative solutions is hard and complex and requires many stakeholders coming together. And oftentimes, when we're doing it right, new stakeholders with different perspectives who help us see things through a different lens that we haven't seen in the past. So today's panel, I'm delighted to introduce you to. So first, all the way to the right, the gentleman, we have John Bailey, who's the founder of Vestigo Partners and an advisor to Fiore Ventures. And John wears many hats, which is one of the reasons that I really enjoy working with him, because he brings to the table multiple different perspectives whenever we're debating or discussing a new challenge or a new opportunity. We also have Shirley Bergen, who, as Andy mentioned, is here in her new role as portfolio lead for the new Project Accelerator Transition Innovation Office in ARPA-H. And Shirley's learning all sorts of new perspectives right now, as having worked in the private sector all of her career until about 3 months ago, when she raised her hand to serve as a public official for ARPA-H. And then finally, we have Katie Uter, who is the Chief Operating Officer and Chief Financial Officer for the Florida Chamber of Commerce. And Katie comes with a variety of commercial enterprise perspectives in her background, as well as someone who I would put up against anyone with taking on a physical challenge that no one else would even think of taking on. So I would encourage you to talk to her about that after the panel. So this panel will showcase unique ways that leaders across the United States are collaborating across sectors. We'll delve into the connection between business, policy, and brain health, and we'll emphasize the true need for all of us to think and try things that are not currently being utilized, and to evolve our approaches in solving some of the complex problems that have been discussed today so far and will be discussed tomorrow. So can we give our panel a round of applause again? So team, we talk a lot about the problem of mental health, and the various problem statements have been presented today. But I'd like to kick off this question with you, Katie, and just like, why did the Chamber think about wanting to create a business-led, the first ever business-led strategy for mental health for the state of Florida?
Yeah, no, thank you so much, Casey, and it's an honor to be up here with both of you. So the Florida Chamber of Commerce, we see ourselves as the driving force for Florida's future and the leading voice of business in the private sector. So when we look at what our goals are, it is global competitiveness, it's prosperity and high-paying jobs, as well as vibrant and resilient communities. So just sort of setting that as sort of our high mission and sort of where we set our priorities. I mean, mental health is certainly an underpinning of all of that we talk about. So just for a greater, context to that, probably about 4 years ago, we put a significant amount of dollars, a couple $1 million, into a research report on where was the world going to be in 2030, where was North America going to be in 2030. So where did Florida need to be in 2030 to be the 10th largest economy in the world? So right now we're 16th. If we want to get to the 10th largest economy, what does that mean? That built out our 6-pillar framework and 39 goals. So you can actually go to thefloridascorecard.org, and every single one of those goals are on there in metric form that are continuously updated in real time. And you can actually go down to county level as well on that. And so that's really sort of how we set our true north. So one of those 39 goals is being the top 5 state for overall well-being, but it also has goals on there about solving childhood poverty, 3rd grade reading scores, kindergarten readiness. And so we take that down to the community level, and a lot of these solutions happen at the community level. When we look at our Florida Gap map, we can see every single zip code in the state of Florida, how many kids are living in poverty in that zip code, how many elementary schools and how many kids can't read at 3rd grade reading level within those schools. And what we do is we unite the business community for good in Florida to solve these issues and these problems through the private sector. And so trying to get to the top 5 state for overall well-being, we created the Florida Chamber Leadership Cabinet on safety, health, and sustainability. Our Safety Council is in the field doing safety trainings every day, OSHA and forklift, tactical safety trainings, if you will. Our Health Council is focused on long-term systemic issues that if we don't start addressing, we won't be able to train our way out of. So this is where our mental health initiative comes in, overdoses, preventative health programs, because we can't get to safest if we're not healthiest. And then we have an entire sustainability initiative under this on cleaner air, cleaner water, and cleaner land. So all of these initiatives and goals need to be met to ultimately reach our goal of 10th largest economy by 2030.
Thank you. Katie and I first bonded when she introduced herself and started talking about metrics and outcomes immediately. So I really, really enjoy sort of knowing that anything we're going to do together is grounded in how we're going to measure it. So John, I'm going to kick it over to you because you spend a lot of time thinking about what is the role of philanthropy versus the role of your traditional investor. And can you speak a little bit to what role you think philanthropy can play in catalyzing innovation and really thinking about accelerating innovations that exist today?
No, it's great. So great to be with all of you today, too. I think Andy set the table nicely that, I mean, we're facing huge systems barriers, very entrenched, and the only way you're going to change that is by systemic reform. And I mean, just a little context, I work for a wonderful leader, Carrie Walton-Penner. She's on the board of Stanford and the owner of the Denver Broncos. But she's been very moved by the youth mental health crisis and wants to make sure that we're addressing sort of the systemic challenges, but also creating systemic reforms in this space too. And one of the best things about Carrie is that she's really using flexible capital because it's different tools in the toolbox. We have a venture arm that's called Fiore Ventures, and it lets us invest in really promising and incredible innovations and entrepreneurs. We have Hazel Health that's here, some other great startups that are just tackling different facets of the mental health challenge. But the other thing is, like, we know it's not just going to be venture. And so we use our philanthropic arm to take on some of those system barriers. And we do a lot of that through policy work, with partnership with the Meadows Institute, with the Kennedy Forum, with Inseparable. We support the Child Mind Institute, which I know is part of this as well, because they're doing some cutting edge research, but also helping governors and a lot of other stakeholders with communicating some of these mental health resources and needs. And then we're also using it as a way of helping to just set the table for a lot of the system reforms as well. That's through conference sponsorships. We just did Rock Health last week. It's through landscape reviews. We have a philosophy of a lot of times, and Carrie and I have been in education and philanthropy for a number of years. The playbook has always been to sort of hire consultants. They come in and they give you a really good plan, but it just benefits you as an organization. It doesn't benefit anyone else. And so a lot of our work is really trying to lift up the whole sector and lift up the barriers, help make sure that other investors and philanthropists are informed so that they can deploy their strategies in a way that's targeted and going to be systemic and hopefully catalytic as well. So.
Thank you. And Shirley, I'd love for you to shed some light on, now that you are officially in ARPA-H, what is the unique role that ARPA-H is playing within the government agencies, and what has convinced you to raise your hand to want to lead in that organization?
Thank you. That's a great setup. You know, look, my whole world, my whole life has been about impact. I think I just kind of follow where I think I can make the biggest difference. It's always been kind of part of who I am. I had the opportunity to join ARPA-H about a year ago as a contractor. So I was a senior advisor to the Project Accelerator Technology Innovation Office, PATIO is what we call it, which is very connected to transitioning ideas out of the science in beyond translation and into industry or into the patient, making sure that whatever is being worked on actually has a real plan to reach the patient. And so I had the opportunity for a year to kind of experience what it was like to be in the government, but be a contractor. And with that role, I was able to do a lot, but as a federal employee, I'm able to do more. And I'm able to make and influence more decisions and be able to make more of an impact. So definitely a personal decision in terms of wanting to make an impact. When I think about what makes ARPA-H unique, I mean, I'm unique. I don't fit the mold. I'm not from DARPA. I haven't been 20, 30 years in the government. I look very different than a lot of the government employees. And that's a testament to the way ARPA-H is being led, the way ARPA-H thinks about its impact. I think when Andy set this up in terms of collaboration, almost everything about ARPA-H is sitting in the realm of collaboration. So we are a problem-focused, program manager-driven organization. So what that means is the individuals who have these big, bold, audacious ideas, and they don't actually see a pathway in traditional funding models to ever be able to get it off the ground. ARPA-H is the place to come. This is non-dilutive funding. It's an opportunity for you to come in and take a program from beginning to end to be able to influence areas that you wouldn't normally be able to influence. A program manager has the opportunity then to take that program, and when it is ready to be transitioned, we think about transition from the very beginning. It will go through the Project Accelerator Technology Innovation Office. We will make sure from the very beginning that we're thinking about how it's going to reach the patient. So from a unique perspective, that's a big part of it. The other part is we're really big about a network. We're building a huge innovation network. It's called ARPANET-H. It is built around 3 hubs. We have a hub in Cambridge, Massachusetts, which is our Investor Catalyst hub. We have a customer experience hub, which is in Dallas, Texas. And of course, we have our headquarters in Washington, DC. But the expectation is that we are using those hubs to connect with other entities as spokes and building this huge hub and spoke model of health innovation so that as these program managers have created these incredible opportunities for advancement, we already have this built-in innovation network for them to connect to and for them to be able to help catalyze their programs quicker, more efficiently, and therefore meet the patient more efficiently.
Great. I'm sure lots of people are going to want to talk to you afterwards. I hope you're able to stick around. So it's really great to talk about the innovative work you're doing at a conceptual level, and all of you are leading from your positions in really unique ways. But I'd like to now sort of dive in a little bit and get really concrete with some of the things that you're doing so that people can have real grounded examples of the work that you're doing and how that plays out in your everyday lives. So John, can you talk a little bit more about the work that you're doing in Colorado on youth mental health and how your and Carrie's vision for addressing the youth mental health needs in the state of Colorado, how you're thinking about that, and then what you're actually doing about it?
Sure. Yeah, again, we're new to this area. So, I mean, we've been actively making grants and investments for the last 3 years, but we also recognize, so we're trying to approach a lot of this with humility, that there are giants in the field. Many of them have been on stage today, and we're trying to learn from them in terms of what's worked and what hasn't worked in the past, and just be respectful. And that's particularly true in Colorado, that Carrie just recently relocated to Colorado, and we've wanted to know, you know, just what are the strengths in Colorado? What are the assets they have in place to tackle youth mental health? And then where are some of the gaps? Where are some of the challenges? And as opposed to just start going in and blindly making philanthropic grants or other investments that may duplicate what's already been done, may replicate past mistakes, and also miss opportunities to close gaps or address some of the systemic challenges. And so we're working with the Meadows, with Casey and the Meadows Health Policy Institute team to essentially do that, to do just a large landscaping analysis of what's going on in Colorado. What are the strengths and what are the assets that can be built upon, and what are the gaps? And again, just a strong commitment to not just informing us, but hopefully informing a lot of the other philanthropic players in the state, and also hopefully attract support for some of the catalytic changes that we need in a policy area, as well as some of the innovators and entrepreneurs that are trying to make solutions more scaled to better serve kids across the state as well.
And it's really fun working with John and the team at Fiore Ventures, is because they are so invested in learning and making sure that they are smarter than they are today. And it doesn't really seem like any amount of information I can give him is enough, which I really do love that about you. I know, it's just such a refreshing partnership to have a funder who is as interested in really understanding and learning so that you can use your perch to make sure that we're collectively making the best decisions that we have available to us with the information that we have today. And so I just really, really appreciate the desire for more information. Can you talk a little bit about some of the conversations we've had about the differences? I mean, Colorado is not as big as Texas, but we have talked a little bit about the differences in the urban areas versus the Western Slope, and how you guys are starting to think about that.
No, I mean, just Colorado, like a lot of states, has very distinct regions. You know, the needs in Denver as a major urban center are very different than the Western Slopes and rural. And there are just vast areas of Colorado that even if you wanted to scale some services, it would just be too difficult. And that's where innovation comes into play, especially with telehealth and teletherapy. But again, that's also where setting the table matters, and where we're trying to use some of our philanthropic support is how do you bring public policy players who may not know what innovations are out there, so they don't know what to build into their budgets, into their pieces of legislation or executive actions. How do you introduce them to these innovations so that they can use their public policy levers to help scale that? And it's going to look different. I think it's going to look different in different communities, communities of color, in rural areas. It's going to look different with low-income students. But we also know that mental health really crosses all classes, and it's going to need solutions that can scale for low-income children as well as for middle-class children as well. And so it's really, and Meadows has been great in just helping us understand the needs of the different regions, and also what the assets are that we can also deploy capital and resources to hopefully help build up the capacity and better serve children in those areas.
So Katie, let's flip it back over to Florida. A different region from Colorado, and a place that you've been thinking about how to scale solutions across the state. Can you talk a little bit more about how you're thinking about taking these strategies that we've recently released and deploying them for implementation and impact?
Yeah, so when we started looking at this issue, we're 49th out of 50th access to care in the state of Florida. When you look at the number of licensed mental health professionals in the state, we're 43rd out of 50th with the number of mental health professionals that we have in our state. When we look at it from sort of the business perspective, we have about 3.5 million organizations and companies in Florida. We represent about 10.7 million employed Floridians. So we insure commercially through the private sector more than half of the non-elderly individuals in Florida and 2 out of 5 children in the state of Florida. So this is, really sort of fundamentally why we're trying to approach this from a business-led perspective. 40%, I'll speak to, Colorado is not that much different in Florida. 40% of our youth and adolescents have some sort of mental health issue that can be identified as a mild to moderate symptom. A quarter of our adult population has a mild to moderate sort of mental health, need, and that's our workforce, right? So that's everybody that we need coming into our organizations, and I heard it from the business panel, on how do you create, I'm going to use the line that was used before, right? Sustainable high performance, I think is an excellent phrase, right? So if we talk about growing our economy and being competitive to become the 10th largest economy, it sort of comes down to that individual workforce level. And so when we sort of looked at that, there's so many drivers. And so it was sort of a real game changer for us to work with Dr. Keller and Casey on doing the first business-led mental health report for the state of Florida. And they're actually tremendous partners working with us on this. And we approached it very differently with Dr. Keller and Casey at a lot of the other reports that we do. We do child care reports, we do trade and logistics reports. There's a lot of work that comes out of our foundation. But what was different about this is we went out and did key stakeholder interviews. We looked at a lot of the static data across all the regions in the state. We did interviews with the healthcare industry, the payers or insureds, the private sector, the nonprofits, and what is everybody currently doing in the state of Florida that we could actually create a blueprint and a mechanism that everybody could see themselves in so they can actually play the role that they're passionate about and what they're already sort of making a difference in, but create alignment behind all of it. And so there's 25 recommendations that we launched this past May, and they're really broken into 3 categories: the employer-facing recommendations, we have domain-specific recommendations, and we have outcome-driven recommendations. Some of those are going to be much more longer term. We talk about breaking down systemic barriers and how stuff is being tracked on spending, whether that's through all of our government agencies, through nonprofits, the private sector, and then some of them on our employer-facing recommendations are sort of some immediate things that we can sort of start to tackle with the business community and with our government leaders in that regard. So there's definitely some short-term tactics that we're aligning behind. A lot of C-suite awareness. We heard that, and it was very validating, actually, to hear that when we talked about, stigma. Some things that I've learned from the Meadows Institute is if we talk about stigma, it actually reinforces it. But if we talk through the lens of hope and solutions, we can make a lot further headway just on that topic. So we're doing a lot of work on the C-suites, aligning the business community behind that, the nonprofits behind that, on some of the short-term tactics. And then we're really starting to put our policy agendas, our political agenda behind those recommendations that are more systemic changes that we need to see happen in Florida, so we can start to create some air, lack of a better term, some air in the system on some of this, especially on access and mental health professionals that are providing the access. And I can go through, a lot of data, a lot of dynamics, but that's sort of how we're approaching it.
Katie, where could people in the audience find the report if they were interested in looking at what those recommendations said and how you intend to take the initial steps and moving them forward?
Yep. So underneath the leadership cabinet, we have the Florida Chamber Health Council, and that is where we're building out. Our report can be found there in a PDF form, and that's where we're sort of aligning and building out all of the private sector best practices. I actually, heard that on the previous panel as well. As how do we share best practices amongst, our sort of leading companies that have this expertise in-house, and how do we create that hope, those best practices that actually can move down market to the mid to small size companies. And so that has really been sort of our hub on the Florida Chamber Health Council website, on where we are starting to really populate all of this and sort of be the go-to resource, all sort of fundamentally rooted in this report that we did in concert with Dr. Keller and Casey and the Meadows Policy Institute.
Yeah, and I would encourage you to check it out. when we started working with the chamber on this, we had a long track record of doing assessments, but this one was different, and because they were very interested in like what they could do now while we were working on those larger, longer-term goals. And so I'm really thankful again for the partnership and the collaboration, likewise with our partnership with John and team over in Colorado. So Shirley, you shared a little bit about how ARPA-H may be different from other government agencies, but this panel is really about cross-sector collaboration. And so can you talk a little bit about how you and the ARPA-H team are working across sector to drive innovation?
Yeah, absolutely. I want to address one thing too, though. Like I said, we're program manager driven. We've onboarded 20 program managers, which means there's 20 programs in our first 100 weeks. We are 100 weeks old last week. Who counts, right? We do, every single day. Because it's one day less to be able to make a difference. So we count the days. We just onboarded our first program manager in mental health. And it's been something we have been focused on since the beginning of ARPA-H. We are driven by the ideas that come to us from these program managers. So I'm going to reiterate, if you have an idea, you want to talk about potentially ARPA-H being the right place for it, we are so hungry for mental health and brain health innovation. So just know it's a real commitment by the agency. From a cross collaboration, I mean, it's kind of just inherent to who we are at this point. Most of you probably have heard of the Sprint for Women's Health. It was a pretty big initiative with the White House, the First Lady. We launched that in February and finished awarding about $100 million over the summer. So the program was a massive success because we had so much cross collaboration. The actual very first meeting, which inspired then the programs that drove that sprint, were done with a cross-sector, multidisciplinary group of individuals who came together to help really roll up our sleeves and identify what are the most pressing problems that aren't being funded in the traditional sources. They have to be what we call ARPA hard. They have to be transformative. They can't be incremental. And that's a hard thing sometimes to wrap your head around when incremental advancements matter too. We have a lot of capital going into incremental advancements. We actually need those transformative leaps. So that's what the Sprint for Mental Health was initiated for, was what could we do in 2 years? What would happen in 2 years if we were to identify what we thought were big, bold initiatives that could be cultivated within an ARPA-H environment in 2 ways. One, through kind of a what we call technical readiness levels 1 through 3, so kind of that earlier kind of still research space, and then those that are kind of 4 through 7, which are much more closer to being transitioned out and into the patient. So I call it as like 1 through 3 is kind of getting them across the starting line, and 4 through 7 is getting them across the finish line. And so when we looked at all the different ideas that came in, we were really blown away by how many of them were teaming efforts. So they were teaming with, it could be an entrepreneur who's teaming with an academic institution, who's teaming with a industry player, who's also teaming with a philanthropic nonprofit. It could be across sectors in terms of engineering and design and absolutely science. But it was really looking at all the different players that are going to be really required if these bold ideas are going to make a difference in our lives. So cross-collaboration, multidisciplinary collaboration, absolutely critical and something that ARPA-H is all in on. There will be other opportunities to collaborate as we continue to roll out programs as well. We're always going to be looking for what's that transition out and who are those partners? Are they healthcare systems, hospital systems, payers? Are they big tech companies? What will it look like to take this innovation and make sure that it absolutely reaches the patient and reaches the patient at scale, and with a foundational element of access and health equity? We're designing for the 99%, not the 1%.
Great, thank you. So now we have a few minutes for any Q&A that the audience might have, any questions the audience might have for the panel. So I'd like to open it up for a few minutes to the audience and see if there's any burning questions on your minds that you'd love to throw at this group.
Hi, I'm Susan Krause, and I'd like to thank you so much for this illuminating and inspiring program. I trained in developmental psychology, PhD program, and added training at Yale and Cornell and Columbia in economics and finance. I'm a startup, Green Corsair Labs, with a focus and interest in neuroscience and mental health and psychology and other areas of biomarkers. So my question for ARPA, we're very focused and interested in the varied areas of machine learning, AI, deep learning. And I think we had the speaker from Lundbeck who mentioned that we can accomplish in one day what previously required 2 years of effort. So in terms of efficiency, this is a very crucial area. So I'm wondering, do you place a weight when you are evaluating your applicants on whether they have a focus on deep learning, machine learning, and we have resources and partnerships and team members for that?
I probably can't comment on like how we evaluate. What I can say is across the 20 program managers, we have those that are experts in artificial intelligence, cybersecurity, every kind of healthcare background you can imagine. The expectation is that we are a technical agency. And so what you're talking about in terms of technology, that is going to be an enabler for scale. So the short answer is we're not, we're somewhat technology agnostic. We want all of it. Whatever is going to help us get those ideas and those innovations into the patient, that's our focus.
I think, yeah, there's.
So my name is Laura Jana, and I am a pediatrician by training. I like to say I was born and raised academic medicine, hard sciences. And actually, I was going to say it's a question for ARPA-H related interest, but it's actually for all of you because I do a lot of the multidisciplinary cross-sector, broader definition when we shifted from healthcare to health. I sort of laughed and said one word difference, but really big difference. So I'm interested for all of you actually, not just for the ARPA-H purposes, because what I see a lot of, and this is very refreshing, you know, for the summit here, because what we see is a shift from not just brain disorders, right, and the neurological and the biomedical sciences, but expanding into the social determinants of health and all these other things. Where are you looking at those things? Because I find a lot of times it sounds like health and then it defaults right back into patient-centric, healthcare-centric, as opposed to the broader sense of health and the innovation that can take place when you integrate, you know, sort of all of these other factors that impact health outcomes.
No, it's a super good question, and you know it sort of ties into the AI question a little bit in technology, and so it's something I certainly don't have the answers for, but I'm very curious sort of in that entire space. So right, the ultimate sort of place that we're trying to get into Florida is sort of whole person care. Advent Health, Baptist Health has gone a long way in sort of going down that road. We had some success in the 2024 legislative session as well. Right, in that, payer Florida Blue has also started moving in that direction as well. And so in Florida at least, and through our work with Dr. Kelly and Casey on this, right, the majority of our individuals, whether it be adolescents or adults, are entering in through our mental health system through points of crisis. So we see that through ERs, we see that through law enforcement. So the ultimate ideal system that we're trying to get to in Florida through breaking down some of these systemic barriers is getting to whole person care, right? There is no health without mental health. And that is really sort of the framing, the mindset of where we are ultimately striving to get to. The AI question, I'll just comment on that for a second. I was at Harvard Kennedy last week for 5 days, and we were doing a lot of conversation around technology, AI, and all of that. And one of the things I'm very curious about when it comes to AI, I think it absolutely can help productivity. I think it can help in a lot of those areas. But as you heard the governor of New York speak this morning on the perils of social media and sort of how the unintentional consequences of some of that has gotten us where we are. A lot of our youth is using a lot of that AI-based stuff, but it takes away our sense of purpose in some way and our struggle and learning and giving us a feeling of success, right? And so we're very sort of caution on some of the technology and how it's applied, sort of trying to learn the lessons that we've learned sort of from the social media aspects as well. But does that answer your question?
No, Yeah, I mean, we would just agree that mental health is part of whole health. And some of that is breaking down stigma. Some of that is also just looking at system. We talked about children coming in through points of crisis, but also pediatricians are often on the front lines and they don't know necessarily how to handle this. And so how do we help change the system to give them better tools for referrals and for help in the space? But again, it's like thinking about this, I think as you were just saying, comprehensively. We're also seeing a lot of companies, some companies are just laser focused on different parts of mental health. We're also seeing a lot of health companies that the way they're achieving their health outcomes is also by providing behavioral health and mental health services as well. It's part of the social determinants of health and helping to make sure that they're getting the support. We just had a great, back to a great company called 7 Starling that provides maternal mental health at every stage of the motherhood journey. Very different and very bespoke, but also that's going to have what we think and what we believe is going to good outcomes for the children as well. Because if you strengthen the mother's mental health, that's also going to have good outcomes for children too. Since everyone's talking about AI,
this is actually John's favorite topic.
might be my love language, but no, I just want to double click on something here because I think it's going to be an amazing set of tools and innovations. It's going to help introduce efficiencies. It's going to introduce, I think, new ways of helping to support both providers, but also I think children as well. But I do want to double click on this. Like I worry on this, some of the emerging research that these tools are highly relational. And that may not be the way you engage with ChatGPT, but even when ChatGPT or OpenAI released Strawberry, part of their systems card talked about with voice that they noticed people started developing more personal sort of language as they were engaging with it. And I think this is a little bit of like looking at where we are with social media. Like we might be at the beginning edge of that next 10 years. And how do we get ahead of this so it's a tool to strengthen mental health, but also doesn't deteriorate social connections as people start using more sort of relational aspects with their AI bot or companion. And so that sounds like science fiction, but it's enough that the companies in Silicon Valley are worried about it. I think that we should be worried about it too.
Okay. I think the gentleman in the back had his hand up first before, I think.
And it helps.
Sorry.
Hi, thank you for this great panel. My name is Vaibhav Narayan. I'm part of the Davos Alzheimer's Collaborative. I also work with the UK Mental Health Mission. I used to be at J&J for many years.
Pull your mic up.
And I want to ask a question which I think will provoke a little bit, but just suppose, imagine that you had a near perfect algorithm or a solution to predict suicide, oncoming mental health crisis. It's near perfect because there is always a little bit of false positives, but it gives you an advanced 2-week warning, and it's fairly good in its performance. It can be deployed. I think what I would say our experience has been that it is almost impossible to get such a solution deployed, adopted. It is almost impossible for there to be a business model around this, to have the solution be sustainable. You will hear things like, well, there's a little bit of false positives, but these people are not costing us anything anyway right now. I couldn't be bothered with dealing with any of the signals, right? Or even more perversely, you might hear things like, well, actually, if something happens and they come to a psychiatric ER, that's a more profitable event than any long-term monitoring of these people. And I ask this question because I think we are talking about innovation and how to support an innovation ecosystem, but the incentives are often quite perverse.
So what's the question?
The question is, I guess, from your perspectives, how do you fix this, right? I think my larger question is that even if technology solutions do exist, it is very hard for them to be sustainable and for them to scale for reasons that I think we can discuss.
No, I think that's, first, I think you're right, that whenever there's an innovation, it's hitting a whole bunch of headwinds, and that's everything from the regulatory system that approves it or adopts it. It's also the policy and payment system that pays for it. We have a number of innovations in our portfolio that are just running up against payers who've never seen this innovation. so they don't know how to pay for it. They don't know how much to pay for it. But I think that's like the whole idea of what we've been talking about here is that's part of the reason you need all these sectors working together. And you need policymakers and regulators creating sandboxes to run pilots in order to kind of experiment and help them get smarter on it. I think we need to be smart too, that as we have events like this, how do we bring policymakers and regulators and payers into the space so that they can learn and they can see what's on the horizon, as well as, to your point, solutions that are ready to be deployed and scaled as well. But it's about, I think, facilitating a lot of cross-sector learning. What I find is that a lot of innovators are going full speed, and payers and regulators are just years behind. They didn't know something was possible. They didn't know something was possible because no one showed them. So it's bringing them together in a room and setting that table and hopefully creating a bigger tent around that.
So we are now running up. Again, I'm getting the look from Fred, and so I wanted to give the panelists just one more quick opportunity to share if there was one key takeaway that you wanted the audience to learn from our session today. Even if it means you're repeating yourself, I think that's okay. Like, what is the one thing that you want to make sure that they take home from this session? And we can start with Katie and go down to John.
I should have sat down there.
Come on, he got the AI question.
That was my one takeaway. No, I'm just kidding. I think my fundamental message always is hope. And I think everybody in this room, I've listened throughout the day. There is incredible things that are happening. And in a time that things seem so polarized in so many different areas, there's a lot of things that are happening that are bringing people together behind sort of a common purpose and a common good, especially in the mental health area, in the mental health field. And so I think the more that we're able to do that and sit down and ask these questions, I mean, the technology question around policy, I don't have a specific answer to that, and I can't sort of answer that, but it does create enough curiosity within me to sort of go back and start thinking about that, right? And I think that's the power in a lot of these new technologies and what's coming, is how do we create curiosity and educate each other and learn from each other to make sure we're mitigating against unintended consequences, but we're doing things sort of with the right intent that solve the problems and move this entire, issue to a better place.
Shirley?
I mean, I'm just going to, kind of double tap again on big, bold ideas and program managers, because that's what's going to drive our ability to fund to fund ideas in mental health. So program managers, big, bold ideas, if you have them. If you work in an environment where you see great ideas, but they're too risky for you to invest in, you're not going to get your return in enough time, it's going to take too long, send them our way. If we can de-risk something and unlock tremendous value and potential innovation, that's a place ARPA-H wants to play.
John?
Maybe my charge would be take advantage of this moment. I have worked on so many different public policy areas, and so much of that is agenda setting. How do you get the public, or policymakers, or innovators to care about something and deploy resources and attention and other supports to it? Here you have this moment where there is bipartisan support and interests about the mental health crisis with our youth right now. You have this amazing energy that's happening in Silicon Valley and with the tech community, with governors out and Medicaid directors, with innovators and with public policymakers and philanthropists. Use this moment and set those tables so that they're bigger tents. Bring those people together and help sort of deploy them in all their unique strengths in order to help deliver some collective change and hopefully some systems reform that can drive outcomes and improvements for kids right now.
And I'm going to take facilitator's privilege here and offer my one thing that I really would like. And it is a combination, I think, of what you've heard the panel say. And that is that now is not the time to stay in your lane. Now is the time to look to the left and to the right. And I encourage you to meet someone who you've never talked to before and truly listen to their perspective on how they're trying to solve some of the problems we're talking about today. Because I find myself more hopeful than I have ever been in my 25-year career because of leaders like this who have not worked in mental health care for the past 20 years. And they have decided to enter into our community and our ecosystem and be part of the solution. And they think about solving problems differently than many of the people in my 20-year career. And I'm just really thankful to have learned from them. And I encourage you to learn from the people around you in the audience. Thank you, Fred, for having us. Thank you, Stephanie.
Well, thank you very much, Casey. And I think we now have an opportunity to move on the discussion as we are having double clicks or double taps, as it was said, on different issues. And well, that's the word that was used. That's what they use. Well, they said double click and double. I don't know. I thought it was an expression, popular in New York or something. No idea. Or maybe in Texas. So our next panel is going to have a deeper dive on collaborative partnerships for improving access to neurological medicines in low and middle income countries. So I will have the privilege to welcome back on stage Werner Obermeier from WHO, Rajinder Damija from the government of India, Kent Jankarik from EMD Serono, and Dan Gwynell from the Clinton Health Access Initiative.
Hi. How are you? Good afternoon.
This morning, really fantastic.
Thank you very much.
Very good. I would like to have your slides actually. We work with Tarun Dua and with a bunch of the.
Yes.
I move a bit so I see.
I got it from.
I can see the entire panel all at once. Well, actually, Werner, you explained this morning the work of WHO and the implementation of the Global Action Plan. You actually touched upon some of the work being done on access to medicine in neurology specifically. But I wanted to ask, before we go into this, why is it an issue? And why has WHO decided to take it on?
Well, when I mentioned this morning and gave you the second slide, I believe, on the data that we have on the global burden of disease, the data shows that neurological conditions are the leading cause of disability and ill health. And one of the main reasons is the high treatment gap, which I also mentioned. Now, there are different drivers to the high treatment gap, but one of the main ones is a lack of access to medicines. There are many medicines that are effective, that are not very expensive, that have been available for many decades, but they are not accessible in high-income countries, but particularly in low-income countries especially. And there are many barriers to this. We find in many low and middle-income countries treatment for epilepsy and Parkinson's disease equal or exceed a monthly salary of a government public health official. So it's unaffordable. And we also see that there are many problems with stockouts and a lack of availability across the health system. So there are 4 challenges that we are working on that I quickly want to mention because I think it will be relevant for what we are talking about here. The first is a lack of registration. If you cannot register medicines for neurological conditions, you cannot procure them in the regular way from the national perspective, and you cannot market them. There is no market authorization. So it doesn't allow national regulatory authorities to compete for pricing, better pricing. There is a lack of neurological medicines in universal health coverage packages. This is important because the universal health coverage package has a list of essential medicine services that need to be provided at the primary healthcare level. And if this is not included in the list, then it's not publicly funded. So there is a high out-of-pocket cost for the public, and it makes it unaffordable. Supply chains also big problem, not only in terms of the availability, but we see in many cases health systems don't have the right data to inform their decisions, so they cannot forecast capacity levels into the future accurately. And obviously, in many low and middle income countries, we have a problem with storage, cold chain, and distribution. The fourth one is even more important, and I think the last one to focus on is you can have the treatment and the medicines, but if you don't have adequately trained and equipped health workforce to prescribe it and to monitor the provision of it, then you will not go anywhere. So we find that there is a large capacity gap at this point, there are 12 million health workers shortage in the world, going up to 18 million by 2030. And it varies across regions. So in Europe, for example, there's one neurologist per 11,000 people. In Africa, there is one per 1 million people. So it's investing in the capacity and the training of people. I think I'll leave it there. Thank you very much.
Well, but so it's putting this in perspective to an holistic approach to the treatment for neurological disorders. So you mentioned the eye gap, you mentioned the list of essential medicines. There is also the report on improving access to neurological medicines. Where do you see that these, and what do we need to do in order to see the recommendations implemented and pushed forward? It's like more as a kind of alarm bell being pulled, or are there very concrete, let's say, actions being proposed and that the WHO is looking forward to seeing implemented?
Well, I think it's a mixture of both. There is cause for alarm, but there is also cause for hope, because there is no government in the world that doesn't have the will. The capacity is lacking, and there are systemic issues to address. And that is actually not a bad thing, because systemic issues are fixable. If there is no political will, that is not fixable. So I think that's where the community needs to come together, and why I mentioned this morning also, it's very important to have people with lived experience involved in reaching out to politicians. That's why you change the dial, such as we heard from the politicians this morning.
Okay, that's a good point. Dan, I'd like to turn to you. So you're a special advisor, the Clinton Health Access Initiative. Maybe you can tell us a little bit of what that organization is and does.
Absolutely, I'm happy to. So the Clinton Health Access Initiative has been around now for about 20 years, and we do a variety of different things, but one of the things that we've done the most over that time is market shaping for access to medications. And that's medications for HIV, medications for tuberculosis, long-acting reversible contraceptives, viral load tests, TB diagnostics, and so on and so forth, oxygen. We've worked on a variety of different things. And part of that is around organizing deals, essentially at the global level, with manufacturers, so that if there is a need for a bulk order of carbamazepine and phenobarbital for the treatment of epilepsy, for example, that is well priced and that there's a volume guarantee and that you're assured to get it. And then it's also doing the work in country, which Werner was talking about a bit more, with the supply chain unit, with the pharmacy board, with any local manufacturers, with the HRH directorate, training health workers, and so on and so forth. And so we approach product access from like a full end-to-end perspective, where it starts even sometimes as far back as R&D or developing a different formulation for pediatric HIV medications, but then all the way down to the minute that that product gets delivered to a health post and is then prescribed. And so that's what we work on at the Clinton Health Access Initiative, amongst a variety of other things.
Okay, so HIV, tuberculosis were successful examples. Could you, could you give an idea of like current or more recent project, or how it worked efficiently?
Yeah,
or what was the problem you were trying to address there?
Yeah, I think that the HIV one is really instructive, because we've been working on that almost since we were founded. And I've been working in the global health space for now 17, 18 years. And so I remember the conversations in 2005, 2006 around HIV treatment scale up. There was a lot of hesitation around it. There were questions about the price of the medications, whether it would be affordable, whether you could sustain it, even if you scaled up at the beginning. And so, at the time, the regimens were $300, $400, $500 a year, even for first-line treatment. And now they are $47 in most of the countries where we work. And we've been able to help keep improving the kinds of medications that are available, so switching to newer formulations of HIV drugs like dolutegravir, which have less side effects, but keeping that price down and doing that through a mixture of volume guarantees, working with the pharmaceutical companies, and then working with national HIV programs to make sure that the countries are prepared for the rollout of new medications. And it's very similar for our TB work and oxygen work and other work as well.
So you could really say that this work on market shaping that you specialize into was influential in addressing those issues. That was really where the gaps and the flaws were in the system.
The party line is that we've done 140 deals, we've saved $4 billion, and that we've helped millions of additional people get on HIV treatment and other treatments.
I'm asking this because Werner was pointing to a systemic issue, and that we're talking about medicines, but it's integrated into a more general landscape. So do you see that market shaping is like the silver bullet in that respect, or
Absolutely
how is that
not.
like bringing the contribution in terms of addressing certain gaps? And where do you see that actually you need a counterpart in order to address all these other issues in the system that you cannot address?
It's so hard. I was the country director in Sierra Leone for 3 years, from 2014 to 2017, during a very difficult and challenging time for that country because it was in the midst of Ebola, and there was obviously pretty substantive disruptions to essential health services. And I sat in the supply chain unit, and we tried to make sure that the stream of essential medicines was still going to health facilities. And at every single turn, you know, the systemic issue is that the supply chain is not stable and secure. And so I remember one day coming in on a Monday morning, and nobody had checked the warehouse over the weekend, and the AC had been off, and the temperature-sensitive drugs had been held at 120 degrees over the weekend. And so, you know, it's like, do you have sufficient trucking capacity? Do you get the right order from the UNICEF warehouse in Copenhagen? Most often, yes. But occasionally they have a shortage because they're dealing with a variety of different countries. And then you maybe get 100 packs of phenobarbital, but for 120 to decide how to. So there is a real substantive logistical issue that exists on the other end of market shaping. It's not just enough to get down the price. You have to do the really nitty-gritty work of essential medicines list, registrations, procurement, quantification, warehousing, distribution.
And obviously, one of the challenges that we are facing in the care for neurological diseases is the adherence to treatment and the capacity for patients to have access to the treatment that they need to follow and adhere to. So how do you see a parallel to the experience you had, or that you just referred to in HIV, and the way it can contribute to the efforts mentioned by Werner in neurology?
It's so hard. Adherence challenges are really, really hard, especially when there are shortages of sockets. Thankfully, we're in a place in the HIV response where that's less common than it was, 10 or 15 years ago. One of the things that we're working on within the brain health space now is that we're thinking a lot about getting into drug access for mental health conditions and neurological conditions. And so I think that one of the things that I find really exciting and really promising is new technologies and new formulations of different things. And so now there are these long-acting injectables for psychosis, which is super exciting. I mean, we've never had these before. And it requires a lot of training. People need to be on oral pills first. Like, there's lots of different problems. There's no silver bullet. None of this is easy. But the idea of this continual churn of new technologies, now there's the long-acting injectable for HIV prevention as well. Like, I feel like that's really exciting, and I think that that's going to make our jobs as logisticians and drug access people a lot easier.
Okay, thank you. Rajita, I would like to turn to you with a practical experience. I mean, you mentioned you're on the Brain Health Task Force of the Government of India. Well, maybe you can tell us more about the situation that you experience in India, and how does that resonate with what Werner and Dan just said?
So thank you once again for having me. Just again highlighting the same problem of huge disease burden in a country of 1.5 billion. With of course diseases like epilepsy, more than 10 million people registered for epilepsy, and with a treatment gap of 70 to 80% in epilepsy. So it's not only the treatment gap, as Werner showed in the morning, it is also the people who are starting on anti-seizure medication, they become all right and then they stop it because of the various reasons, whether it is financial or it is social or other reasons, and then they land up with the status epilepticus. So one thing leads to another thing. It's because of the lack of accessibility or availability or cost effectiveness. So all these factors combined in a simple disease like epilepsy or Parkinson's disease, where there's a controllable disease, you take the medication, you become all right, and then you stop it. So that is one problem which we are looking at, that how we can make sure that the people continue to take the treatment, that adherence rate of less than 30 to 40% in a bigger population. That's one aspect. The other aspect is a huge disparity or inequity that is a problem. You can have the best of the treatment of epilepsy in the country, and you can also have not availability of a drug like phenobarbital or a phenytoin in some part of the country. So that's a huge disparity. And every day you get a new molecule, and then people get to start prescribing those without caring about the drug interaction. On one hand, you have genomic medicine coming up, pharmacogenomics, where individual has a precision medicine, so that tailored to each individual. You can have a carbamazepine, for example, suiting to one individual, not suiting to another individual. So you can predict which individual is like to respond to this medication without any adverse event, and which individual is not likely to respond. So that's the huge disparity. That's number one. But having said that, the task force now, which is the national task force, has a mandate to make available the accessible drugs which are in the WHO essential medical list, as well as our own national medical essential list. My own experience as a neurologist in Delhi and in charge of the Delhi state essential medical list, we are talking about the political leadership or the leadership or the governance. So we had about 200 medications approved, which were questioned. Again, we tried to improve it to 600 to 1500, but eventually it was scuttled down and then came back to 200. So that is where we get the resistance from the financing institutions, the finance department, that if issue of finance is a big problem. They have to be a budgetary allocation for each and everything, whether it is a diagnostic or it is medicine or it is infrastructure in the hospital. So each budget has to be taken care of. So that is one aspect of financing. Of course, leadership, of course, the supply chain, as Werner mentioned. Again, there is a huge disparity, huge distance where we are not able to maintain that cold chain or the supply chain. That's again. In addition, the paradox is that India is the largest producer of the generic drugs. And India has made available HIV, as Dan must be aware of that. We are the supplier of the generic medicine, but at the same time, in our own home, it becomes difficult to provide medication, simple medication, such as phenytoin or phenobarbital. I go back to 1980s. One of my own teacher had done a study with two simple drugs for epilepsy, phenytoin and phenobarbital. 80% of the epilepsy could be managed in 1980 with these two drugs only. That paper is published in Lancet in 1980-81. So that model of having a primary care with two drugs, managing 80% of the population with epilepsy. So that model was quite successful, and now at this point of time, we are pushing for the drugs which are modern, which are ultra modern, and which have come a very broad spectrum effect and less side effect. So obviously, there are ranges and there are difficulties and there are things like that. Of course, when I touched about the capacity building, we need specialized manpower who knows which drug to be prescribed and how the rational use of drugs can be prescribed in a larger context.
But that's where, and maybe I can circle that back to you, Werner. What is the process of assessment and then evaluation and incorporation of drugs into the list of essential medicines? So how does that work?
I wanted to talk a bit about the essential medicines list in our second round, but usually this is done by a scientific advisory panel, which are experts from many countries that come together and bring their data and the epidemiology to the table. We discuss in WHO, and then it's placed on the WHO essential medicines list, which is a guide for countries to determine their own essential medicines list.
But you were saying it's impacting the capacity to pay from countries, or at least the fact that a drug is on that list would then put a requirement on the country to be able to reimburse it or make it affordable to the population. Do they have a stake in the process?
Not necessarily affordable, but to put it into the public health system,
available,
right?
Rather than affordable.
Yes, available. Yeah. The affordability is a different question.
Coming to affordability in a country like India, every year 55 million people go beyond the poverty line because of the out-of-pocket expenses on medicine. So that is the financial reasons, and that's the cost which we are talking about, and that we need collaboration amongst the various stakeholders, from manufacturers to the users and users to the developmental partners to the meetings like this.
But the impact of the WHO resources that we just discussed with Werner, how is that helping you on a daily basis? I mean, those different instruments, how is that changing the situation that you experience in India? You would say the list of essential medicines, the fact that there is a push for the improvement of accessibility, does that enable you to go back to your government and improve availability of drugs?
Yes, we have tried, and my personal efforts have been to include as many drugs as minimum which are required for the essential list of medication. But there is always a resistance. You have to draw lines. It's not only neurology, it's always oncology, which is a very big, very high cost drugs. And then you have to balance it, which drugs to be included and which drugs to be excluded. So there's always a competition between the different specialities, and I'm afraid that the newer molecules or monoclonal antibodies coming up, even for migraine, for example, or all the neurodegenerative disorders, including Alzheimer's and including the immunological disorders, multiple sclerosis or animal spectrum disorders, all these are very, very costly drugs. And we need to provide them because they are the one who are disabled people and who are not working population or a working class where wages are again an issue. So obviously you have to take a balanced view, and WHO is essentially a guidance which doesn't have many medication, but there's a minimum list of medication. We have much more than the WHO list of medication. But the mandate of state to provide this medication free is not available for everyone. So there has to be out-of-pocket expenses, and I'm afraid that is causing a great concern for all of us. In my own state of Delhi, the government has mandated to give all the medication free of course in all the public hospitals. But that doesn't happen all the time. You always have that problem of availability, supply. We try to achieve 80% of the medications in the list to be provided all the time, but that also becomes a big challenge for us.
Okay. Kent, I'd like to turn to you. Sure. So you are head of global public policy at EMD Serono. Actually, I'd like to ask you, what is your company position on this issue of access to health and to medicines in low and middle income countries, and what sort of commitment is your company making towards that?
Great, thank you very much for having us. So I'll mention first, EMD Serono is the US healthcare division of Merck Group based out of Darmstadt, Germany. Not to be complicated with the other Merck.
Well, let's not go back to the family business.
There we go. We produce specialty medicines for neurology and immunology, for oncology, fertility, and also general medicine. And we market our products in about 65 countries. And I just want to mention as well that with regard to the essential medicines list, which we've been talking about, Merck has several products on the essential medicines list, including a neurology treatment for MS, which was added to the EML just a few years ago, which I think was an important step when the WHO moved towards adding neurology treatments onto the EML. Prior to that, I think there had been a focus on oncology within specialty, but now that focus is broadening to include other neurological treatments, which I think is a good step. Also wanted to mention that we partner with WHO on praziquantel donation program for schistosomiasis in the developing world. So that's for Africa and other markets. But we essentially give that drug away as part of the WHO program. And I think it's just a sign of the importance of the public-private partnerships, working industry with government, NGOs, to do the right thing to make a difference for people in a less fortunate situation. We're committed to developing medicines for a number of life-threatening conditions, making them as widely available as possible. So we very much support having our products on the EML. And in terms of access, we're trying to get to where the UN Sustainable Development Goals are, which is 170 million patients a year treated. Access can be achieved in a lot of different ways. Everyone has a different role to play, everyone on this stage. For industry, I think there's a couple key areas where we can make a difference. One is just pure donations, giving the product away. in certain markets, as we do with schisto, or praziquantel for schisto. Technology transfer is another important element here. For example, in Brazil, we signed a deal with the Brazilian government to distribute one of our MS products there. It's now manufactured and produced locally in Brazil. I think makes a big difference having local production. It removes the whole importation element and other challenges, which can be quite daunting at times in terms of getting any given treatment from point A to point B. Also wanted to mention, obviously, government tenders. We participate in those in many markets, and that's really a matter of exchanging higher access for a lower price. And then fourth, early access programs that focus around registration and reimbursement. And I know that point was made. You have to be able to register your product to be able to have it in a market. So the more we can do to be creative about working with governments for capacity building to allow for registration in more markets, we want to move in that direction. Just also wanted to mention that IGAP, published in 2022, it also seeks to improve access to neurology treatments, and it's really around elevating neurology medicines in the policy debate. Historically, neurology has been underrepresented in that space. I think there's been more of a focus on heart, on oncology, some of these other areas. So it's nice to see that neurology is getting more of a focus and an emphasis. Maybe some of that's driven by the fact that we see more treatments in development for Parkinson's, for Alzheimer's, for other neurological conditions. Also want to move towards creative solutions, turning creative solutions into policy, legislative, and regulatory frameworks. Without the necessary regulatory frameworks in place, it's very difficult to get onto the market in a given country. There's risks for the company, there's risks for the government if there isn't a clear path, and also making sure that path is clear to all and able to be followed. And then also investing in R&D. We need to continue to invest in incremental innovation. It's not about going from A to Z. There's a whole process that we have to go through for many years to move in the right direction to get to where we are. For example, with MS, we have over 20 treatments on the market now for MS. It's a completely different therapeutic area than it was even 20 years ago when I started in the industry. So I think that's an important consideration as well. Anything we can do to allow for the facilitation of the next era of therapies is important. And then also, we need to continue to develop better and more effective treatments. We don't have all the answers today, but I think with science and innovation, we're moving in a good direction. Producers of essential medicines also have, I think, an important role to play around importation and addressing challenges that we face at the market level, addressing the urban versus rural divide in certain markets, access disparities between public and private. Sometimes we see great coverage on the private market, but we don't have the same level of coverage on the public market. How can we even the curve, so to speak, so that both the public and private markets are represented in all of the countries that we're operating in? Infrastructure challenges, this is a real thing too. You can give your product away for free, but if there isn't effective infrastructure in place to allow for the delivery of the medicine to any given country, again, it's going to be a problem. And with the cold chain, with the biologics, it's even more of an issue. So making sure that we had in place the infrastructure, like with the technology transfer agreement we did in Brazil, it's a biologic. So you have to look at, can you share the cell line with the government to allow for them to do the local production so that you've eliminated that transportation variable, so to speak, from other markets. And then also just supply chains that can minimize disruption as well.
Mm-hmm. Mm-hmm. So we come back to what Werner was saying about the need to have a systemic approach. A word that has been mentioned a couple of times since this morning is partnership. Mm-hmm. So do you see an opportunity within those partnerships between companies, with NGOs, potentially with dance organization, but also with governments, in order to improve this situation and bring those and potentially shape solutions together?
I think we have to. I mean, if we're not working in partnership with government, with industry, with NGOs, we're never going to be successful. And the challenges that we face in some of these developing markets are real, they're difficult, they're not easy to fix, and they require everybody to be working together to get to a solution. And so, like, I mean, Clinton Global Initiative, we've been involved with them for years in the past. I mean, so we have to be involved with all stakeholders to really make a difference, I think.
Well, Werner, Dan, I'd like to circle back to you for your reflections on what was said, both by Rajida and Kent. Werner first, maybe?
I wanted to pick up on something Rajinder mentioned about the difficulty that governments have to actually roll out what is available on the essential medicines list. So one of the 10 targets in the IGAP is actually to get 80% of countries to that level by the end of the decade. And the essential medicines list is one way to do that, to show which are the most quality assured products to put on the national lists. But then having access to it is obviously a different discussion. So what we've done just in the past few years, we have 3 more drugs for multiple sclerosis on that list. And just recently, we added levetiracetam for epilepsy to the list as well. There are things actually that I picked up from what Dan was saying in terms of the market shaping. What we do a lot with countries in the Pacific, in Asia, but also in the Caribbean, is to put in place pooled procurement mechanisms. So a number of countries would bid for better pricing on medication that some of them may need or all of them may need. So that kind of way to shape the market with supply and pricing is very effective, the multi-country pooled procurement, but also a mechanism that we have put in place where countries can use the WHO pre-qualification program to also procure at lower cost, because that gives them opportunity to purchase pre-registered medication or drugs, or whether they can loan from other national registration processes and simply duplicate it. The sharing of benefits there and the sharing of capacity.
Okay, thank you. Dan, you'd like to add?
Just generally agree with everything that's been said. I don't know.
No, I mean, come on, it's a panel.
No. I'm about to say more. I'm about to say more.
Let's make it a bit more lively.
Well, I do still agree with everything that's been said. I don't know a ton about neurological conditions. Most of my work has been on other areas. I know a little bit about epilepsy. I know a little bit about Parkinson's. I'm really curious about MS. That's something that has been personally affected by in my family. And I'm curious about these new drugs in particular and the kinds of logistical challenges that they present in terms of rollout and access. And so this is something that I can say that we will take a look at the Clinton Health Access Initiative, and I would love to have a follow-up conversation to talk a little bit more about MS, epilepsy, Parkinson's, and these other things, to see if there's something that we can do, because we're already about to embark on a big piece of work on psychotropic medications. And so I would love to continue this conversation. I think just beyond that, like, it's really hard. Like, after having sat in that very, very hot, air-conditioned office for 3 years in Sierra Leone, working with the team to write a new law, to create a new supply chain institution, to address the board issues, the graft issues, the logistical issues, the warehousing issues. There's just so much. And it's going to take, I think, years. This is a generational project. But that's not to say that we shouldn't move fast, and that's not to say that we shouldn't move efficiently. And so just looking forward to seeing where this conversation goes and where we can be a part of it.
But give us a bit of hope. You managed to achieve that law in Sierra Leone?
We did. You know,
Okay.
we got to a place where there was a reasonably reliable level of essential medicines stocked in the health facilities, which
Awesome.
doesn't sound very ambitious in some ways, but for the situation that we were in, it was a miracle.
Yeah, we can picture that.
Yeah.
But did
Since this panel is about the improving the access to the neurological medicine in lower and middle income countries, the focus is on lower and middle income countries. So one issue which we have not touched upon, and it's a very sensitive issue, I know it's a business kind of a proposition. So intellectual property rights. So we are talking about the MS drugs now, and many of the MS drugs used to cost thousands of dollars. And once the patent came down, the price came down to 1/10. So it is also a magnanimity or a big heart that lower and middle income countries, which now constitute 2/3 of the world's population, should have that access at some stage where the profits have been obtained. So the drugs should be made available at a price which is rational, which is reasonable, and which is accessible, even in the era of intellectual property rights. So that issue is, I know it's very, very sensitive issue, but thinking in lower and middle income countries where 2/3 world's population lives should be considered in that angle also by the business.
Thank you. Kent?
I mean, for sure. I think we need to look at intellectual property along with all the other issues. I mean, we're coming up now with the EML on 50 years. It's hard to believe that it's been around. And national governments, across the world are looking at the WHO's list to determine their own national list. So I think anything we can do to kind of broaden access, broaden adoption of the WHO central list in as many countries as possible is something that we need to encourage. And that's around capacity building initiatives and other activities that I think industry and NGOs are pretty good at participating in and collaborating in with governments locally to make happen. We've got 2 billion people who still lack access essentially worldwide for a variety of reasons in some of these markets. And I think we need to do a better job servicing those 2 billion. Can we look at affordability? Absolutely. That's an element of the equation we have to consider. And that's why I think donation programs, tech transfer, some of these other agreements that can be put in place with governments can really make a big difference in that regard. And then also registration of the medicines in high burden countries. In some cases, we don't have registration across all the high burden countries. We need to make sure that if there's a high incidence of MS, for example, in any given country, that we're able to register in that market. And if we don't have effective regulatory and legislative frameworks in place in that market, we need to work to achieve that.
Awesome. So it seems that there will be another offline conversation after this panel. So shall we invite you back next year in order to report on how that collaboration was brought to fruition and what were the first steps?
An audit of what has happened.
An audit, oh my God. Okay, so that means you're very ambitious. Okay.
I don't know that I can agree to the audit, but I can agree to the conversation.
Because it says the partnerships. So obviously we have to work to partnership.
Okay.
And we hope we come next year at the same platform, we will be in a better position so that the accessibility is much more than what it is today.
So I take this as your takeaway.
Yes.
So Dan, what is your takeaway from this discussion? One sentence.
My takeaway is that I want to start looking at brain health as a much more broad category. We've been mostly looking at mental health, and I think it's really exciting to think about expanding it to include this.
Okay, thank you. Werner?
Well, very simple. I'm very optimistic. Everything I have heard since this morning up to now has filled me with optimism.
Wow, well, so pleased to hear that. Ken?
The new focus on neurological medicines within the lower and middle income markets needs to grow and continue.
Awesome. Okay, well, thank you very much for this discussion and for your contribution to this meeting and to this panel in particular. So please join me in thanking everyone. Now, you have a bit of job to do now in creating this partnership we just discussed about. So there will be drinks tonight where you can discuss all of that and it boosts your creativity. We are now moving on with our next panel. It's a panel organized by another of our partners for today's and tomorrow's events, Perkins and Will. And actually, we are going to discuss neuroscience and the built environment, advancing brain health and resilience. And I'm very pleased to welcome as moderator Hala El-Khorazati, who is a senior interior design. So Hala, you have the floor.
Thank you.
sit here and you're just so because you're.
Can I do the front and give it to you? Yeah. You sit here. Yeah, we're ready. All right. Thank you, everyone, and thank you for joining us today. This is going to be a bit of change of pace. We have quite a visual presentation, so please, if you can't see a screen, try to see a screen. So I hope we can inspire you a little bit about what we're doing. So our topic today is neuroscience and the built environment, and we're looking at how we can advance brain health and resiliency. We are Perkins & Will, and we have quite an exciting panel with us today. So I'll give you a bit of an overview about who we have. And please, because it's not going to be just raise your hand. So first, out of our Chicago studio, we have Max Adams with over 19 years of experience as project architect. Max has also worked on numerous award-winning work across different sectors, so very exciting. From Dallas, we have Dr. Debbie Beck. Debbie is a principal and healthcare operations and strategic planning executive. She has more than 25 years of experience in healthcare as a clinician, healthcare executive, public health leader, and executive planner. She is also our driving force and a huge inspiration to me. And she is a leader in research and innovation initiatives across the firm. We have from our Houston studio, Diana Davis. She's our managing director and healthcare practice leader with over 25 years of experience working with diverse healthcare clients, academic medical centers, and community health hospital clients. And Diana has brought one of our favorite clients with her, Stephen Glazier. He is a hospital administrator with over 40 years of experience and is currently the Vice President of Business Development and Government Relations for University of Texas Health Behavioral Sciences campus. And we also have out of our New York studio, so locally from here, Robert Wall, who is a Senior Associate, a Project Manager, has a diverse background in engineering and construction and really does ensure that the project vision comes to life. And myself, I am Halal Khorazati. I am a senior interior project designer with Perkins & Will. I've been with the firm for over 14 years, and I've actually had the privilege to work and live and work with them in 3 different continents. So a little bit about us. We were founded in 1935. We have over 2,600 staff members and 14 areas of practice. Today, we have our healthcare practice really representing the stage here, but we do work across every sector. We have 32 studios, and this does not even count our sister companies across the globe. Our core values really is about partnership, advocacy, and finding talent and taking action. That's why we think it's so important to be involved in this from the start and help you design spaces for the future. We're also considered a design research firm. So as you can see, we are one of the top 3 research design firms in the nation, and we have our own research teams that are developing a lot of exciting new work like the area research, and we have our research journal as well. So please look us up and reach out if you have any questions. I'm now gonna leave it to Debbie to talk a little bit more about why we're here today.
Thank you for having us. We're so excited to be here. We've learned so much the last couple of days. It's amazing what the globe is doing to improve brain health. One of the things, neuroarchitecture is just a small component of that, and we wanted to kind of talk a little bit about that today. So we know that brain capital is very important. We got to do 2 things. We need to improve brain health, and we've got to advance brain skills. And the built environment has a lot to do with that. So our panel is going to talk about some key variables and how the built environment does that. First, we're going to talk about how does that built environment enhance cognitive function and emotional well-being. We'll talk a little bit about how it supports neurodiversity and inclusivity. We'll talk about definitely how it creates that innovative and collaborative spaces, how we promote health, and most importantly, resiliency within that workplace. We'll also sort of end about talking about pathways. How do we build a path forward to have a positive brain economy? So we're really excited to present this. I'm going to talk a little bit first about enhancing the cognitive function. On this slide, you'll see numerous evidence-based design characteristics, and you can kind of look at those as the audience and say, wow, this is my favorite. But I'm going to talk very briefly about 3 of my favorites. It's about natural light. One of the things that we know that natural light improves our mood, it improves our ability to sleep. So ultimately, it improves our cognition. It's our ability to do things and to look outside. The second one is biophilia. I'm often told I could stick a 2x4 in the ground and build a tree. And I love the biophilic environment. I love being outside. I really love that. And I think being able to look around and see greenery and be able to be one with nature really does improve. It helps us to be calm. It helps us to regenerate. So anytime we could build that into the built environment, I think that's really important. And then, of course, last but not least, again, it's about acoustics. And we've been struggling with that a little bit today, but acoustics is really important in all of our built environments to be able to, one, be able to function and you know, enhance our well-being and kind of have things that are very quiet. So those are some of my favorites. And the next illustration is a project that Perkins and Will did. It's Nicholas Children's Hospital. And you could very easily see from this photo that all 3 of those characteristics that are my favorite. There's lots of flooded light coming in. There's biophilia. And the lobby was really designed very specifically for acoustics. And knowing that this was a children's hospital predominantly for surgery, it was really important to incorporate those things within this environment. So those are really critical, not only about the acoustics part of it, but another one was where can these families, patients, staff have respite? So there are areas throughout the lobby and throughout the building for that to take place. The next one is one of my most important things that I love talking about. It's neurodiversity. I could probably talk for days about this and how trauma-informed comes into that. But neurodiversity is not about somebody who has autism. It's not about somebody who has neurological illnesses or deficits. It's about how every one of us in here experiences a room when we walk into the room. And we want to make sure, and I noticed today and even yesterday, there's a variety of seating around. There's chairs, there's stools, there's table, and that's all about neurodiversity. It's about supporting those individuals and how they work. So we know that choice, flexibility, and variety are very important in that. And we'll talk a little bit more about that in our panel. We'll talk about the importance of that. So the hospital that you saw earlier, this is a sort of a rendition of that, but it kind of breaks out the patient and the family journeys throughout that process. So all those things that was designed within this children's hospital to support brain health and to make that family feel very comfortable in the children is all illustrated here. And I'm going to point out 2. I wish I could talk about all of them, but one is an active play area. We know that when children are outside, and people talked about this morning, we have our pediatrician up front this morning that put emphasis on this. If they're outside playing and they're one with nature, they're building they're building critical thinking skills. They're learning to problem solve, and that's really critical, not only in a healthcare environment, but anywhere that's at that point. On the opposite of that, again, we need that respite areas. We really need that area to where it's calming and peace, where they can go and escape or flee from the environment that they need to be. So I'm going to pass it on to Hala real quickly to talk a little bit about resiliency.
Right, and resiliency and tying it to living design. So what are designers doing in this conference, right? We are designing for life, and research has shown that a space impacts how you feel, and how you feel impacts how you think, and how you think is why we're here today, right? So it impacts everything we do, and it's really important for us to translate everything that all the work you're doing into spaces that can accommodate the future. And when we talk about resiliency in brain health, Debbie and I have been doing a lot of research in this. There's 2 main categories here. There's research on resiliency through trauma-based care, so understanding the traumatic events that others have gone through and how we can design spaces that can accommodate them, and resiliency in education and prevention. And I think that is the one thing that we are lacking at the moment, is educating our younger youth and helping them understand how to prevent disease or intervening in disease a lot earlier. So a lot of these things are going to impact the future and how we design spaces. Oh, something's... Do you know how to do it? So we have
There we go.
Oh, we go. All right, and then I'm just going to end this quickly on another piece of research that we have been doing in finding the connections. So resiliency is in finding the connections that tie us all together. And when we're looking into trauma-based care, we did this huge graphic, and I know this is very hard to read, but we try to understand what a single mother will go through, what a senior citizen will go through, what an adolescent will go through, what a refugee might go through, and finding all the connections that gathers them together. So it's not just about construction and building, but it's finding the connections and helping people, finding a space that can support people in general. And I will leave it to Robert to talk about innovation and collaborative spaces.
Thanks, Hala. Thanks, Hala. Thanks, Hala.
Yeah, there's definitely, I think the clicker might be out of battery, so.
So the one thing that we really is critical to the understanding of creating environments is that architectural space is really only one of the critical factors. There are many other factors and spaces that we need to consider. There's social space, cultural, organizational space, and they really all need to come together. They need to work as one, and really to stimulate and support all of the creative and collaborative efforts that are really critical to building brain capital that Debbie mentioned, and to supporting brain positive environments. And we know that innovation drives growth, it drives economic growth, but if that's the case, really what drives innovation? What architectural spaces drive innovation? So in order to drive innovation, what we need to provide and create for people are choices of healthy, brain-healthy environments. Everybody needs their own space to kind of stimulate their unique creative impulses, their collaborative efforts, and really what moves them. And through design and architecture, we can start to identify some of those spatial choices. And that'll be things like a safe space where people are free to really experiment and brainstorm without fear of failure or rejection. There are things like private small spaces that let people reflect and really sorry.
You're fine, it's okay. I'll come. Sorry, Robert, your slides were beautifully done.
Just moving on to social spaces, activity hubs that really reinforce and promote relationships, strong, meaningful relationships, that at work, they help to reinforce trust and that we all share common goals. Next, we can think about spatial and functional adjacencies. So what happens there is it's just this constant exchange, it reinforces a constant exchange of ideas and thinking. And that can happen intentionally, it can happen randomly, but those adjacencies, mixing things around, really sort of promote that interaction. And lastly, these days, hybrid spaces, we're all familiar with them. And what's key to those spaces is providing both virtual and physical spaces that really foster these exchanges that will allow people to feel not just engaged and worthwhile, but very productive without compromising the sort of work-life balance that we're all really concerned about. And what you'll see later on are the impacts of some of these spatial choices that we've developed in some of the projects.
Thank you for enhancing our brain health and talking without the slides, Robert. One of the things, as I get ready to turn it over to our panel, everything that we've been talking about the couple of days about how do we build that path forward, it's about research, it's about innovation, policy development. Another one of the favorite things that I like to talk about and establish policies to make sure that this goes on, and it's not just every year that we talk about this. We need a comprehensive framework, and also making sure that our workplace, and we're talking into our schools and making an awareness, and also perhaps looking at pilot studies. How can we fund these? How can we look at this from a longitudinal to see what really works, and abandon the things that don't work, that's not evidence-based, that's not making a difference, and move forward. And then perhaps we look at some tax benefits for people who want to put in some of these policies within that. So now I'm going to turn it over to our panel, and I'll let...
I will just...
I'll let Hala talk.
So before we start with the panel, sorry I had to pause you there. I actually would love you all to just give us a brief introduction about your project. So Diana and Steve, could you give us a quick overview about John S. Dunn Behavioral Health Sciences Center?
Certainly, Hala. Thank you.
Beautiful building. Yeah.
Thank you. The John S. Dunn Behavioral Sciences Center is a 264-bed acute inpatient psychiatric hospital that opened in 2022 to serve the greater Houston metropolitan area. It sits on campus with a neighboring facility, also an inpatient facility of a similar bed count that is from the 80s era. And the two combined form the largest institution for academic psychiatric inpatient medicine in the US. We were fortunate to have a very visionary and research-focused client that we were able to collaborate with on this beautiful project. And I would love for Mr. Glacier to share a little bit more about the stakeholders that we worked with.
Sure. The Dunn Center that we're going to talk about, like Diana said, is part of a larger campus that includes Harris County Psychiatric Center. Now, the Harris County Psychiatric Center is a 274-bed acute care psych hospital that for the last 38 years has served as the primary safety net psych hospital for Houston and Harris County. It was built 38 years ago, and it was built with absolutely none of the features that we're going to talk about that we put into the Dunn Center. When I first walked into that building 11 years ago, I looked around and I said, this building was designed to be like a tank. It was designed to stand up to as much abuse as possible for as long as possible. But it was dark, and it was cold, and it was institutional. And so now we've had 2 years in a new building designed with some of these new features. So I'll be able to talk to you a little bit about some of my anecdotal experiences with the differences in those two buildings, but also some of the research that we've been doing to really try to quantify how much difference did the building itself make. You know, we've got two buildings, and for a lot of our patients that come in, they just get randomly assigned to the two buildings. They're very similar patients. They get randomly assigned to the two buildings to where the primary variable difference is the building, which really enables us to begin to isolate some variables and do some research around the outcomes that the building itself might have caused. The Dunn Center, as Diana mentioned, was done in cooperation. It was initiated by the University of Texas Health Science Center, done in cooperation with the Texas Legislature and Health and Human Services Commission. The older building is owned 50-50 by the state and the Texas Health and Human Services Commission. In fact, when I got there 11 years ago, I found a set of drawings that the architects had left. It was a floor plan, and there was a line right down the middle of the floor plan. And on one side, it said HHSC's half. And on the other side, it said Harris County's half. And I think the reason they did that was so that if there was a problem in the building, they could point at each other and go, no, you have to fix the air conditioning on that side, or you have to fix the plumbing on that side. Both of the buildings, the new building is owned 100% by HHSC, but they only own the buildings. They own the bricks and mortar. UT Health owns the business that operates inside the building. We serve as the governing board of the building. All the employees are our employees. We own the business that operates inside the building. So as you can see, there are a lot of stakeholders. There are a lot of stakeholders in this building. When I was operating that building, let's count the people that I had to keep happy. We had UT Health. We had the UT Board of Regents. We had the Texas Health and Human Services Commission. We had the Texas Legislature. We had Harris County government. And then the funding for the other building comes to us through the local mental health authority, goes to HHSC, comes to us through the local mental health authority. So I had them to keep happy as well. So you can see I had a lot of stakeholders to keep happy. You know, it's very challenging, but the nice thing about having that many stakeholders in an operation like this is it gave me, if we could get everybody trusting each other, which was not always easy, and if we could get everybody cooperating around the same goals for the building, it gave me multiple very powerful resources that I could go to when I needed something to help make a difference in that building. So later on, we'll talk a little bit about the differences between a 38-year-old building with none of these design features and a brand new building that has these features built in.
Yeah, so,
Go back a minute, just a minute. What we've got here is a picture of the Texas Medical Center, where the little orange section to the right is where we're located. The purple section is the majority of the Texas Medical Center, and there's a whole new South Campus to the south of that you can't see that has a brand new massive research center. The Texas Medical Center, it's an amazing place. It does 10 million patient visits a year and has 125,000 employees and 250,000 individuals that go in and out of the medical center every day. So it's an amazing place.
yeah, so this image gives you a little bit of an overview of how the building is sited and organized. You're seeing the two bars of the John S. Dunn Center here. We split the building into two bars intentionally so that we could keep the overall height of the building at something closer to a residential scale, because you'll notice that there is a residential community and even a community bike trail that is adjacent to the building. The overall design of the building is set up to maximize natural light coming into the building, and to make sure that the views are either focused on landscaped courtyards that are at the center of and embraced by those two bars, or are looking out towards the community in one direction and to downtown in the other, while still maintaining the privacy of the patients that are inside. Because we were trying to maximize light coming into the building and views, it could have easily resulted in just a uniform grid of windows, but we all were committed to making sure that this facility didn't look institutional, that it both looked advanced, but didn't look like just a grid of isolated patient rooms as it read on the facade. So the facade was intentionally designed to be emblematic of interconnectedness, given that the goal of the building is to reintegrate its patients into a social network. And as much as we were focused on the patient experience, we know that the patient experience is driven by the staff experience. So we worked really hard to create the most clean, clear, intuitive diagram for the organization of the building as we could. The provider space is in the, if you look at the diagram on your left, you see that the provider space is located centrally. Providers are able to move back and forth amongst offices and collaboration space without interrupting patients. And then the entire building is organized with a podium that has shared services anchored by a dedicated space for education, with the units then stacked above, all focused around courtyards.
Thank you. And again, with Max, if you would give us a brief introduction about the UC Gardner Neuro Institute, which is one of my favorite buildings as well.
Great, yeah. So yeah, the other project we want to talk to you about today is UC Gardner Neuroscience Institute, which is an outpatient facility in Cincinnati, Ohio. This is a building that we partnered with UC Health on to really treat patients with complex neurological disorders, so a wide variety of disorders. Project was completed in 2019, and it's one we're very proud of, not just because we think it's beautiful inside and out, but really because the design kind of came out of the need to meet patient needs. So Dr. Broderick is really the vision, led the vision for UC Health And he wanted to really make this facility not just expand their services, but also consolidate them and bring them into a single building. So with that, he brought together 125 faculty members from 15 centers of excellence into what is now a new regional home for neurological care, education, and research. Unfortunately, he couldn't join us here today, but as a project designer, I hope to bring a perspective about how the design decisions we made were informed by research and how that impacted the architecture, and really, I think by extension, how our built environment can better support brain health. So this building was designed to serve, as I said, people with a really diverse set of disorders, and that could range from patients who were recovering from stroke, traumatic brain injury, or managing chronic diseases like Alzheimer's, epilepsy, migraines, or multiple sclerosis. So really we needed to respond to a wide range of conditions. And as such, a patient advisory group was formed. So even before design began, for over 2 years, the design team led a group of patients, families, caregivers, and doctors to garner feedback from them and to inform the design. So looking forward to telling you about some of those specifics on this project and more broadly about how the built environment can impact and support brain health.
Thanks, Max. So what we'll do now, we'll just let the pictures of both buildings run in the background, and I have so many questions for you guys, so I'm just going to try to go through them fairly quickly so we can allow some time for the audience to give questions. Steve, I'm going to start with you and focus on the community. And how do you see the John S. Dunn Center was designed to address the community needs?
The Dunn Center was actually part of a much larger legislative initiative the Texas legislature was starting to try to rebuild the entire physical infrastructure of all of our state hospitals. Now, this was designed to be a 3-session, 6-year, the legislature in Texas only meets every other year. You know why that is, by the way? Early on, they decided that whenever the legislature met, all they did was spend money. So if they only met every other year, they might not spend as much money. So we meet every other year. So this was going to be a 6-year, 3-session project in which the Texas legislature was going to spend over $900 million to try to completely rebuild and redo the infrastructure of all the state hospitals. We tagged on to that project. If we had simply been a standalone project where we were trying to get $125 million from the legislature, I don't think we would have gotten it. But tagging it on to a much bigger project and showing how our project could help facilitate things that especially the Senate Health and Human Services Committee wanted to do in the other hospitals really helped us. So it was part of this much larger project, and it was designed to do several things. It was designed to help relieve the wait list, the wait list for acute patients in Harris County. We used to start every day with about 125 patients on our wait list. That meant 125 patients sitting on a stretcher in a hospital emergency room somewhere in the Texas Medical Center waiting for a bed, which might take them anywhere from 2 to 8 days to get in. I'm happy to say that yesterday that number was in half, and we had about 70 patients on that wait list. It was designed to relieve pressure on the state forensic wait list. So these are individuals that have been arrested, they're in a county jail somewhere, and they've been deemed incompetent to stand trial because of a mental illness. Just before COVID hit, in February of 2020, there was about 800 people on that wait list statewide. COVID accelerated that like you wouldn't believe, and just by the end of that year, it was up to almost 2,000 patients on that wait list. So we were designed also to help relieve that wait list, which is also now gratefully significantly down. We did that by providing competency restoration units ourselves, and with all the civil beds that we provided, we were able to take some of those patients from the state hospitals, and they were able to convert their beds to more competency restoration beds. It was designed to relieve pressure on the state hospital civil wait list also. So the new building, Our funding comes directly from the state hospital team in Health and Human Services. And we take patients into our building that would have previously been on the wait list for one of their other buildings. And finally, it was designed to conduct research on program initiatives that the state was interested in exploring. For example, if you get admitted to a state hospital, your length of stay is liable to be, you might be there 6 months, you might be there a year, you might be 2 or 3 years. It's much longer term rehabilitative care. If you go into an acute care hospital, you're going to stay probably 7, 8, or 9 days. Well, the state was really interested to see if they might get better outcomes if they had an intermediate level of care, we call it a subacute level of care, that did not exist at that time. They funded us to do this. They said, you decide which patient group you want to treat in this new level of care. We started it with first episode psychosis patients, early onset patients. We discovered, interestingly, that there are quite a number of patients that actually do worse if you keep them in the hospital for longer periods of time. So we learned which diagnoses benefit from this more. When we finally had enough patients that had graduated this program, we compared them to a matched group of like patients and found that the patients that had been in this program were 250% less likely to be readmitted at 6 months in a year and 250% less likely to get arrested after discharge. So these are some of the kinds of program evaluations and research that that the state wanted us to be able to do, and that was another big part of what they hoped up for us to accomplish in that. I will tell you too, by the way, if you ever have a chance to get peer-reviewed published research on a program that the government funded, and you can take that back to the legislators and the funders, they absolutely love that. They get, because I'll tell you, they get so many anecdotal stories of, oh, let me tell you about this patient, or let me tell you about that patient. But they said, we really don't know for sure if this is what we've funded is doing long-term good and having good outcomes. When you can take peer-reviewed research back, your credibility for getting funding the next time shoots up astronomically.
Thank you. And I'm just going to keep the conversation moving a little faster. So Diana, we talked a little bit about evidence-based design. Can you tell us how your research findings kind of dictated some of the design that you implemented in the Dunn building?
Yeah, certainly, as Debbie alluded to earlier in the presentation, of course, natural light views and biophilia. There have been numerous studies that have shown direct patient outcomes in recovery times and in reduced length of stay in general healthcare environments based on access to specifically natural light, but also views as a contributing factor. Noise reduction was very important to us here. It's been shown that noise not only increases agitation amongst patients in these environments, but it can contribute to psychosomatic disorders. We went to the research and also the lived experience of our client that shows that patients in these environments who have roommates are less likely to self-harm. So we chose for the bulk of our rooms to be dual occupancy with some singles for flexibility. And then patient autonomy was a big one. And there are indications that would say the amount, and studies that would say that the amount that patients feel empowered to make choice, empowered with a sense of self-determination, the more that translates into their ownership of their own care and recovery.
Thank you, Diana. I'm going to shift a little bit here, and Debbie, can I just ask you, how can trauma-informed design principles be incorporated to improve cognitive function and emotional well-being?
As I said earlier, this is probably one of my favorite, more passionate things to talk about. Trauma-informed environment, being in the clinical environment for 25 plus years, see how all the patients respond to the environment. You know, we all have that physiological response, fight, flight, freeze, and fawn. And everything about a building has the ability to enhance those physiological responses or minimize those, or in some cases decrease those. So I think that's really important that we think about that. And as we're talking about mental health, it's even more of an issue because trauma is not about, you know, a physical abuse. It could be a disease puts trauma on different individuals. But in a mental health area that we're talking about building brain health, it's even more important, making sure that people know how to get in and out of the building. They're able to see through the building. I know when I walk into a facility, the first thing I say is, where's the exit? How do I get out of this building? And that's very important. And keeping those ideas in mind when you're building facilities or when you're in a facility, so it's very important.
Thanks, Debbie. I'm going to go to Max quickly. So we know that enhancing cognitive function is critical in emotional well-being. So can you explain the relationship of these distinct goals to your patient population more specifically?
Yeah, I think as I mentioned earlier, the Gardner Neuroscience Institute, we had patients with a really wide range of needs that needed to be responded to, and that sort of informed really all aspects of the design. But I think the most obvious one of those was really the unique facade that, if you saw in some of the imagery cycling behind me, the building is wrapped in a fabric mesh on 3 sides. And that came out of a need to respond to glare. Certain patients really had sensitivity to that. So, responding to that need, but also balancing that against what was mentioned earlier, really the positive benefits of providing daylight and views to patients was really important. So the screen became kind of a novel way to achieve that, while simultaneously actually kind of also creating a new image for UC Health as a whole and kind of projecting that out, how they were moving into the future, and meeting sustainability goals as well. So it cut down solar loads by 56% and actually kind of moderated temperature swings throughout the day, improving occupant comfort as well.
We also talked about neurodiversity and inclusivity in design, and we are almost out of time here. So would you be able to tell us very briefly about how sensory-friendly areas are some key features incorporated in the UC Gardner?
Sure. Yeah, I think in addition to responding to the need for addressing the daylight concerns, that glare, as mentioned earlier, really acoustics and auditory stimuli was also very important. So for some patients, specialty rooms were designed for them to really support that need for them. But even beyond that, we tried to address acoustics as a building as a whole. So if you saw imagery of this is on a busy medical campus in Cincinnati, and you can imagine the sound of ambulance sirens and helicopters landing nearby, general road noise. What we decided was that really we wanted to block that sound before it even entered the building, and so we had extra thick glass on this project, and that blocked really a broad spectrum of sound that would otherwise be coming into the building. And to me, it's really interesting because I think we often really see architecture as a visual discipline. But when you step from outside this very chaotic, noisy environment to the interior and to see the contrast or to feel the contrast really of a calming, quiet space, it really just goes to show how important our built environment is to support those mental needs.
Thanks, Max. I want to open some questions from the audience, and then we'll have a couple closing statements. So, yes, the front row, there's a mic behind you. Yeah.
Hello.
Oh, sorry.
My name is Howard.
We'll get
I'm
to you
an
next.
IO psychologist, but my question is not about psychology. I was just curious to know what compromises you had to make between building a beautiful building and staying within budget, and how did you approach those?
All right, I'll take that one.
Yeah, okay.
We really didn't have to make very many compromises. We did start having some budget problems at several times. I've done 4 hospital construction projects, and every one of them hits a point where you have a budget issue. We didn't have that many. We did things like we took a look at how many prox card readers we had to open the doors rather than a key, and they were all over the hospital. And we said, let's only use those where we absolutely have to, and just put a key lock on the others, because the other hospital, all the employees were used to, and I think we saved about $1 million on that. But we didn't really have, we were very fortunate. We had a good team. We didn't have, I don't think we had to make any sacrifices. You know, I've read a lot in the literature where people talk about having to choose between, you know, designing a building to where the building is adjunctive to therapy, which is what we designed this building to be, and designing a building that's going to be safe and efficient. And I think if you have a good team, you don't have to make that choice. You can get both of those.
In fact, we had such an exceptional construction manager that we were working with that we were able to add at kind of the 11th hour another floor to the building, in fact.
We did, and we were probably the first agency in the history of Texas to give back $1 million at the end of our project. We just didn't use that contingency.
Yeah, just Zulmar Ali from the Brain and Mind Institute in Kenya. Before I moved to Kenya, I was in Canada, and I wanted to commend you on the detailed visioning of the architecture, because I think that in the past, as you see the old asylums for mental health, transforming from the TB asylums to mental health institutions, dark and dingy, shameful places, to new and exciting, innovative spaces. And I think that that's really an architectural statement to destigmatization, because people now know, and even people, the patients, feel that they are deserving and that they don't have to be ashamed of what they are actually grappling with.
Thank you.
So I think that this is so exciting to see innovation through architecture for the benefit of the patients and the statement it makes to the communities. Thank you.
Thank you so much. Thank you. We have one more question.
So I'll stand and I'll just speak loud.
Go for it.
Having served most recently, my name is Ira Wright. Having served most recently as the superintendent in Cincinnati Public Schools, I would like to say that this is an amazing building. Absolutely beautiful.
Oh, thank you.
Know that. But one of the questions that I've really had as a recurring question in every session, as we think about K-12 education across the board and all of the initiatives and conversations that we've been having, and think about what we have in most of our school buildings across the country, they are polar opposite in most instances to the things that we've discussed, except the newest of the new, and not many of us are building a lot of schools these days. So what kind of recommendations would you have in a K-12 space around one or two things that could happen that also help to further these kinds of conversations and initiatives?
I'm actually going to direct this question to Debbie, although Max, I know UC Gardner's your building, but I think maybe it's a two-way question here.
Well, I'd like for Max also to kind of weigh in, but one of the things that doing with a local school system, they believe that their school, a lot of their children are challenged, and they believe their school is dull, dark, and dingy. So they've asked us to kind of come in, do an evaluation. How do we make it more trauma-informed? And looking at that, they don't have a whole lot of money, but the county system is so invested in this school, they're willing to kind of help front some of the funds for that. So just kind of coming in and say, a lot of times it could be just a few things that you change can really make the difference, whether it's paint or whether it's restructuring an entrance. So I think that's really important. But I think awareness is really the key, that we need to make sure that our legislator people understand the built environment makes a difference with our children, and our children have to come first, and we need to make sure that that starts happening in the school system. Max?
Yeah,
Oh,
I'll just
I'm
add
sorry.
on, because I do work on quite a few K-12 projects, and I will say that I think you know, having a district that has a vision, and if that will be embraced by architects. And I think, you know, what we try to do is, just like in the mental health space in the Dunn Center, you know, by kind of providing a space that is uplifting to those students, they will, you know, they will perform to that level. So if you give them the nice space, it gives them agency in a way that empowers them.
One more question, please go ahead.
Orla Galvin, AFNA. So a comment and a question. First of all, huge congratulations for patient and caregiver involvement in your project concepts and design. Suzanne, in terms of topics for a recap in the morning, patient in conclusion should definitely be one. But actually something we were speaking about at lunchtime with Samir was the fact that, yes, we're talking about all of these innovations in design and architecture, progressing businesses in all of these like high-powered industries. But what actually about all of our doctors and nurses and medics? And my question to you is, keeping in mind that in neurology, and I'm sure it's the same across the board, we have real issues with the retention of staff in hospital systems and also inviting new young doctors and nurses to take up that vocation. Are you recording any data on the benefits or feedback from those working in these fabulous new buildings? And if you are, can you please share that so that we can say, look what they're doing, we want to do it too?
Yes, so let's start with recruitment, okay, which was where we've been. We started recruiting for this building in November 2021. And those of you from the United States will remember what an incredibly tight labor market it was then. We hired 200 new employees and got the first 2 units open by the beginning of March of the next year. Within just a little over a year, we managed to hire 500 new employees. At the same time, the state hospitals were closing beds because they couldn't even keep the staff that they had. That initial surge I attribute to this building. I absolutely believe that we got this because people in the medical center saw this and they wanted to work in this type of an environment. We'll see what happens with retention, but I absolutely believe it's going to have an effect. And I would also say, do not underestimate the impact that light and lighting in the building has on your affect. The first day we moved people into that building, we were walking out and talking to each other on the way out about how much different our mood felt one day working in this new building compared to the old building. So it had a huge impact on recruitment. I believe it will on retention too.
We need the data. I'll stop talking now, don't worry.
Yeah, we are being pushed off the stage at this point, but this exceptional talent and panelists are going to be around for the rest of the day. So please reach out to them. It's rare for me to even see them all in one city. So thank you all, and I just want to congratulate them on all their work.
And the animation of this panel. We obviously move to a new chapter of, okay. So apparently I've been told we need to delay slightly Samir's introduction. It's probably going to frustrate even more our last panelists. But the idea was to open a new chapter in our today's event and enter into the Brain in the Life course and the life course approach that we wanted to provide to you in terms of the content. And we have as a speaker the former president of the European Pediatric Neurology Society, Samir Zubairi, who is a professor of neurology in Glasgow, Scotland, but he's also a board member of EBC and very actively representing child-related conditions in our organization. I'm just completely unaware of what's going on. But I think Samir is really meant to give a pivotal presentation in order to then allow Walter Korochetz from the NIH to then follow up, providing a more US focus right after, and then we will follow up on panels. And this conversations is going to be continued and will feed into tomorrow. So Samir, I'm really pleased to see that you are mic'd. So you have the floor.
I was going to rely on this, but it doesn't work, so I hope you can hear me. So I'm Samir Zubairi. I'm a pediatric neurologist from Glasgow in Scotland, and I've got 10 minutes to talk about the Brain in the Life course. So there are developmental changes to the normal brain throughout the lifespan independent of disease. So I'll talk about some of these. So you've got this beautiful newborn and this beautiful 86-year-old, and what are the changes that happen? And we need to understand the neuroplasticity and changes in brain structure from birth to the mid-80s to help us understand and promote brain health. So a bit of science for you after the wonderful architecture, not that there's not lots of science in architecture as well. So you've got this neural tube at just a few weeks of age, just a little tube. And then by term, you've got 1 billion brain cells, or 100 billion brain cells, in fact. And you can see how the brain is smooth early on in gestation, and it becomes this cerebral cortex. And what happens in the womb is that your brain cells, these billions of brain cells, move from inside the middle of the brain, and they migrate out to the cerebral cortex on the outside. And they produce this beautiful 6-layered cortex. And that is incredibly complex. And you can imagine then that anything that can disrupt that in the womb can impact on development lifelong. So the newborn brain has all the neurons that you're going to have through your lifetime. And in the first few years of life, what you do is you make trillions of connections. You're making these synapses, trillions of connections. The brain changes most rapidly for the first 3 years of life. And that's why when we talk about adverse childhood experiences in the first 3 years of life, they can be critical for the rest of your life, right through to your 80s and 90s. And we heard in the first talk this morning that even early childhood development can potentially impact on Alzheimer's disease later on in life. So your brain mass continues to grow in childhood. It actually decreases, your gray matter decreases later on in childhood, but your white matter, the connections in your brain, continue to develop right through the 40s into the 50s until late on in adulthood, your brain begins to shrink. This is me looking at one of my friend's babies. We're doing what we call serve and return. Tennis. You serve, the baby gives you back something, you give them back something, they give you back something, and that's how you develop and learn. And that's critical early on in life. So you imagine children that live in poor, deprived communities are unwell, and they don't get that serve and return. And that's what we need. And that's why the synapses that we develop in the first 3 years of life are critical. Then later on in childhood, we prune down and we actually reduce the number of synapses. But the brain continues to develop. You've got this surly-looking teenager from the 1980s who had a bit more hair than I have now. And he was struggling with social relationships, his pals, all these other things. But he was lucky. He didn't have to deal with what Governor Hochul talked about this morning, social media and anxiety. So teenagers are developing that executive functioning, planning, but they're very vulnerable to stresses. And you hope then that they will go on and develop and become mature young adults and contribute to society. There are normal aspects of development that change through life. I was really pleased to see that there was discussion about sleep earlier on and the business grouping earlier on talked about sleep as being really important. Sleep changes throughout childhood. Now I'm from the UK, so obviously I have to quote William Shakespeare in my talk. So 450 years ago, he was talking about the importance of sleep. Gentle sleep, nature's soft nurse, balm of her minds, great nature's second course, chief nourisher in life's feast. So if sleep is not good, if you have problems with your sleep, it affects every aspect of your life, at home and your working day. So really important that we consider sleep. And as you can see, sleep is nicely organized through childhood, through early adult life, but as we get older, our sleep begins to become more problematic. All these complex neurotransmitters, chemicals that control sleep, stop working properly. And we get more problems, so we need to acknowledge that. And also, as we've got Shakespeare here, I think it was really wonderful that someone talked about art and culture in brain health. When times are tight, what happens? Governments stop spending money on arts. They need to spend as much money on arts almost as they do on science, because that's what's really nourishing for our brains. Another thing that changes through life, and this is a project that is cognitive empathy. This is something that not everyone's aware of, a project that one of my colleagues did on 4,500 people throughout the lifespan. Now, as you can see, cognitive empathy, you're probably not surprised, is always higher in women than it is in men throughout life. But it develops through childhood. And I think hopefully in the next session we'll hear about schooling and how education, moral education, social education can help children develop their cognitive empathy. Another interesting feature with cognitive empathy is how it almost drops off a cliff in men when they're in the late 70s or late 65, 70s. Who are our leaders? Who are our policymakers? I won't say any more. Another thing to think about through lifespan, a few weeks ago, I was contacted by Alzheimer Scotland. Now, why would Alzheimer Scotland contact a pediatric neurologist? So Alzheimer Scotland said we're going to have a get-together in December, and we want to think about dementia through the lifespan. And they pointed me to the childhood dementia initiative in Australia. So I would recommend this document, The State of Childhood Dementia in Australia 2024, that has just been published and presented to the Australian government. You think about dementia in childhood? None of us think about that. But there are many, many degenerative brain diseases in childhood. And I think maybe we should be reconceptualizing them as dementias. They're 1 in 2,900 babies. 50% of these children die by the age of 10. And as many children die from dementia as they do from childhood cancer in the US. And we did an audit in our own group and our own hospital a few years ago, and more children were dying under my care and my colleagues' care in neurology than were dying on our cancer ward. But they're largely a hidden burden of disease because they're multiple rare diseases. Rare diseases are hidden if they're not put together. 1 in 6 of us will have a rare disease through our lifetime. So rare diseases are collectively common, and many of them affect the nervous system. So this is in the Children's Hospital Lahore in Pakistan. They see 60,000 patients in their neurology outpatient department per year. About 10% of those patients have degenerative diseases. They have all these inpatients, about 400 have degenerative brain diseases. They even have a part of their ward, which I must say, their neurology ward is better organized than mine in Scotland, in Pakistan, and when we're thinking about design of children's wards. So they have 1,300 beds with 140% bed occupancy. And degenerative brain diseases are a real issue all around the world, but particularly in low and middle income countries. It's a major public health issue. And if we look at the research funding for childhood dementia compared to childhood cancer, 4.5 times greater. So we need to be reconceptualizing and thinking about this. Epilepsy through the life course, we've heard a lot about that, and the IGAP. So one new initiative thinking about is this new Oxford Centre for Global Epilepsy that's just opened in the last couple of months. And the plan is to focus on low and middle income settings and work with stakeholders implementing the IGAP on epilepsy and other neurological disorders. And what my colleague Arjun Sen, who is heading this initiative, said, it's really important because he's thinking about preparing for this tsunami. We've heard this word tsunami a few times today, of epilepsy, particularly in the elderly population with Alzheimer's disease. So I'm going to finish off talking about some of the global initiatives that we are organizing within pediatric neurology. When I was president of the EPNS, we brought together all the child neurology societies from from all the different parts of the world. And we meet together now several times a year to think about programs that we can work on internationally and initiatives. And one of these is the Global Regional Initiative Program, where we're helping train pediatric neurologists in countries where there are no child neurologists. In 27 out of 54 African countries, there's not even one child neurologist. So the GRIP program is helping train these people. Our European Pediatric Neurology Society is working with the Committee of National Advisors in 44 European countries to try and promote the eye gap. So we need to think about prevention, early intervention, and standard of care for every child everywhere around the world. So I think when we're thinking about pediatric neurology or neurological disorders, the key 4 elements are surveillance, prevention, acute care, and rehabilitation. And we should have the same standards of care wherever we are in the world. Thank you.
Thank you very much, Samir. This was a fantastic introduction. Actually, it's putting us in orbit for addressing this second part of the meeting. And Walter, I'm really pleased to invite you on stage. So you are Director at the NIH for Neurological Disorders and Stroke. And we equally invited you to come and talk to us about how to prioritize the life course approach to brain health at the policy level. So over to you.
Very good. So pleasure to talk to you today. What I've heard is music to my ears. Someone interested in brain health my whole life. It's great to have a community already so engaged. Can't really go over everything. I want to get a couple of messages across. Number one, I'm going to talk a little bit about what we know now, the problems we have in moving what we know into practice, and looking through the crystal ball, try and make some predictions about what the future is going to look like. And some of it's rosy, some of it's not. So I'm from the Neurologic Institute. We have multiple institutes at NIH. Turns out that more money at NIH goes into neuroscience than anything else. But it's divided into multiple institutes. So National Institute of Aging, lots of neuroscience going on there. We're 100% neuroscience. Child Health and Development is neuroscience. Cancer Institute is neuroscience. But it is the biggest area of science. It's the area where most PhDs are now going into. If they pick an area, the most popular is neuroscience. So there's this tremendous science force that's coming from the bottom up because people are interested in understanding the nervous system and its disorders. What that means for all of us is that there's going to be lots of opportunities to pick from these discoveries as we move forward. And the bottleneck is there's going to be a lot of things to pick from, and how do we choose which ones we pick. I don't have to go through this again. Folks talked about this throughout, the burden of disease in neurologic, mental health disorders, brain disorders. It's really the largest cause of disability in the world, and it is also, some of these things are one of the major causes of death. As Samir said, the brain disorders span the spectrum, and as he said, early childhood is a real peak, and we lose a lot of kids due to these rare diseases that cause brain degeneration and eventually death. But then epilepsy comes on in adolescence, head trauma begins, multiple sclerosis starts in young adulthood, stroke. There's actually more stroke in neonates than there are in anybody until you get to age 55. The major cause of cerebral palsy is stroke in neonates. And then you get to adulthood where you develop the neurodegenerative diseases like Parkinson's, ALS, Alzheimer's disease, going into old age. Okay, so substance use disorder, clearly for the US, really big problem, trying to make a difference there. I call it an iatrogenic brain disorder. People are volunteering to take a substance that rewires their brain, and it's really hard to get that rewire to go back again. Headache, if you look at the disorders that cause disability, lost work, and the least amount of research going to it, it's headache. traumatic brain injury, a lot of work being done in that space, particularly after the conflicts in Iraq and Afghanistan. So just a couple of comments. One issue that I think policymakers are going to have to deal with at one point in time is that in the US, anybody with dementia was called Alzheimer's disease. Turns out when you actually look to see, for instance, when you enroll people in trials for Alzheimer's disease, you look and see if they have amyloid in their PET scans, the failure rate is about 50%. It's 75% in African Americans in one trial. So that means that 50 to 75% of people who were thought to have mild cognitive impairment or early Alzheimer's disease did not have Alzheimer's disease. So what do they have? It's usually a combination of things. So Alzheimer's is a big one. The other one is vascular brain injury, which is very common. And as you get older, there's actually a more predominance of vascular brain injury in the brain at death than there is oftentimes Alzheimer's. And then Lewy body dementia, which is, Lewy bodies are the aggregates that occur in Parkinson's. It's a protein called synuclein. Recently, the important point to make here is that there are now biomarkers for all of these pathologies. So there are biomarkers that are highly accurate at predicting if you're going to have Alzheimer's disease, that is whether you have amyloid in your head. These are blood tests. They were initially PET scans. Now there's blood tests have been validated. So right now, I think that anyone who wished could get screened and know their risk of developing Alzheimer's disease within the next 10 years. So how that's going to affect policymakers, insurance companies, healthcare providers, patients, unclear right now. Lewy body dementia is Parkinson's disease. Turns out there's a spinal fluid test that's 97% accurate at detecting Lewy bodies in your brain as a sign of Parkinson's. But in the case of Alzheimer's, as well as in this synuclein assay, the test becomes positive decades before you get the disease. In vascular cognitive impairment, the MRI scan shows it's very good at showing what the deficits are. A little bit hard to know exactly what the deficits are going to lead to, but the point is that there are now biomarkers for each of these major three causes of dementia, and that's going to really change how we diagnose cases, apportion them to treatments, but I think also in terms of prevention, we're going to have to realize, what it is that we're going to be doing to try and prevent these disorders. And I want to I talk to everybody about this. George, I keep talking to George. He doesn't buy it, but I'm telling him it's important. Blood pressure control. If you want to make a dent in dementia, what you can do today is in your population, make sure everybody has their blood pressure under control. Blood pressure is basically the force that's going, the blood vessels are pounding every pulse that you have. And if you have high blood pressure, that's a wear and tear on the blood vessels. And that causes lots of problems, some of which you can see on MRI scan, but some of which may be affecting brain blood flow and affect other disorders as well. There was a study called the SPRINT Mind study a couple of years ago where we randomized people to aggressive blood pressure lowering. That means less than 120 versus the standard, which is 140 systolic. And the finding is that the aggressive blood pressure lowering decreased your risk of cognitive impairment and dementia. And so, but we had to stop the trial. You know why we had to stop the trial? Because it also prevented death. And you couldn't continue the trial because it was unethical, because we knew that the aggressive blood pressure lowering prevented death. And that was usually due to heart attack or stroke. So lowering blood pressures might be one of the easiest things we could do to decrease the risk of death, stroke, neurologic disability, and cognitive impairment as people become older. Now, the problem is we've known this for decades, and it hasn't really taken effect. I just looking, the last data that there is, the number of people with high blood pressure who are controlled is somewhere between 37 and 40%. So the majority of people with high blood pressure are not even in control, and by control, meaning 140, so not aggressive blood pressure lowering. And it doesn't account for the people who have high blood pressure and they're not actually in the study because they don't know they have high blood pressure. So this would be, I think, a public health campaign. Know your blood pressure, know your numbers, that could really have a big impact. we have been working to try and get the message out, focusing on different groups. Now we're focusing on middle-aged African Americans because they have the greatest risk of vascular problems. And in all the data we have, the greatest input on the risk occurs in middle age. So you're trying to tell people who think they're invulnerable still and not thinking about cognitive impairment or dementia, but that's where we need to start, in middle age. The SPRINT trial worked in older folks, so it's not that it doesn't work in older folks, but all the data points out that it'll be much more effective if we can move into middle age. The other area in the US, if people are interested, is that there are parts of the country where the health care is terrible and the health outcomes are terrible. We call it the stroke belt. It's the area of southeastern United States. Stroke risks are sky high, maybe triple. Stroke mortality might be triple what it is in, say, the Midwest or the West or the Northeast. And we've known this for decades, and yet no, we haven't made a dent in it. And again, we think that the simple measures would be the ones that are going to make a difference in the space. So what we're trying to do, and our institute, is to try and build programs that will be effective in these communities, but it's got to be done differently, like we do as compared to what we do in the university settings. We understand that the communities we're trying to reach don't actually trust us and things aren't working. So we need a new way of getting into that space to be able to make a difference, which means working with the communities and moving in the directions that they want to move, not necessarily, being so rigid on our end. In terms of global health, these issues that were talked about are, even worse in many countries, and so there's so much to do, particularly in undeveloped countries. We have done some research in the global health space. We have programs in trying to better treat epilepsy in Nigeria. We have medical groups in epilepsy in Zambia, stroke group in Nigeria. But scaling up is certainly difficult, hard to see how we do that. But we're very interested in working with other groups to do that. And we do have some really good programs over in sub-Saharan Africa right now. We're embarking on a strategy to improve our global health over the next year. And lastly, we talked about this a second ago, which was the crisis of opioid overdose. People may or may not know that this started out by overprescribing physicians for people who complained of pain. And I don't know if people know that in 1898, we were actually in a worse problem where something like 30% of women in the US were addicted to opioids because doctors were just handing it out to women for almost any kind of complaint. So we've been in this problem before with opioids, and we need more effective treatments for pain. It's not clear that opioids actually help chronic pain at all, but they're kind of a default, so people take them, and it may actually make things worse. So the HEAL initiative is something that we're working on. Dr. Volkow is working primarily to reduce the opioid overdoses. We're working primarily to develop more effective pain therapeutics and pain treatment strategies that are less addictive. So another program that I think, again, can make a really big difference if policymakers can adopt some of the research coming out of this program. And finally, looking into the crystal ball, I would say that neuroscience is completely different now than it was 10 years ago. And that's because of what's called the Brain Initiative. So if you think about the disorders we're talking about, the patients are suffering. Why are they suffering? They're suffering because circuits in the brain are not functioning like they should. We had no way of interrogating those circuits. People had autism, schizophrenia, depression. These are epilepsy, pure circuit disorders. Circuits are not functioning. We didn't have a way to measure them. The Brain Initiative actually gave us the tools to do that. So now, at least in the animal experiments, we can record from millions of neurons simultaneously. We can understand what their firing rates are doing in different circuits. We can then go in and we can find out which neurons are driving what circuits. We can turn those neurons off. We can make a mouse forget what happened to him, and we can also make a mouse believe that something happened to him that didn't happen. So the power of modulating these circuits is tremendous at this point in the animals. In the humans, We don't have the same kind of techniques that we can go in invasively and record and modulate neurons yet, but I think it's coming. What we have now is electrical measures, and this is just one example of what's come out. There's with a New England Journal paper, a person with amyotrophic lateral sclerosis who cannot talk because he's paralyzed, but electrodes in his brain were able to take the firing pattern out of his brain, send it through a neural network, send it through a large language network, and then out it could go to a computer, and he could talk almost in real time. And they captured his voice from before when he could talk, and so the computer sounds just like him. So it's not real time because it shows up on a computer, he hits a green button saying, yeah, that's what I want, and then the voice comes out. So it's really quite amazing. But this is just one example of what the Brain Initiative is allowing people to do now by interrogating circuits. Modulating circuits is also very active in the Brain Initiative. We have had people who have severe chronic pain. They have a device that can detect the pain signal in their brain. That turns on the device and the pain goes away. So the gentleman who presented said he can feel the pain coming on and then bang, it goes off. Or a patient who had severe obsessive compulsive disorder, completely disabled, now with brain stimulation is able to function normally. Depression, similarly. So these psychiatric, what we call psychiatric disorders, which are basically neurologic disorders that people didn't understand, but basically these are now open towards to real circuit manipulation for health. Which also brings the point that they're also open for circuit manipulation for nefarious means. So that's a secondary issue that society is going to have to deal with, but you can hook up someone so they can talk. You could hook up a fighter jet pilot so he can drive an airplane faster. So there's lots of things that society is going to have to deal with as these tools come out. I'm going to end up by the other area which is coming to neuroscience, and that is genomic therapies. So the problem with small molecules are when you give somebody a drug, they go everywhere. The drugs are stupid. They do not know where to go. The gene therapies know exactly where to go. You can design them so they only go in the cells you want, and they only get turned on when you want to turn them on. And you can turn them off in some occasion. And that's what's coming down the road. This is starting in people who have severe, the therapies are starting in kids who have severe neurological disorders that are going to die because there is no other therapy, but we're working on gene therapies, we're working on gene editing therapies, and once these inroads are made and we understand how to do this safely, I think we're going to make a big difference for these rare disorders. We have to learn, figure out how to scale up. That's our big problem for the policymakers. Spinal muscular atrophy, a fatal disease in children, is now curable with the gene therapy. I have 400 rare diseases in my portfolio, and the families all come and say, if we have a therapy for spinal muscular atrophy, what about my kid? And I don't have an answer for that. It's just a matter, I just say it's a matter of time, but they don't have time. So we got to figure out how to move this thing faster. The difference is in drugs, the IP is on the molecule, which the companies spend years and years developing. In gene therapy, there is no IP on the gene. So it is possible to short circuit and move things quickly in a very different manner. There's a paper by Jennifer Doudna, who got the Nobel Prize for CRISPR technologies, that came out in Nature. It's called How to Make Pediatric Therapies Affordable. And I urge people to take a look at it as a possible new way of going. So those are the points I wanted to make, and a lot more to say, but great.
Thank you. Thank you very much, Walter. It was really a thorough overview, and thanks for providing this insight and the gamut of activities that you have, but also the key priorities. It's very informative in us opening this life course approach. We'll start obviously with childhood and maybe a deep dive. We stay in the US, but we are going to invite colleagues from Hazel Health to run their panel on how school-centered care boosts US economic power. So it's really the story about how interventions at early stage of life can be impactful in that context. So I'm really pleased to welcome Andrew Post. Andrew, you're the president of Hazel Health, so you'll be moderating this panel, so you have the floor. Over to you.
There we go. Can you hear me? No? Yes, you can hear me. All right. I was a teacher. That is how I started my career. So this is the last panel after 2 keynotes. It looks like you are all fired up. It is either for this panel or it is the fact that the bar was set up 30 minutes ago. Either way, we will take it, and we are excited. Before we get into the panel, I have the great privilege and honor of introducing 2 keynotes. The first is going to be Lieutenant Governor Coleman from Kentucky. She is the 58th Lieutenant Governor of Kentucky. She is a lifelong Kentuckian, educator, basketball coach, writer, and founder of a nonprofit. As the state's highest elected leader, Lieutenant Governor Coleman is a vocal and passionate advocate for public education. She believes education is the key to providing Kentuckians opportunities for transformational change that can create new cycles of success. During her first term, through the Team Kentucky Student Mental Health Initiative, she worked with student leaders to secure more than $40 million in federal funding to increase student mental health resources in schools across the Commonwealth. It is my privilege and pleasure to introduce Lieutenant Governor Coleman.
Thank you. Good afternoon. Let's see. There we go. All right. It is an honor to join you all today to discuss the omnipresent issue of youth mental health. With every passing year, the challenge grows. And if there was ever proof of that, it is this profound yet alarming statement by the United Nations. Even the greatest minds in the world recognize that the future of our countries and world economies depend on us getting this right, and that is what brings us all here today. As you are all too aware, mental health challenges were not caused by the pandemic, they were simply exacerbated. The CDC reported in 2018 that even as 1 in 5 young people received a mental health diagnosis, only 20% of them received treatment. By the end of 2020, behavior issues increased by 21%. Now, I might have been a new lieutenant governor at the time, but I was an experienced teacher. So I knew these challenges would eventually make their way back to the classroom. And more adults began to come to grips with this reality, and youth mental health began to dominate our conversations. But what I recognized is that it was always adults talking to other adults. So I set out to change that, and the Kentucky Student Mental Health Initiative was born. Pictured here is a part of the group that led that work, because that was my one requirement. If we were going to set out to tackle the growing issue of youth mental health in Kentucky, then we were going to do it by listening to young people. The student leaders met and planned regional action summits to hear directly from their peers. They developed the questions. They facilitated the conversations at all 10 of the action summits across Kentucky. Now, we were a little bit ahead of the curve because as our student leaders dove into the data they collected at the regional action summits, major research was being published around youth mental health. And the guidance wasn't just groundbreaking, it was reaffirming to our student leaders. These national reports produced by renowned experts in the mental health space served as proof that Kentucky's Student Mental Health Initiative was on the right track. So without further ado, here are the Student Mental Health Initiative policy recommendations. You can capture this QR code to see more specifics with our one-pager. I want to point out that including and elevating student voice was paramount to the development of the Kentucky Student Mental Health Initiative, but it also remains the foundation of our work. The emphasis on improving suicide prevention was resounding, allowing mental health excused absences, providing more and better mental health services in schools, increasing awareness and education to reduce the stigma, and improving professional development so that faculty and staff can recognize and refer students who may be suffering in silence were the common themes that were highlighted by our student leaders. So next, the Kentucky Student Mental Health Initiative hit the road. We presented the students' policy recommendations to the federal government, state agencies, legislative committees, and community partners. That spring, our students hosted the first Mental Health Awareness Month at the Capitol, where Governor Beshear signed House Bill 44, a student-led bipartisan bill that allowed school boards to adopt language around offering mental health absences, which was one of our major policy recommendations. Meanwhile, more research was being produced. As we emerged from the pandemic, the Pew Research Center reported that the #1 concern for parents across the country was their child's mental health. And statistics showed that students were 6 times more likely to access mental health services when they're available at their school, which made us even more determined than ever to find the funding that our schools so desperately needed. So, along with our partners at SAMHSA, the Substance Abuse and Mental Health Administration, Kentucky Student Mental Health Initiative helped secure $42 million in federal funding to expand school-based mental health services in Kentucky schools. And we are not done yet. This year, Kentucky was one of 6 states selected for the National Governors Association Youth Mental Health Policy Academy, and recently we received an award of another $2.5 million to facilitate expanded Medicaid billing in schools for mental health services. And here's why that's important. We know that half of Kentucky's children are covered by Medicaid. When Governor Beshear expanded Medicaid access in Kentucky, that allowed our schools to improve coordination between healthcare providers and school districts to address student health needs. But less than 1/3 of Kentucky school districts billed Medicaid services during the 22-23 school year. Aligning Medicaid and the needs of public schools is a complex process. But when we get this right, our schools will receive a 3-to-1 match from the federal government. Simply put, for every $1 a school invests in a mental health counselor, they get a $3 return to expand that access to mental health services for their students. Equipping our schools with the knowledge and access to what is possible presents a real opportunity to improve mental health for a generation of Kentuckians. So our work continues. We will remain focused on addressing funding for school-based mental health services, as well as turning our sights to serving the mental health needs of teachers and school employees. As we prioritize supporting our students' mental health and ensuring our schools have the resources they need to meet this moment, I remain so grateful for our students' work, and I'm proud of their commitment to what the UN has described as the defining issue of our time. So I will leave you with our mantra that drives our work. It is a reminder to be kind because everyone is fighting a battle that you may know nothing about. Thank you so much.
Thank you so much, Lieutenant Governor Coleman. Incredibly inspirational to hear what your office and what your Commonwealth is doing around the youth mental health crisis. Before we bring up our panel, and Lieutenant Governor Coleman will come back for that as well, I wanted to introduce Dr. Alexander Biu, who is the Chief Medical Officer, Government Programs, and Senior Vice President for Population Health and Social Care at United Healthcare. As Chief Medical Officer, he is responsible for the individual care, population health, and provider partnership strategy for UHC's Medicare and Medicaid plans. He also leads UHC's enterprise-wide strategy and capabilities to address individual health-related social needs and community social drivers of health. He is an internal medicine doctor focused on supporting whole person health by delivering coordinated physical, behavioral, and social care, and advancing cross-sector population health strategies and sharing data to foster coordinated learning health systems. So Dr. Biu, thank you so much.
Let's see if this is on. Not yet. Can you hear me now? Oh, you can. Okay, good. Well, thank you, Andrew, for the introduction, and thank you, Lieutenant Governor Coleman, for, I think, a really inspiring stage setting. I think it's appropriate, at least good, that we're ending the day, a long day of talking about the brain with where it starts, talking about children, talking about their development in schools. As you've heard from numerous speakers and panelists throughout the morning and the afternoon, so many long-term challenges that people may face have their nidus in childhood. Mental health for a child is as important as physical health. The two are inextricably tied. And that's why the statistics that you just heard are so troubling. As you heard, the CDC points out that one in five children are suffering from a mental health condition. And challengingly, I think even more sadly, only 1 in 5 of those are actually getting care for their mental health concern. It has major impacts, both for the individual at the moment, but then also their long-term health and development. Importantly, this is at an all-time high. Certainly as we come out of the pandemic and we think about the opioid epidemic and all the pressures, social media included, that our children are facing, we're seeing anxiety and depression and these other challenges really mounting and having their impacts on our children and in schools in a significant manner. So children who face these challenges are 3 times more likely to actually have to repeat a grade. Once you get to high school, high school individuals who are facing depression or symptoms of depression are twice as likely to drop out. There's significant long-term opportunity impacts by having those conditions at an early age. And frankly, many children will have those conditions. Most conditions are showing up, or half of conditions are showing up in somebody's lifetime before somebody enters high school. So there's a significant burden of behavioral health concerns that are manifesting in school. So that's one challenge, and then the challenge is what do we do about it? And unfortunately, the delivery system that we have to meet those demands is fragmented and underpowered. As you heard from Lieutenant Governor Coleman, too often it's challenging to get children to services, whether that's because there aren't enough providers in an area, or because transportation is a barrier, or frankly, just the coverage and reimbursement are a challenge. As a former public health leader myself, I can tell you that it's not for lack of trying, but it is very challenging to get services to the right areas, especially to serve our most underserved and vulnerable populations. And that's why United Healthcare, as a managed care company on underserved Kentucky and many other states, really thinks the opportunity lies in public-private partnerships, where we have the ability to identify these problems and then bring innovation to the table to actually address the challenge. One such innovation we think is the partnership that we have with Hazel Health and their unique capabilities to reach students in their schools at the time that they need services. We were proud earlier in the year to announce a $1.5 million investment in Hazel Health Services that expanded access to mental health services to over 100,000 children, K through 12, in Iowa. That meant that Hazel's system of virtual care, really bringing talented providers into reach of students where they're spending their days, was now able to, or is now going to be able to reach, as I said, hundreds of thousands or 100,000 students across Iowa. Now we're happy to also announce that we're going to expand that partnership further. We want to reach 1 million students, and that's still just the beginning. As we reach more states, more school systems, we have an opportunity to really change care. And why is that? Schools are where 90% of kids are spending their time. It's finding the person where they are at the moment without having to deal with the transportation issues. You don't have to face the challenge of parents who may not be able to get time off of work having to take that time to meet their child in school. And then from an equity standpoint, especially when we think about rural states, we may be able to get really great care in some schools, but how do we ensure that every school has access to top-notch providers that can truly address their concerns? And so leveraging a system like Hazel with telehealth and broad reach is a great opportunity to really even that playing field and ensure that mental health not be a barrier to the opportunities that our children face. And so again, I think these types of public-private partnerships and the opportunity that we can bring to these public health challenges is a significant opportunity that we're really excited to be a part of. And I'm excited to join the panel and answer more more questions about that shortly. So thank you.
All right. Well, I would like to invite the panelists up. And so Dr. Bu, Lieutenant Governor Coleman, Steve Carnevale, who I will give a full introduction to shortly, and Commissioner Angelica Infante-Green, if you wouldn't mind joining us. And then I will give a few quick remarks, and then I will sit down and pepper them with questions. Yeah.
Doesn't matter.
So today we've heard a good deal about the importance of addressing mental health and more broadly brain health. Governor Hochul began with both qualitative and quantitative data on the damaging impacts of unmet mental health needs. Multiple panels have linked the downstream consequences of unmet brain health conditions. The governor and others have issued their plea for partners to not only treat mental and brain health, but go further upstream to create an environment of resilient youth, prepared to thrive in a very different world than we grew up in. And in a world we don't know what it will look like when my 10, 9, and 1-year-old are adults. At Hazel Health, we partner with states, as you just heard in a wonderful announcement from United Healthcare, school districts and health plans to bring physical and mental health care to youth in school and at home, capitalizing on what we refer to as a school-centered care model. Why schools? You heard a little bit recently, but this is not only where children are for almost half of their waking hours each day, but is where caregivers turn when they need support for their children. As you heard from Lieutenant Governor Coleman, children are six times more likely to receive healthcare services when delivered through their schools. But schools cannot be expected to bear the financial burden or operational burden of these services. Today, schools deliver 2 out of 3 meals a day to many children, 60% of vision and hearing screenings, and 70% of mental health services. The states and school districts that Hazel Health partners with across 16 states, soon to be 18, and probably 20 or more by the end of the year, are looking at our partnership not as delivering services, but empowering youth to have a brighter future, their community to have a happier, healthier, wealthier citizens for generations to come. This outlook, as I understand it, if Harris Ayer did his job in explaining brain capital well, is the very spirit of how school-centered care is about broadening the support from mental health to brain health and to power a brain economy. To make this a reality, it takes the partnership of state leaders, school district leaders, and healthcare leaders, along with parents, caregivers, and students. Student voice is essential, as you heard just recently from Kentucky, to build this kind of infrastructure. Today, you will hear from incredible leaders from states with representation for school districts and a health plan that are embracing this opportunity and leading to work to address the youth mental health crisis in a positive way, addressing from prevention to intervention for all youth. With that, it is my honor to welcome our panelists. You have heard from Lieutenant Governor Coleman from Kentucky and Dr. Bu from United Healthcare. A special thank you to Dr. Bu and United Healthcare for their incredible announcement, but more importantly, their unwavering commitment to the national impact of this work. Also joining us is Commissioner Angelica Infante-Green, the Commissioner of Elementary and Secondary Education from Rhode Island, and Steve Carnevale, Commissioner for Mental Health Oversight and Accountability Commission of California. Unfortunately, Senator Katie Hester, who was on the program from Maryland, was unable to join us today as she had a family matter to attend. So without further ado, I will sit down and start peppering our panel with questions. And we are very excited to talk about how school-centered care does boost and can boost the US economy. So the first question goes to you, Commissioner Infante-Green. Leading a Department of Education, you're closely connected to school leaders and students across Rhode Island. What do you want this room to know about what students are experiencing?
I think it's important for all of us to know that our kids are not the same, right? We've heard throughout the day, social media, technology, school safety. Think about what happens when there's a school shooting, what happens to the people in the building. And then the pandemic exacerbated everything. So our students are just not the same. And it's compounded because our teachers are not the same. Our system is under crisis and duress right now. We don't have as many mental health providers as we used to on the ground. And it's just a different landscape. And we're asking teachers to do more every single day, more of what they're not prepared to do. So that is real. That is where we are as a nation. It is very trying. And when you talk to our kids, the depression and the anxiety are off the charts. So we administer a survey to all our students in this entire state, as well as the teachers. And 32% of our students for the last 3 years have said that they feel depressed. 32%. That's huge. So how do we continue to move forward? And we are talking about academics when our kids are struggling day to day to even get to school. And this mental health crisis is also manifested in different ways. Behavior, but as well as chronic absenteeism. It is a crisis in our nation right now. We have never experienced this. Our kids are not coming to school, and that's where the services are. The services are in the school, especially for our population that come from an economically deprived community. It's in the school, and we want to be able to provide those services at home as well. And they don't always go together. And they're not always available, not just in rural, but in urban. The amount of care that is needed right now, we just can't keep up with it. We have Bradley, a hospital, which was the first psychiatric institution for for children in the nation, and can't keep up. We're in a different place. And I think that as we start thinking about schooling and the services, it has to be intertwined. There is not nice to have, it is a must if we're gonna continue to move forward.
Thank you so much. And how does that reality of experience impact not only their futures, but the nation's future?
Well, I'll tell you, if you've seen the PISA scores, they're the lowest they've ever been. Math scores, the US, and all of them have gone down. The kids can't be in the classroom worrying about their academics when they are worried about just getting out of bed, making it to school, really what's happening, the level of anxiety. Technology, it's different. Our kids, their attention span is very short right now. Getting them to really focus in on what they need to be doing in the school, but you can't do that divorce of the mental health support. So we're thinking about what is happening. When you talk about the impact, when our kids are not coming to school for more than 30 days, when a school year is 180 days, we're in a crisis right now. And if you talk to higher ed or employers of our kids recently leaving our system, they've lost social skills. It is a crisis for us. The workforce is different. Working from home has changed also how people interact. So we're in a very different space where we have to relearn things, we have to shift and adjust. If not, it's going to impact, or it is already impacting our schools, our workforce, and what does it look like for us as a nation and as a world, as the whole, the globe.
And so thankfully for the children of Rhode Island, you are an action-oriented leader. And
I am.
So you are. And so can you tell us how you play a central role in connecting federal, state, and local policy, practice, and funding to exemplify how you're approaching addressing the youth mental health crisis across your state?
Yeah, several ways. So we also got SAMHSA grants. We got $50 million to really work with our schools to make sure that it is student-led. Our students helped us, and they said, if we have 1 or 2 caring adults in a building, that matters to us. Doesn't have to be a teacher, but that matters. So we made that a priority for us. So we have this huge campaign, getting more mental health providers in the school system, but also making those other connections, using our survey data to make the changes that are important. We heard today about spaces. So we used our, what we call COVID money, our ESSER dollars, and we invested in buildings. And what we invested is what the spaces look like. So we have our own campaign in Rhode Island of having new buildings, but at the old buildings, how do we change that? What does it look like? We have wellness rooms for our teachers and our students. We changed what the lighting looks like, those fluorescent lights, very problematic. You know, if you don't have a lot of money, invest in that. So we have done that across the board in all our schools. So you have old buildings that you can't have all these new innovation, but you can retrofit things. There's spaces where kids need to go and have a few minutes. There are places where there's sensory, where we're really bringing the noise down. So there's a lot of things that we can do, that we have done, but we've really prioritized this, and it has really been important to us. We cannot have the learning, and then there's teachers. We're expecting teachers to do things that they weren't trained to do. So one of the things that we did is that we worked with Yale University to create courses for teachers. So our teachers in the state of Rhode Island have 10-hour courses on how to integrate this into the actual instructional practice. Because you don't want to just have this therapeutic session, but how does that play out in the classroom? How do we know how our kids are feeling when they walk in? How do we really instruct them? So all of our teachers, bus drivers, school kitchen workers, everyone across our system, anyone that touches a student, has to take these courses, because it is really important for us to know what to do. What are the signs? How do we work? What kind of conversations? We're not trained to do that as educators, but this is where we are, and we have invested in that. And we will continue to invest to make sure that these things become part of, these initiatives become part of our everyday schooling, not just when the money goes away. This is something that we are lobbying for. And to have the mental health supports when the kids need it, how they need it. You know, a lot of our kids really rely on virtual. Telehealth has become something that some people may like or not like, but there is some supports. Our kids have told us that that's important to them, to have a person to connect to outside of the school day as well. So we're investing in that. We are looking at what are the next level of supports. So we're seeing this as our new instructional practice, not just something that's here in mental health, but something that is part of our everyday instruction.
That's amazing, and just very happy that the students of Rhode Island have someone that is looking out for them, so thank you. Lieutenant Governor Coleman, earlier you spoke about the roles states play in addressing youth mental health. Can you tell us more about why you believe that work should be centered in schools?
So I think very simply, we're talking about meeting people where they are. I mentioned in the presentation that our students are 6 times more likely to access mental health services when they are available in their schools, which just makes sense when you think about the removal of barriers, right? Transportation, insurance, appointments, parents' work schedules, all of those things are now not a factor because those services are available in the schools where the kids spend most of their days. And so making sure that we continue to focus on meeting these kids where they are, meeting people where they are in general, will only increase the impact that those mental health services can have for our students. And we're talking a generational difference that we can make by doing this.
Yeah, couldn't agree more. And you've announced again today that $42 million of funding for student mental health across the Commonwealth. What's the impact to date that you have seen of that?
And I want to reiterate that $42 million was federal funding, but the reason that we were able to access it is because of our student leaders, because of their policy recommendations. They're the ones that did the work. And so, you know, I'm very proud of them for that. And I know they're very proud of that work too, because that's work that's going to, you know, pay dividends down the road. When it comes to this funding, the way that we are using it in Kentucky is our K-12 public schools and the public universities and colleges in a region are partnering together. So our colleges and universities are going out and recruiting mental health majors and bringing them into the pipeline. This funding is utilized to graduate these students debt-free, with the agreement that they will be placed in a K-12 school in that region to provide mental health services for students. And so we're literally using this funding to build a pipeline of mental health counselors because, as the commissioner pointed out, we don't have enough. So to date, we have had 30 mental health counselors placed in 30 different school districts across Kentucky. And we have another 40 who are currently in what I would call the education and workforce development pipeline. So they're either in an internship, they're already working in a school, and so we are certifying them, reskilling, upskilling them to be able to provide services in a different way. We are truly trying to tap into every resource that we can possibly find to help provide these services. And I think another good point to make, and you kind of hit on this a little bit, Commissioner, is this should not be something else that we put on classroom teachers' plates. As a matter of fact, it cannot be. They're not trained for this. This is not their job. They can be a great partner in recognizing challenges and referring students to the professionals, which is what we need them to do. But this is not to place anything else on the backs of teachers. It is truly to provide those, wraparound services so that our schools are serving the whole child, not just academic needs, but the whole child's needs.
Yeah, I think that's such an important point, Lieutenant Governor, because I'll go one step further. As a former classroom teacher, like I know you are, we already play or have played all of those roles beyond actually just teaching and learning.
Beyond.
Way beyond. But I will also say the school in and of itself cannot be responsible for delivering and accounting for and doing all of the healthcare. There has to be help for them to do that, because at the end of the day, they are there to make sure that children are educated and successful. And so it is about kind of the real community effort to make sure that this can be successful. Thank you. Steve, we have now heard from Kentucky. We've heard from Rhode Island. Can you tell us how California has focused heavily on bolstering mental health support across the state, and in particular, expanding support at the school level? Can you tell us more about what you're seeing in terms of rollout, buy-in, and outcomes?
Sure. I don't know what to do without a microphone, being Italian and all.
You got one.
I don't know what to do with my hands.
Wave this.
So let me just back up before I go there and say, I think the punchline to this for me, for school systems, is mental health. And the reason I got to that is I started this. I'm a venture capitalist by background, but I started this with a dyslexic child identified in kindergarten. This put me on this 20-year trajectory. I started the UCSF Dyslexia Center that brings neuroscience to try to figure out where the root cause of dyslexia is inside the brain, which nobody has done until we did it. And I thought that was enough to solve our literacy crisis, which I didn't really know about until I got in the school system. And I thought, well, the problem is 20% of our kids are dyslexic. But it turns out 2/3 of our kids, don't pass the 3rd grade reading scores, and they have underserved lives, underdeveloped lives. So then I thought for a long time it was science of reading. So you go into a classroom, I've been to superintendents and say, you ought to teach your kids how to read. And they say, well, we'd love to do that, but we don't have enough time in our classroom day. It's like, okay, well, how does that work? If they can't read, what are they doing? But anyway, so then I start this center, and it turns out that in California, one of our famous dyslexic learners is our now Governor Gavin Newsom, who was mayor of San Francisco at the time. So he helped me build this, and so he knows a lot about learning differences, and he knows a lot about neuroscience. And then he appointed me to the Mental Health Commission. Until that point, it's like, if you're a hammer, you're looking for nails. But then I start looking through this problem through mental health and understanding what I understand about neuroscience and realizing that this is all about mental health. Our kids are not coming to school ready to learn. And the frustration is we can do this today. It's just that these systems are so broken that they're not making available the services that we now know we have to address the problem. So Governor Newsom, we have a large state. We spend $12 billion a year just on mental health alone. And the commission I sit on, which is an independent body, has about 1/3 of that funding that it flows through to the system. Governor Newsom, when he came into office, has put in unprecedented money into all things youth-related, $5 billion into just one single program and billions more into mental health. And so there's a lot of money that's been put into youth programs, and the Mental Health Commission has all kinds of school-based mental health programs, too many to really list, but I'll just talk about one, which is that we don't talk enough about, which is elevating youth voice. You know, our kids have opinions. They may be fragile, but they're pretty smart. And we don't elevate youth voice. We talk about how we're designing a system for them, but we don't ask them how to design the system and deliver their needs. So I think the punchline for me is that our kids need to come to school to be in a position to learn. We now have technology, by the way, that can read that objectively. We don't just have to ask them. We can measure their brains, and we know if they're in a condition where the social determinants of health are putting them in this fight and flight mode, or they're ready to really settle down and to start learning in class. And if they're not, we should divert them to the wellness center and then bring them back when they're ready, because it's a waste of time. So I think the answer to education is that teachers do not have enough time, but AI does a better job of delivering content. And so I will provocatively say that the teachers themselves should be not the behavioral health therapists, but they should be the first stop on that journey. They should have a relationship with all of their children. They should be their advocates. They should be making sure our children have what they need in school, and we should be engaging in whatever mental health services they need, because we know that the investment early in childhood pays off magnificently downstream, and it doesn't matter what side of the aisle you're on, it's a great thing to do.
Yeah, I think it's a great point. You started to allude to one that we won't have time for today, but even making sure that those who care for our kids are cared for as well. And I know we could really make sure no one gets a drink tonight if we want to go down that rabbit hole. But instead of doing that right now, thank you very much, and I will come back to you in a minute. Dr. Bu, you just talked about, and again, thank you to Hazel as well, but United Healthcare has been investing significantly in expanding access to school mental health supports broadly. Why is UHC, as a healthcare company, focused on schools as a point of intervention?
Yeah, well, I think there's probably two big reasons that I would call out. So one is we see a significant challenge. As I talked about, more than 50% of lifelong mental health conditions are going to be experienced or start before somebody enters high school. Sadly, it takes about 11 years on average for us to move from symptoms to actual diagnosis. And so when you think about, well, what does it look like when we finally get diagnosis? Those are the people in the emergency room. Those are the people who need now inpatient hospitalizations. And that's not the right way for someone to get care once their disease has progressed to some state that it's so obvious that now you're in the emergency room and you have to get care. We need to be reaching upstream. We need to be reaching people earlier. And so for that, we need to find how do we partner with the people who are serving children. So certainly as a healthcare company, we start with pediatricians. We start with the built healthcare system and continue to do that. But the reality is it's kind of like the analogy of the person looking for their car keys under the light, the street lamp, when the car keys may be somewhere else. We don't have people going in the volumes that they need to for their annual well visits, for their vaccinations, to those community providers. But where we do see kids going is to school. There's a whole infrastructure to really reduce absenteeism. And so we think that that's a huge opportunity to leverage, not to put the burden on the teachers, but to say, look, we've got an audience here. This is the time to reach them. Also take a burden off of their caregivers who might have to, again, shuttle them around to these appointments. I can vouch for that. And so really, how do we reach them at that point? And so for us, that just makes sense that the delivery at the school is the best way to reach folks.
Yeah, and I will say, and then I will ask the last question to the panelists. When I came over from public education to healthcare, I was told that healthcare doesn't focus much of the conversation, at least, on pediatrics. And I was shocked. I was like, there's no way that could possibly be true. Then again, my entire world was children. So, and then I went to a healthcare conference and realized, wow, there's one person on one panel in 4 days on talking about children. And realize that, but what you all are doing, again, with Hazel, but more broadly, really is just commendable that this conversation has made it there with healthcare and health plans to say, this is a population we need to focus on, and now is the time to do that. So we have really enjoyed seeing that evolution across the board. So because I know we have wonderful superintendents also in the room today, raise your hand or clap or scream or do what you do, and you're a superintendent in the room. Thank you. There we go. I do want to give a couple minutes for questions, even though we're over. So let me ask one more question to you all. And hopefully it ends us on a very positive, hopeful note. What's your final word on why school-based interventions are central to building a more resilient, prosperous future generation? So I will start with Dr. Viu and come down this way.
Well, I'll be short and just say I think it's where the students are, and just as we think about the impact of that, I'm an internist, so I do see things through adult eyes. As we think about the impact of health on jobs and somebody being able to show up to work, the most important things that our children can do is really prepare themselves for their life in school. So it just makes sense to be reaching them and supporting them staying in that place, focused on their future.
I would say two things, and I probably say this every single day, but the future of the U.S. economy is in our classrooms today. And that's how we should look at education, is understanding that that's where our future is. But I would also say, when it comes to making sure that our students have what they need, we've got to also make sure that the people around them have what they need. So when we talk about teachers, school employees, those types of things, we're all in this together. But ultimately, the future of the U.S. economy is in our classrooms today.
Well, I would ditto. And we realized early on, Rhode Island was one of the few, we were only closed during the pandemic for 3 months. We have been open the entire time because what we saw were screens off, kids shutting down. The need was so great that we came back. June, everybody was back in the classrooms, running summer school. We were doing all of that because we understood the need. And we are seeing some of those skills that were lost, even though we were there. The anxiety was still there, all those things are there, and we're seeing it in our workforce. So what happens in the school is important throughout everyday life, but it affects our workforce. And we're seeing that the kids that are coming out now are less resilient. So if we don't focus on what happens in the schools, we're gonna be feeling the reverberations for years to come. So everyone that's out there, this is the place to invest, support, and help guide.
I would say that we are on the precipice of this extraordinary golden age of neuroscience, of understanding the brain. We all wake up every day thinking about our heart and exercising, eating well and all that, but we don't think about the brain. And that starts in the classroom. We're teaching life skills. We no longer need to deliver content in the classroom. That's going to be all available. But teaching foundational literacy skills, math skills is even more important. And those are worse than the literacy skills. About 15% of kids have adequate math skills in the 21st century. And it's mental health. It's managing our brain. And so we have this duality today where people don't think about their brain. And yet everything we are, not just analytically, but in terms of our social, emotional beings, all come out of our brain. And it's in school where we need to learn the skills that last a lifetime. So I think that is literally job one.
Very good. And so I love these because I get to take quotes. I will properly quote who it came from, but the future of the U.S. economy are in our classrooms today. I think that is a really great way to sum up not only why we are investing and talking about school-based care, but also the connection to brain economy and brain capital and brain health. And so thank you all so much. Question, we will take 3, I don't think we're supposed to, but we're gonna take 2 questions. I was told 2. There's 2 hands right here in front of me. So I don't know if they get to do it, but they're first.
Hi, hi, my name is Anita Burgos. I'm the Director of Policy for the National Alliance on Mental Illness. My question was for the Commissioner. I know that you got your start as a, or not start, but in your career you were a bilingual educator, and so was curious how that impacts your approach to your current job and how, to meet the needs of Latino students and other kind of communities that might have unique needs.
Yeah, so I started off as a bilingual teacher. I have an autistic son who is completely and totally bilingual. That is extremely important. And I know that you were talking about the brain, and he's dyslexic too, because when you're autistic, you have so many different gifts. And, but language is very important. So when we start thinking about the brain, that is a key place to start. And I am a proponent of everyone speaking 2 and 3 languages. And the Latino community with mental health supports, there's a lot of education that we have to do. It's a very closed community in terms of we're not going to share, that we can't go out of our circle. And that's a lot of work that still needs to continue to happen. And having these conversations, I will tell you, when my son was first diagnosed with autism, I went out there and I spoke to the parents because nobody talks about those things. It was like shameful in some ways, especially in the Latino community. And so I put out a YouTube video with some parents, and it's okay. It's okay to talk about these things. It is real. And I was flooded by the Latino community saying, thank you for talking about it. There's still a stigma in that community that isn't as prevalent in other communities. So that is one of my passions, my goal. Being bilingual, speaking more than 2 and 3 languages. When my son was diagnosed, I was told that I was doing him a disservice. And I said, okay, thank you. I'm going to do what I'm going to do. And he's 17 today, and he speaks, Spanish fluently. And now he is the vice president of the French club.
That's amazing. If I can add, because this is a really important topic. In California, 40% of kids speak another language at home. So this is a big issue for California. Governor Newsom funded a neurological-based learning screener for kindergartners. And one of the things we found is that you can't just take a screener in English and translate it for the language. They have to be culturally responsive, and the brain develops different with different languages. And so you've really got to understand the neurology, and then you've got to pay attention. In San Francisco, there are 75 different languages spoken at home. So it's a complex, and this is the future of America, except the future is now.
We're going to
So
excuse,
if I could just.
We're going to excuse Dr. View. He does have to run, but thank you so much. Go ahead.
Well, thank you, everyone. Michael Martino. I'm an MD, PhD student at MUSC in Charleston. And my question is, it's really inspiring to see people in your positions doing this incredible work that needs to be done for our youth. What can people who are not directly involved in politics but are really interested in elevating the voices of youth do to get involved in our local communities, in our states, to start laying the groundwork for some of this important work that people like yourselves are doing, when maybe the greater community or the local politics are not putting that as a priority?
Well, I'll start because I don't consider myself a politician. Giving them platforms to have the conversation, right? Finding opportunities, whether it's in the business sector, whether it's in a community group. What are the things that are important to the youth? How can they lead in this area? People that make policy and politicians need to hear that voice, because we're always trying to solve problems that we are not experiencing. We are not teenagers anymore. I'm not 9. So I have to ask. We have to say, what works for you? And it is a different generation. So creating those opportunities wherever you sit, whether you're a PhD student, do some of that work. And then elevate it. Find ways in different sectors to have that conversation and bring it to the politicians that actually do make policy and pass laws. That's really important.
So I can say in Kentucky, Governor Beshear and I are the only Democrats elected statewide, and there's a supermajority of Republicans in the House and the Senate in Kentucky. We're the only Democrats elected in our positions in the entire South. So I know a little bit about navigating the political headwinds here, but also this should not be a political issue, right? And so the way that you talk about it matters, the words that you use matter, and you heard me say the future of the U.S. economy is in our classrooms today. That, I say that for a lot of reasons, but mainly because it hits home with folks who are across the aisle. And so if I have to talk about it differently, I'll talk about it differently, right? But ultimately, you as a community member, as a citizen, I wouldn't think, the problem is so broad and systems are so big. You know, we eat an elephant one bite at a time, right? And so I think it's something as simple as going to your local school district and saying, I would like to, you know, to advocate for students. I'd like to mentor a student who you think needs a little extra help. I'd like to volunteer to do X, Y, and Z. Because don't ever underestimate the difference that you can make in a child's life by showing up and saying, how can I help? What can I do? If everybody that had a negative thing to say about, you know, that generation or schools did that for one day, we probably wouldn't be up here right now talking about this, right? And so don't ever underestimate the difference that walking into a school and saying, how can I help? Is there a student that could use a mentor? I would love to help, would make in that child's life. Yeah.
I would just add that I get frustrated because we always say our kids are our treasure, but we don't do enough about it, right? Yeah. And the reality is that what matters are votes, and kids don't vote. But what I've seen make change in the system are mobs of angry moms. Mobs of angry moms have literally moved law and getting people organized. It doesn't take money, it takes organization of people. Yeah. And even in California, as big as California is, you can march down to Sacramento and legislators are very open to talking about these issues, and they will. I'm surprised at how much they will be impacted by these conversations. So there's a lot you can do if you want to do something.
And I am certain we could go on, and next year we'll move the panel to the front of the day so we can dominate time. But really do appreciate all of your time today, and to the panelists, thank you so much, not only for being here and having this conversation, but being such a staunch advocate for children and doing the hard work that needs to be done. Thank you.
And thank you very much, Andrew, and congratulations on keeping the attention high in spite of the fact that the bar was nearly going to be open. But I'll simply would like to take still a few minutes of your time because we heard from Kena Inamoto in opening her speech that the feelings and the emotions that we have are extremely important on how we learn and how we memorize. So I'd like to ask across the room impressions and maybe in one word how you feel after today's discussions. Maybe I can give the mic to you. How do you feel after today? Don't laugh because you'll be the next one.
I feel hopeful because ultimately, yeah, I mean, the power is, well, the future is now. That was just said on the panel.
Okay, thank you. Hopeful.
It's just good to hear different voices. I feel like I'm talking to the same people often, so it's just nice to hear from different perspectives.
Great. Thank you. Maybe you can pass the mic behind. One word.
One word. Cross collaboration between these disciplines is great.
Okay, cool. And sir?
Inspired.
Okay. Hala? Go ahead. You deserve one.
I'm excited to see what we can do. Yeah, I'm very excited.
Okay. Did you get the answers you wanted? Yeah, okay.
Inspired and optimistic.
Okay, maybe last?
Optimistic.
Okay, great. Okay, you go last?
I'll say hopeful.
Yeah, go ahead.
Absolutely not.
Inspired.
Okay, thank you. Ola, we conclude with you?
Encouraged.
Okay, thank you. So there was just one thing, and okay, this is not part of your program. This was not prepared. So it's a bit of improvisation and maybe a bit of teasing, probably for next year. I was saying that music in the brain could be a very nice way to maintain our brain health. And I was just proposed by Janine to pep you up right before we can get onto the bar and get a drink. So Janine has a little gift for all of us. So I'll ask her to come on stage. And so you've got the floor.
But I know something's starting right now. Watch and you'll see. We're going to be a positive brain economy. And thank you for doing your part. Thank you.
Thank you, Janine. And I hope this is recorded because this is going to become our anthem. Okay, so please help yourself and enjoy the evening, continue mingling, and see you tomorrow.